So with all your permission, we are getting started today. So may I have your attention, the esteemed faculties and delegates. I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for the second day of the online event called Gurukul classes, hosted by the Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital, under the aegis of NARCHI Delhi chapter. Well, before we start the session, let's take the holy blessings of the Almighty, followed by the lamp lighting ceremony.
Om Saraswati Namo Namah Ma Saraswati Namo Namah Vidyadayani Namo Namah Hansavahini Namo Namah Om Saraswati Namo Namah Ma Saraswati Namo Namah Vidyadayani Namo Namah Hansavahini
Hello.
Thanks, Dr. Rituparna. Good afternoon, everyone. It's my pleasure and privilege to initiate the second day of Gurukul classes that we've planned for this 3 days event. And I'm sure all the PGs are really benefiting from the scientific deliberations that we have planned for these 3 days. There are case presentations, there are didactic lectures by very senior people, and our PGs are guided by very senior teachers across India. So it's a great opportunity for all our PGs who are learning every day. These 3 days, they will get a didactic lectures, case presentations, then table viva in the form of W pelvis, forceps, X-rays, ECGs, NSTs, everything they will get to know. And of course, there is also a program on OSCE as well. So I hope our students will be benefited. And we have this afternoon none other than teacher of teachers, Dr. Kamal Bakshi, as a chief guest. We all know ma'am as a mother figure in Delhi who has taught almost half of Delhi gynecologist. She's a senior consultant, obstetric and gynecology, Fortis La Femme Hospital, and she has been ex-HOD at All India Institute of Medical Sciences. And she has been in teaching for more than 50 to 55 years. She is the first Indian obs and gynecologist to develop the standardized in utero fetal skin biopsy technique, fetal diagnosis and in utero blood transfusion, uterine balloon therapy in patients with AUB. Her pursuit for newness in obstetrics and gynecology in terms of quality care and ethics is never ending. Her other achievements have been in the field of gynecological endocrinology, especially in PCOS, hyperandrogenism, plastic reconstructive surgery of the vagina, microsurgery, infertility, adolescent gynecology, gynec oncology, and high-risk pregnancy. She has more than 250 publications to her credit, and of course, she has taught so many obstetrician and gynecologists across India and across world. Ma'am, we are really blessed to have you with us this afternoon in this, our teaching program, which I'm sure will be beneficial to our PG students. Over to you, madam, for pearls of wisdom. Ma'am, you have to unmute yourself, madam.
Dear Dr. Mala, Dr. Gujral, and Dr. Mansukh Sukhani, every member of the Sir Gangaram Hospital, I congratulate all of you And today I feel humbled as well as honored to be a part of the Gurukul. A Gurukul has been there for ages, and it is an excellent. And I would congratulate, Sir Gangaram being the pioneer as far as research is concerned. Now, what is very important, you young students, when I was at your age, the most important thing is, which you have already learned, an excellent history taking, examination, as the patient walks into your clinic, what is her gait? Is she looking pale? What is her expression? And then when you examine her, and then in that cases, 70% of the diagnosis is made. So after your first class, you already have come at least the 40% you have reached as far as the goal is concerned. But what is very important, as we have got two hands, we have got different communities of the student to reach as far as the standards, which Dr. Shrestha Ghai was as far as London and America is concerned. So you belong to that lovely institute and you're attending their Gurukul classes. So what is important is discipline. Most important, hard work, desire, keenness to learn, ethical, to love your patient. As a patient walks in, quite often, the first thing she does is she puts the ultrasound in front of you. But you have to say, my dear colleague, that as far as I'm concerned, that I would love to talk to you. What is your history? And then what is as far as family, drug, in a very systematic way. And I'm really honored the way Dr. Mala and Dr. Gujral, who have been great teachers, how they have planned systematically. And even not only that, they have kept the specimens. It's very important when you take out a uterus, how does it look? And as you're examining a human being, what are its appendages like? What is its inner surface? So you are examining itself, Then as far as the dummies, the pelvis, the holistic is there. And not only that, they have kept asking. I wish that I was also in these Guru classes, and I'm honored I have joined the Guru classes because I will update myself with the great Gurus. And who are the Gurus? You young dynamic. They say, na, jo bacha hota hai, jo student hai, they are our leaders because you have been learning from in utero. And now you have reached that age, and I am outdated. So, dear Dr. Mala, I'm so happy you have kept such lovely topics. Fetal growth restriction. Now, is it because was the patient herself a fetal growth? Is it a hereditary? Or is it because of the genetic? Or is it because of the blood supply, blood pressure, or various other things? Uterovaginal prolapse, again, very important, Then hypertensive disorder. Is she having hypertension before the pregnancy? Abnormal uterine bleeding. I would say each topic by itself is worth $1 million, is being taken so beautifully. So I congratulate you, Dr. Mala, Dr. Mansukhani, Dr. Gujral, for giving their student such a big, wide, holistic, and in a single day. Thank you for inviting me and to be a part of your lovely Gurukul. Namaskar to each one of you.
Thanks, ma'am, for all your blessings. All your blessings, ma'am. We are so lucky to have presence of teachers with us this afternoon. And I'm sure all our students are also blessed with your presence. Our guest of honor, none other than Dr. Rajendra Singh Pardesi. Sir has been the president of AMOGS. He is a very senior gynecologist from Maharashtra, was faculty in FIGO, Kuala Lumpur, Malaysia, faculty in FIGO, Rome, was chairperson of Food and Drugs Committee of FOXY and awarded Hansotia Best Committee Award. Sir was vice president of FOXY, vice president of AMOGS, with so many papers in national international journals, with best paper awardee in FOXY AICOG conferences, was faculty in ECOG, TAIPAI, and ECOG 2013. Sir, we are really blessed to have you this afternoon with us as a very senior person and guest of honor. Over to you, sir.
Thank you, Dr. Mala, for kind introduction. Good morning, everybody. Respected Chief Guest, Dr. Kamal Bakshi ma'am, mentor of mentors, our past president, Foxy, I think in 1995. We still remember her tenure. It was very successful tenure of Dr. Kamal Bakshi ma'am. Various programs. I was in the started practice after 7-8 years of practice. So we attended many programs. Feeling proud and honored to be a part of this Gurukul classes program with Dr. Kamal Bakshi ma'am. First, I wish to congratulate Dr. Mala Srivastava, Dr. Chandra Man Sukhani, and Dr. Gujral, and all others also, Dr. Ila, Dr. Abha Singh, for organizing these Gurukul classes. It's really useful in day-to-day practice, not only for PGs, but practicing obstetrician also. As Dr. Kamal Bakshi told, topics covered are practically important for women's health and also to reduce maternal mortality rate. Dr. Mala Srivastava is hardcore teacher and obstetrician. I wish every success to Dr. Mala Srivastava. We need leaders like Dr. Mala Srivastava in Foxy. I wish every success to her for her future endeavor in Foxy. In these forthcoming elections, she is contesting for chairperson of Gynaecology Committee Foxy. I don't want to be in between you and scientific content. Thank you. Thank you so much for inviting me. Thank you.
Thanks, sir, for your kind words and your best wishes and blessings. And we are very happy to have a senior people like Madam Dr. Kamal Bakshi and you with us this afternoon. We quickly go to the scientific session. I introduce my Master of Ceremony, none other than young, dynamic, enthusiastic, and energetic Dr. Ila Sharma, who is the consultant at Institute of Obs and Gynae with special interest in endoscopy. Over to you, Dr. Ila, for conducting the scientific session henceforth.
Thank you, Dr. Mala. A very good afternoon to all of you and a warm welcome on this Gurukul program, where we have the opportunity to directly learn from our gurus. We start with our case presentation. First case on fetal growth restriction. I invite my moderators, Dr. Kamal Gujral, who is an advisor in the Institute. Yes. Advisor at the Institute of Obstetrics and Gynaecology, Sir Ganga Hospital, and Vice President NARCHI and President of Fetal Medicine, Delhi chapter. And Dr. Abha Singh, who is the Emeritus Consultant at Lady Hardinge Medical College in the Department of Obstetrics and Gynaecology, New Delhi. Over to you, ma'am.
Oh, actually, and I'm not at Lady Hardinge. I am I am superannuated from there, and I'm working at ESI Medical College, Faridabad.
Ma'am is also the Vice President of Foxy.
Yeah, elect.
Sorry,
ma'am. No problem. Thank you so much for inviting.
So, who are the case presenters? Kindly introduce yourself. The two case presenters, please introduce yourself and start with the case. Good morning, Abha. How are you?
Yeah, I'm okay, fine. I just had a minor problem. So if I'm not on video, don't mind it.
All right, no problem. Your voice is good enough for us.
Yeah.
Chalo ji, start karo.
Good morning, Dr. Kamal.
Good morning. Good morning. So nice to you. The students, please start.
My name is.
Yes, introduce yourself.
Good morning, ma'am. Ma'am, my name is Dr. Arati. I'm third year DNB resident from Sir Ganga Hospital.
And you. Both of you are from Gangaram Hospital. Smriti, I asked you could introduce yourself. Huh?
Good afternoon, ma'am.
What are my slides you're showing? What is this, Smriti? You are showing some slides. You're supposed to show your case. What are you presenting? You are showing some presentation. Show your case. Get on with your case.
As the slides are getting ready, I would say we wish all the best to our dear Mala. She's such a hardworking, and we wish her all the best, you know.
Thanks, madam, for your blessings and good wishes, madam. Your blessings mean so much for us.
They are loading the slides. I'll loading the slides.
Just a minute.
Case will be presented by Dr. Arati and who are PGs in our department.
Third year PGs.
Third year
Switch off.
Third year PG.
Voice both correct. Are you ready, girls?
Ma'am, just give us 2 minutes, ma'am.
Step in ready, beta. Fatapat karo, you'll waste time.
So Mala has done a very good job of starting this Gurukul, and I hope the PGs have benefited and will again be benefited these 2 days of this deliberation.
3 days.
3 days, total 3 days.
You see, Abha, we've been having Gurukul for a very, very, very long time.
2008,
Physical, yeah. We used to have physical and now it has switched on to Zoom, you know. But I still prefer the physical, you know. The companies used to make the students stay. We used to have 100, 120 students, made arrangements for them to stay in Delhi for 3 days. So those were better days than this.
And then we had a lot of interaction, physical interaction.
Yes, physical interaction. I think next year
next time we will do
that
physical.
yeah. We'll resume that.
But Corona times taught us something more.
Yeah.
That we can communicate with each other.
Yeah. But the only thing is the hands-on thing is missing, no? The dummy and all, they always preferred hands-on there, you know.
Hands-on. Yes,
that was missing in this. क्या हो गया भाई?
Smriti and Adi, are you ready? Smriti and Adi, can we start with the presentation? Smriti, everyone is waiting for you all. Yeah, please start.
Start, please.
Ma'am, is our screen visible?
Not at all, not as yet.
Not right now.
Not visible. Yes, now it is visible. Start.
Something is being moved.
Hello?
Yes, now visible. Start.
Hello? Are you visible?
Yeah, visible.
Please start.
Patient is
Hello. Yeah.
Ma'am, patient is she's 21-year-old female. She's a 6th class, a housewife. She stays in Haryana. She's wife of Mr. Y, who's 10th pass. He worked as a laborer. They belong to low socio-economic status according to the Kupuswamy scale. She is G2 P0A1. Her last menstrual cycle is 3rd of December 2023. Her EDD is 10th of 9th 2024. So according to Negli's, she is 28 plus 6 weeks. Her chief complaint was amenorrhea since 7 months. Patient visited to us with her as a treating obstetrician in CHC, told her that the baby is small for gestation, small baby, and referred her to higher center for further management. A patient was a booked case of ANC outside at a local CHC. She was told by her treating obstetrician that her baby was small and referred her to higher center. She was perceiving fetal movements well. There was no other complaints. So, history of present pregnancy. In her first trimester, her pregnancy was a spontaneous conception. She was diagnosed with as a pregnancy after UPT after 3 days of OD. She had an episode of spotting per vagina in second month of her pregnancy. She consulted locally available gynecologist, where ultrasound was done, and it was told that the baby was normal and the treatment was prescribed. There was no history of nausea, vomiting, headache, burning, maturation, increased frequency of maturation, fever with or without rashes, no history of exposure to radiation, illicit drug intake, alcohol, smoking. As per patient, her routine blood tests were done, which was normal. No further scan was done in her first trimester. She was prescribed tablet orally, which we assume to be folic acid. She was given a tablet to insert in her vagina, which could be a progesterone support. In her second trimester, her pregnancy quickening at 5th month of pregnancy. No history of raised BP, epigastric pain, headache, blurring of vision, leg swelling. There was no history of itching over palm and soles at night. No history of leaking, pain in abdomen. No history of burning, maturation. There was a history of one episode of post-coital spotting at 5th month of pregnancy. She visited her local gynecologist where ultrasound was done, and she was told that her baby was normally formed with no internal bleeding on scan. She was also prescribed iron and calcium and TT injection in the same visit. This was the only visit throughout her second trimester. In her third trimester, there was no history of rise in BP, epigastric pain, headache, blurring of vision. There was no history of itching over palm and sole at night, no leaking, pain in abdomen, or burning in maturation. Patient went for routine checkup to her gynecologist where blood test after sugar intake was done, which was normal as per patient. She was also told that her baby was small and she was referred to higher center. Her obstetric history, she's married since 2022. It was a non-consanguineous marriage. She was cohabitating with her husband. Her obstetric score was G2A1. Her first pregnancy was in 2022. It was a spontaneous abortion at 1.5 month of amenorrhea. The DNC was done. Her menstrual history, she attained menarche at 13 years of age. Her cycles were regular for 3 to 4 days after every 28 days. Dysmenorrhea during her 2024. There was no history of diabetes.
The voice is cracked in between.
Allergy or any jaundice.
Yeah.
Her father had hypothyroidism and hypertension. And
नेटवर्क इशू है मैम, इसलिए न्यूज़ साइट वो सबसे लास्ट रूम में बैठे हैं।
इधर लेके आ जाओ,
बोलूं क्या
आप जाओ। Arati, what's wrong with your net?
Hello?
We are hearing you, but the net has gone off on them. Trying to raise for that.
Hello, ma'am.
Now we can hear you.
Hello?
Speak up, speak up.
There was no personal history. She consumed vegetarian diet. She had normal sleep, appetite, bladder habits, no history of drug abuse. Her dietary history by 24-hour recall method. Energy intake was 1540 kilocal per day. Her requirement supposed to be 8 there was 9 kilocal per day. Her protein intake was 35 grams per day and the requirement was 65 grams per day. In the protein,
5 grams. Arati, at critical moment, your voice is not heard.
I know.
इनको यही बुलाने बोल दिया मैंने यही आ रही
Ask him to come here only.
I know.
Arati, without video, if you can speak, just speak up the case.
आप बोलते जाओ आरती. Forget we are hearing you. Forget the slide. Can you hear us? Too bad.
Either they can present from here.
Yeah, call them here in this. Jaldi kar dena.
They
We
can
wait
present
time.
without the video on. They may not show us our faces.
Yeah, even the voice is all right. Jaldi kar do isko. It's already half an hour gone. We seen this history.
Examination.
Yeah.
Examination. सुनाई दे रहा? Patient.
On examination, patient is alert, conscious, and oriented to the time, place, and person. She is thin built and the poorly nourished. Hydration is adequate. Her height is 5 feet, and the pre-pregnancy body weight is 45 kg. And the and square. Currently she is afebrile or the pair of 78 measure on the right arm in the sitting position. Her respiratory rate is 20 per minute regular. They on general physical examination, there is no uterus clubbing.
There is a problem. Let's go there.
On general physical examination, there is no uterus clubbing, cyanosis, pallor, palpable lymph nodes, and fetal edema. On breast and thyroid examination, it is normal. On cardiovascular examination, S1, S2 heart, there is no mouth thrill. On respiratory system examination, the air entry equal on both sides and there is no edit sound. On central nervous examination, it is normal. On per abdominal examination, on inspection, abdomen is lower, abdomen is distant.
One thing, just wait. Whoever is this, it's not Arati. I know your girl has changed. But in antenatal patient, you have to give us a full breast examination. You have to see the patient, the breast, the nipple, and everything, whether they are cracks, fissures, because you have to prepare this patient for lactation also. So you have to examine. You just can't pass off that breast is normal. Then another thing is, in nervous system examination, you can just tell us the gait is normal. Don't start with general that neurological examination is normal. You haven't seen the neurological examination, so don't comment on that just like that. You can just say that her higher functions are normal, her gait is normal, like that. Okay.
So little spine and gait normal. Okay, go on.
Go on, continue. Continue.
Get them here.
On inspection,
Arati, come this side if you are having
come
a
this side. You're wasting time unnecessarily. बुला लो ना यार.
Start with your per abdominal.
मेरे फोन में मेरा फोन लेके जाऊंगा इसको नहीं चाहिए ये नहीं लेके
You all hear us, Arati and whatever. Smriti, can you hear us or no? You can now. So come this side. You think
Yes,
so wasting time unnecessarily, you know. This all has been said by you. Achha, no, not that. जल्दी आ जाओ तुम इतना टाइम वेस्ट कर सुनते क्यों नहीं? Just start from here only. हाँ, why two places? चलो. हाँ, बोलिए. फटाफट, quick now.
On examination, patient is alert, conscious, well oriented to the time, place, and the person.
इसमें बोलो ना यार.
And she is thin built and poorly nourished. Hydration is adequate. Her height is 5 feet. Pre-pregnancy body weight is 45 kg and the current body weight is 50 kg. The pre-pregnancy BMI is 19 kg per meter square. The weight gain is 5 kg. On vital examination, she is afebrile. Pulse rate is 80 per minute, regular, good volume. There is no radial, radiofemoral delay. All peripheral pulse felt equally and bilateral. On blood pressure is 110 by 78. Laser on the right.
PPT is not visible.
I think there's some glitch there. We are getting late. PPT नहीं तो पढ़ डालो.
अभी चलो ऐसे ही चलते हैं.
ऐसे ही चलते हैं. आपने breast का pointed कर दिया और चलिए फटाफट कर दीजिए.
Blood pressure is 110 by 78. Measure on the right arm in sitting position. Respiratory rate is 20 per minute, regular. On general physical examination, there is no icterus, cyanosis, pallor, palpable lymph node, pedal edema. On breast examination, there is no crack in the nipples. And on thyroid gland examination, there is no thyroid gland enlargement. And the spine and the gait is normal. On systemic examination, on cardiovascular examination, S1, S2 heard, there is no murmur, no thrill. On respiratory examination, air entry is equal on both sides. There is no added sound. On central nervous system examination, there is no neurological deficiency. On per abdominal examination, on inspection, abdomen is lower abdomen is distended. All quadrants move equally with respiration. The umbilicus is central and inverted. Stria gravidarum is present. Skin over the abdomen is normal. There is no other scar, sinus, dilated veins. All hernial sites are intact. On per abdominal examination, on palpation, there is no local rise in temperature. Fundal height is 26 weeks of gestation. Symphysis fundal height is 25 centimeter. Abdominal circumference is 95 centimeter. On Leopold's maneuver, on fundal grip, soft, broad, irregular, non-ballotable mass, suggestive of podalic pole. On lateral grip, on the right side, irregular, small knob-like structure, suggestive of fetal limb. On left side, smooth curved part, suggestive of fetal back. On first pelvic rib, hard globular ballotable part, suggestive of cephalic pole. On second pelvic rib, both hands converging, suggestive that the fetus is unengaged. Lichens appear clinically adequate. Uterus is relaxed. There is no tenderness. No obvious hepatosplenomegaly. On auscultation, fetal heart rate is 142 beats per minute, regular, heard in the left spino-umbilical line. So my provisional diagnosis is 21-year-old female, gravida 2, abortion 1 at 28 weeks, 28 plus 6 week period of gestation with a small for dates baby.
Okay. Now you say small for dates. If the uterus is less than period of amenorrhea, what could be your differentials? And what justify your small for dates in this case?
Ma'am, if the uterus is less than the period of gestation, the causes are wrong dates, small for gestational age, transverse lie, and oligohydroamnios, and
deeply engaged.
Deeply engaged.
So why do you think your dating is correct? Sorry?
The height of the something which she has forgotten.
Yeah.
The height
she wrote. She wrote. I think you missed in the slide. What I could understand was that height is small. She's 5 feet, and BMI is also 18 or 19. So it could be a small mother, small baby itself. It's a constitutionally small baby. So if you think a woman who comes to you who is constitutionally small, she does not have any high risk factor as per your history. Now, what would be the first test you'll do? First test now to justify your diagnosis or to put a differential?
Ma'am, the first test I'll do is ultrasound for estimated fetal weight along with blood flow, that is Dopplers.
Which Doppler?
Ma'am, umbilical artery Doppler.
Only umbilical?
No, ma'am. Actually, it is umbilical artery Doppler along with middle cerebral artery and ductus venosus with uterine artery.
What do you have to say? When
You
you
don't
see,
need to know to tell all the Dopplers all together.
that's why, yes, true, absolutely. You only require a uterine artery Doppler and an umbilical artery Doppler. You know? Which one will the first to go? Uterine artery, then the umbilical. Umbilical is the baby and uterine is the circulation for yours, you know, the uteroplacental. So why do you go to MCA so soon?
MCA doesn't have that much value.
Why did you go? Then why did you go? So what formula you use for a fetal weight?
Ma'am, headlocks formula we
Headlocks
use
formula.
for the fetal weight.
Okay. So your first test is ultrasound, which tells you the weight, the blood supply, the uterine and the umbilical, and that's all. Nothing more you'll see in this case.
Ma'am, Liker also.
Liker also. And what else?
Ma'am, we'll see at what percentile the weight falls.
Ma'am, fetal growth का जो
weight देख लिया तो percentile तो calculate हो जाएगा ना?
abdominal circumference and
BPS. Liker आ जाता है उसमें.
You are asking for a suspected small for dates baby. You asked the ultrasonologist, you've done the fetal veil by the head flow formula. You looked at the uterine, you looked at the umbilicus, you looked at the amniotic fluid, right?
Yes,
and what else would you like to tell the ultrasonologist that ये भी देख लो आप?
मैम कोई congenital anomalies तो मतलब fetus में कोई congenital anomaly तो नहीं.
Why do you think a congenital anomaly should be coming now? Or in other words, which anomalies can come for the first time in third trimester? Like your patient, Bull.
Ma'am, skeletal anomalies.
Skeletal dysplasia. Ma'am, some renal anomalies, CNS anomalies, some cardiac anomalies which could not be detected surely in the level 2 scan.
Yeah. See, some anomalies come for the first time in third trimester. You already said skeletal dysplasia, renal, GI, and neurology. So you should actually make an appointment. She has an ultrasound at some remote place, one ultrasound, you know. So it's a good idea when you evaluate the fetus, evaluate for anomalies again. Anything you've forgotten? Abha ji पूछ रहे थे कुछ भूल ही गए. They're only looking at the fetus.
मैम
fetus का head weight भी देख लो, biometry कर लो, placenta देख लो भाई वो भी तो है.
Placenta. She's answered your question. You should see the placenta. What will see in the placenta?
मैम placenta में मैम कि कोई प्लेसेंटोमेगाली या फिर प्लेसेंटा कोई type of placenta circumvallate.
They are so rare. What is the significant? If I take the history of this patient, is there any significant in the history which can lead to a chota baby?
Ma'am, actually, in the second trimester, there is a history of postcoital bleeding.
She has a bleeding in the first trimester as well.
Yes.
So what would you look at the placenta first thing?
Ma'am, कोई collection वगैरह या फिर
collection, yes, but
and placing
localization where the placenta is low lying or not. She's had 2 episodes of spotting, and third trimester they bleed more than what they bleed in the first and second trimester. So it should be a complete ultrasound asking you. Abha ji, you want to add anything here?
Yes, it's okay. Continue.
Fine. So if now you've got this done and I give you the case, you've got a weight at the 8th or 9th centile. You said you'll calculate the weight, the ready-made charts available. You have the weight, Liker is normal. Umbilical artery and uterine artery Dopplers both are at more than 95th centile, right? Does it change your diagnosis?
Yes, ma'am.
What does it make it now?
It is early onset FGR.
It is an early onset FGR. Why do you say so?
Ma'am, because according to the Delphi census, in the early onset FGR, the gestational is less than 32, and the
after ruling out all the anomalies.
And the second criteria, gestational abdominal circumference and the effective fetal weight is less than
10
centile. Along with the umbilical artery में absent and diastolic flow and
uterine artery में more than 90%. That fits into the criteria of early onset FGR.
Early onset FGR starts before 32 weeks of pregnancy. You can have an abnormal uterine flow. Delphi has specified it. The candidates who are listening, please open up your books and read the Delphi. They've already said the thing. So she falls in early onset FGR at 28 weeks and 6 days of pregnancy. Weight at 9th centile, flows altered. Now, what is the next test you will order? She has very simple basic glucose screen and small basic tests. Now what tests you will order?
Ma'am, we do the infection, maternal infection.
What will you ask for?
Ma'am, history of
In FGR baby early onset, what are your investigations besides the routine antenatal investigations?
we have to go by step. We have to rule out maternal cause, fetal cause, placental cause.
Right.
We have to see that maternal, if there is hypertension, is
Correct.
it controlled or not? BP, if
So
diabetes, if it is controlled or not? Any renal, kidney, or autoimmune
correct.
disease?
So no maternal medical
Diabetes, you are
causes.
not going to get a small baby.
Yeah.
Diabetes with
Vasculopathy. Correct.
Yeah,
Absolutely.
vascular.
Yeah.
Then
So
we-
maternal disease you have ruled out.
Mhm.
What is the most likely cause of FGR in your case? You've already said that.
Ma'am, she's already a malnutrition and a history of
short stage.
short stature and a history of
You yourself calculated the diet and told us it's
What
deficient
is
in
the
proteins, deficient in this. So it is a nutritional. Nutrition is very important even in early onset FGR. She's a small mother, all right. She will produce a small baby, but on top of it, nutritional deficiency. She didn't have any pallor. Hemoglobin was all right. Okay. Now, what? So you ruled out any maternal cause in her besides a nutrition deficiency, which we think most likely, or history of bleeding,
Yes.
which 2 small episodes can lead to. There's a 3 or more, but that is it. Now, what test you'll do?
Ma'am, then
Fetus
the fetus will rule out any infection, any fetal anomaly.
Pele infection.
Which
Karishma. What is
infection?
Ma'am, rubella, CMV, malaria,
tuberculosis, toxoplasma, and
right? So the torch group of infections, right? What is the percentage of infections leading to? What is the percentage of infections causing FGR? But in FGR, कितने percent में infections responsible होते हैं?
Ma'am,
5 to 10%. So what will you do?
Ma'am, if there is toxoplasma, something.
Whatever the profile is, what will you order for?
This is microarray for amniocentesis. If we suspect.
मैं अभी talking about infection, तो आपने infection पहले तो mother को लेना है ना?
Ma'am,
What will
first trimester meaning history of fever with rash.
You've already said that everything is okay. You said you'll test for infections. Dr. Abha asked you, you said torch infections. What will you test in torch?
IgM, IgG.
That's what I wanted.
So that
you
is
call
what
it
we are wanting.
that
IgG
you
is
test
important
for
or
the-
IgM is important?
IgM. IgM indicate the acute infection.
So your answer in exemplary maternal serology. Serology it involves IgM, IgG, and you decide, as Dr. Abha said, it's a fresh infection or she's already immune to it. If she's got rubella immune, she'll never have it again. Suppose maternal serology is positive. What will you do next?
And then we have to do amniocentesis PCR, amniotic fluid.
Amniotic fluid PCR. Because amniotic fluid infection does not mean a fetal infection. The X organism आपका है, उसकी serology positive है, then you do the PCR. What else can you think?
Ma'am, any aneuploidy or?
Aneuploidy whenever we are at infections.
Ma'am,
can you see some ultrasound features of infection?
Ma'am, toxo में, CNS में
CMV also calcification. So you can ask your ultrasound to re-look at the calcifications if already not reported, or if the ultrasound is reported, then the infection is the cause. Correct? So we said her torch profile is negative. Now, what is the next test?
Level 2
Level 2 तो हो गया ना? There's no anomaly. You've already said.
Aneuploidy, ma'am.
Is it only aneuploidy you'll check for or something else?
Malformation and fetal aneuploidy.
Malformation हो गया. We are at genetics now. Are you going to ask only for aneuploidy testing, nothing else? Or which is the best test? How do you do that? Microarray of the amniotic fluid. So that looks after all the chromosome deletion, duplication, syndromes, everything like that. Correct? In your case, she says, no, I don't want it. How will you counsel her that you should have it? What are the points that your case should have and a chromosomal analysis check? Right? Your case.
Ma'am, I have to educate my patient the percentage risk that.
What is the percentage of chromosome abnormalities in a structurally normal fetus? 2%. Only 2%.
2%.
Malformed fetuses or soft markers, 30 to 42%. So your case has a normal fetus. So what will you tell her?
Ma'am, I have to also tell her that during 3rd month of a pregnancy, there was a test,
Yes.
dual marker and DNB, which she did not do.
She did not go for either a first semester screen or a quadruple test. So all the more thing that you convince her that you should do it. And though the incidence may be 2 to 5%,
Yes,
right?
ma'am.
So now the chromosomes are normal, infections are not there, baby is small. Dr. Abha, what will you counsel the patient and what will you do now?
Ma'am,
Yeah, it's okay.
to counsel her about her nutrition, diet intake, and then follow up regularly with serial ultrasound.
How will you advise
Diet-
about the nutrition?
That's what exactly I wanted, you know.
She is
We
of
have
a low
already been pointed out,
socioeconomic
yeah, malnourished woman. So what will you do?
Ma'am, I have to counsel her about the number of calories she has to take per day and how she has to divide her meal. The meal should have like it should be rich in vegetable, fruits, dry fruits, and she should take minimum of 5 to 6 meals per day, 3 major and in between snacks.
She
And she
is of
should-
a low
I-
socioeconomic strata. Try to understand. She will not be, her husband is a laborer. She will not be able to afford whatever you are saying. You have to tell her in simple words what she's supposed to take. And she does not know the value of your calorie intake. What will you tell her?
मैम हम उनको वो प्लेट में बताएंगे कि उनकी
प्लेट में छोड़ दीजिए, क्या खाने को बोलेंगे?
मैम जो अभी मतलब जो सीजनल वेजिटेबल वगैरह सीजनल फ्रूट्स हैं उनको लेना चाहिए, हरी पत्तेदार सब्जियां।
No, I don't agree to you. You have to tell me about protein, carbohydrates like this. Not fruit. Fruit doesn't contain anything.
Ma'am, we have to tell her that she should in the morning her diet should be rich in like she should start her morning diet with paneer or मतलब we should give her the diet plan what she should eat exactly in the breakfast, in the lunch and dinner and in between the snacks.
What are the sources of protein? Do you know the sources of protein which you can advise her?
Yes, ma'am.
Yes, ma'am.
Like eggs, paneer, then
Dal,
tofu,
soya
pulses.
So all pulses would be better for her.
Chana, grams, which everybody will be able to take. Either it is soaked and sprouted grams, or you can even tell her to have those Gunawala chana. So that they take it quite nicely. So you can tell her about the low cost things. Then which these village people are taking. So these are all rich sources of protein. So you have to tell her that this thing step by step. These are the proteins which you should be taking.
Yes, ma'am.
Okay.
Now, do you think you'll admit her for observation for something at this point of time or no?
Ma'am, I will admit her for workup.
Workup to kar diya na. For what?
What workup?
Ma'am, the ultrasound for BP monitoring.
No.
Ultrasound you're not doing daily.
What
How frequently?
yeah. What is the commonest cause of early onset FGR in our scenario? Nutrition, you already said. What is the commonest cause? Fetal cause we have ruled out. The maternal cause, what is there?
Ma'am, hypertension.
Hypertension. See, she has had only one checkup in first trimester, one checkup in second trimester. What happens to blood pressure in second trimester?
There is a decline in BP.
Right. So at that particular time, her BP may be just normal. She's a small built lady. Her baseline BP may be 100 by 60. For her, 120/80, 130/80 may be hypertension. So it would not be a bad idea to admit her and monitor her blood pressure. Since she belongs to poor socioeconomic status, she cannot come to you for checkups. She can't do a home BP monitoring. Always think of the commonest causes first. Fetus, you've already said, is normal looking. It's only chota hai, but it's normal looking. So BP is very, very important, And sometimes we've seen this very thin nourished women have renal disease. So no harm to even test for that. It's becoming pretty common. So maternal disease should be seen. Having said that, there's no hypertension. Nutrition has been told to you very nicely. What is your next step in this case with the findings we gave you?
What about urine examination?
Absolutely.
Yes, ma'am. Ma'am, we'll do urine routine microscope to look for proteinuria. because that could also be a silent
Yes, very, very nice. Good point
And
brought up.
microscopic also.
Microscopy. UTIs also lead to, so don't forget the commonest causes. So once you admit her, you monitor her BP, you look at her urine, look at whatever is missing in the thing. If she has a proteinuria and the BP is normal, there may be a kidney disease, unheard of. So these things do come up, right? And now, having no maternal disease, you're monitored, her BP is normal, you're given a good diet counseling, as Dr. Abha has told you. Ab kya karna hai?
Ma'am, we will do her. We will call her twice a week with every 2 to 3 weeks with ultrasound for
2 to 3 weeks
for estimated fetal weight in case if the Doppler is more than 90%.
I have given you a case. I have given you the weight. I have given you the growth. Please tell me a stage-based monitoring. No student can pass the exam without knowing the stage-based monitoring. You may not follow the SMM models, etc., but this is in your textbooks. What is a stage-based monitoring?
Ma'am, in the stage 1, there is a mild placental insufficiency. In this, the umbilical artery Dopplers is more than 95 centile, and there is a MCA Doppler, या फिर जो uterine artery Dopplers is deranged. So we monitor.
So your case belongs to a stage 1, mild placental insufficiency, growth at 9 centile, uterine artery Doppler raised, umbilical artery Doppler raised, and glycogen is normal. MCA we've not seen as yet, but that's okay. So what is the protocol for monitoring a stage 1 FGR, mild placental insufficiency? How often?
Ma'am, in stage 1, we do the
how often you do the surveillance?
We do the Dopplers weekly. We'll do the NST twice weekly.
Once is all.
Once a week, and then the effective fetal weight is twice
3 weeks.
3 weeks.
So stage-based, stage 1 monitoring, very clear. The Dopplers weekly, in between you can't do NST, your call, but Doppler weekly and weight check in 3 weeks time, right? What is a stage 2 FGR?
And
Sorry?
another thing is you can advise her to do daily fetal monitoring, home monitoring also.
Fetal movement count, fetal kick count must be explained to her that they must be 10 to 12. If they are less at any point of time, she should come to the hospital weekly se pehle bhi. So what is a stage 2 monitoring?
Ma'am, stage 2 is severe placental insufficiency, and in this the umbilical artery may absent and diastolic flow.
Right. And what is how often you see an AEDV?
Ma'am, 2 to 3 times per week with Dopplers, NST twice a week, and then fetal weight estimation like 2 weeks. But ma'am,
so what the monitoring is that if possible, absent and diastolic should be admitted and followed 2 to 3 times a week. The monitoring is recommended. Monitoring remains the same, looking at the fetus, looking at the Doppler, looking at the amniotic fluid as well. We come to know. What do you look at the amniotic fluid? What do you see in amniotic fluid?
Ma'am, amniotic fluid, ma'am, oligo.
What do you see in ultrasound?
Largest vertical pocket.
Either a largest vertical pocket or
normal SDP.
SDP and MVP are same, na? What do you do? Felons ne kya kiya tha? Amniotic fluid index, how can you forget that? AFI. And when you say the book. So in a stage 2, with a severe placental insufficiency, absent and diastolic is the feature, monitoring 2 to 3 times. What is stage 3?
Stage 3, ma'am, there is a fetal deterioration or mild acidosis, in which there is reversal of end diastolic flow. In this, we will again admit the patient.
There's the advanced, but acidosis is very less. Acidosis is not there. So
mild acidosis.
Mild.
Ma'am, we will admit the patient again. We will give steroid cover, and every alternate day we will do Doppler monitoring.
So what you want to say, once the flow becomes reverse, you will do an order, increase the frequency. And stage 4?
Stage 4 severe fetal acidosis, wherein there is changes in the ductus.
More advanced changes are there. You may need to deliver. So now, based on this, what is the timing of delivery for stage 1, stage 2, stage 3, and stage 4?
Ma'am, in this stage 1, if the effective fetal weight is lie between the 3rd and the 9th.
Stage 1 doesn't come between 30. Don't confuse.
37 weeks.
37 weeks. You take the pregnancy till 37 weeks and deliver. And what is the recommendation for delivery at stage 2, absent and diastolic?
33 to 34 weeks.
34 weeks. And what is at reverse?
30 से 32.
Depending on NARCHI. And what is the stage 4?
More than
Any time because the fetus is deteriorating. Now, when you do all these tests, right? What is the feature? Can you tell us that how sequence-wise how the changes occur? How the changes occur of deterioration sequence-wise. Stages have been told to you how to manage. But what is the sequence of changes?
Ma'am, in the early onset FGR, if there is a decrease in the uterine,
What is the first step, first ultrasonic feature in an early onset FGR deterioration?
Ma'am, decrease in the
right.
Ma'am, first the decrease in the umbilical venous.
No.
Right.
Liver से क्या आप क्या?
Ma'am, abdominal
The
circumference.
first change is abdominal circumference.
Then ma'am फिर उसके बाद ma'am umbilical artery में increase resistance. And then फिर umbilical artery में increase resistance के बाद MCA dilated. And then
why the MCA dilates?
Because
is it bad or good?
Ma'am, it is
good for the fetus because there is an auto-regulation.
Yeah. So brain sparing, the fetus brain gets the blood. Then what happens?
Then there is a decrease in the fetal movements. And then after that, the umbilical artery में absent end-diastolic flow. And then उसके बाद ma'am oligo.
Doctors में change
messed it up.
Ma'am पहले oligo पहले AFI decrease होगा. Then उसके बाद umbilical artery में absent end-diastolic.
फिर reverse होता है.
And then फिर उसके बाद reverse फिर MCA में increase flow. And then फिर मैम जो ductus venosus में change and then उसके बाद BPS में changes and the NST में changes and then उसके बाद मैम fetal acidosis.
So what you have to remember is that first is abdominal circumference, then is the umbilical artery Doppler, then the MCA dilated. Because more blood has gone to the brain, less is going to go to the kidneys. So there'll be oligoamnios, then advanced by absent end-diastolic, then reversed. There may be change in the movements or something variation in the NST. Then the ductus changes, decrease forward flow, and then the reverse. And then the cardiac, the heart of the baby gets affected, you get your NST changes. So remember, once the NST is bad, truly bad, it's a last stage. And the BPS and NST last. So Doppler is the mainstay for management, right? Well, suppose this patient appears at the 8th centile. Yeah, dhyan se sunna. Had normal umbilical Doppler. What will you do?
Ma'am, the
umbilical uterine are normal. So what is it? It's most likely a constitutively small baby. So how do you monitor? Is there any recommendation? How often you see this baby?
Ma'am, हम उसका BPS Doppler करेंगे every 2 weeks पे and CTG 1 per week पे करेंगे and effective fetal rate 2 to 3 weeks पे.
That means it can be like a normal pregnancy 2 weekly assessment. And if the weight is less than third centile, but the Dopplers are normal, do you take it as FGR?
Yes, ma'am.
Yes, ma'am.
It is a solitary criteria in Delphi for FGR. This baby needs a weekly monitor.
Yes,
that's right. Normal Dopplers, but growth at third centile.
Yes,
right? So now, once you've decided to deliver, Dr. Abha asked her how will they deliver the baby? Because they all like to do cesareans.
Cerebral-placental ratio. What is the role
CPR,
of
yeah, bolo.
CPR?
They don't.
Ma'am, CPR in the late onset FGR.
Yeah,
What
you're
is the
asking.
role?
Cerebral plus. What happens when MCA gets dilated? She's asking you. So what happens? What is a cerebro-placental ratio? CPR.
There's a formula, middle cerebral artery PI divided by uterine artery PI.
Umbilical.
Once it becomes less than 1, that means the brain sparing effect has started. There is a decrease in resistance in the cerebral vessel wherein the blood flow increased to the brain and decreased to the less vital organ.
CPR is an adaptive sign and later can become. Right? Where does it has relevance more?
Ma'am, in late onset FGR.
What is a late onset FGR?
Ma'am, hello? Ma'am, disconnect.
Yes, go on speaking.
आपको सुन रहे हैं. I'm asking them what is a late onset FGR, how it is different from an early onset FGR.
Late onset FGR is that starts after 32 weeks of gestation. After ruling out all the anomalies in the fetus, we see estimated fetal weight or AC less than third centile. Sole alone criteria.
Don't describe Delphi. We just said pathophysiology of late onset FGR.
Ma'am, in late onset FGR, we will find that the umbilical artery blood flow will be normal.
Maybe normal.
Maybe normal. So the next step is to see the blood flow of the MCA. We'll see that even with umbilical artery being normal, there is still MCA dilatation.
That's what you're asking, so the cerebral placental ratio gets affected.
Yes.
There's a central adaptation, that's a systemic adaptation.
Yes,
वो बच्चा धीरे 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 मरता है, ये एकदम से death हो सकती है. How much hypertension is there in both?
Ma'am, early onset में तो like 60-70% are
इसमें about 10%. Okay. Now mode of delivery, because she's signing off that 5 minutes रह गए. What's mode of delivery and what will you do? How will you deliver these women?
Ma'am, mode of the delivery should always be normal delivery after ruling out all, if there is no indication for cesareans. First mode of delivery should always be normal, but we have to be very vigilant when we induce this patient for monitoring the FHR, because there is a risk of fetal distress whenever we induce them. But if the patient is far remote from term, and whenever there is reversal or the Dopplers, there is severely decreased blood flow, fetal is acidemic, with poor Bishop, we can directly take the patient for cesarean.
You should have a low threshold for cesarean section, but it's not that you can't deliver them normally. What mode of monitoring will you do during labor?
Ma'am, we will do NST with
NST to antenatal होता है. What monitoring will you do for this?
In labor.
Labor चल रहा है भैया.
Intermittent fetal heart auscultation.
There should be a continuous fetal monitoring. That's very
do
clear.
continuous.
This is one case for continuous fetal monitoring, low threshold for cesarean section. Whenever you have the category 1, 2, 3 of the monitoring, you take them up for cesarean. Is there anything you'll do at birth?
हम fetal acidosis को rule out करने के
Yes.
pH check करेंगे.
Acid based status the fetus, umbilical cord should be done so that litigation later. So anything else, Dr. Abha, you ask them, they're done cesarean?
It's okay.
Dr. Abha?
Only
Or bolo, what are the risks the baby can have? All right.
Ma'am, baby can have hypoglycemia. After birth, there is acidosis. Then
hypothermia, hypobilirubinemia.
पूरे hypo बोल दो.
हाँ, सही कह रहे हो.
Hypokalemia, hypocalcemia. And ma'am, if the
See, they'll start with poor Abgar, NICU transfer, NICU stay, prolonged stay, respiratory distress. Steroid, you said, no, you'll give it less than
34 weeks में हम steroid देंगे.
And what about something else?
Ma'am, umbilical artery में या फिर reverse flow.
Whenever you decide to deliver, na baat khatam ho gaya. You decide
baby
to
is less than 32 weeks, then we will also give MGSO for neuroprotection.
For neuroprotection, magnesium sulfate for less than 32 weeks, you can give them. So, what are the long-term risks of this baby?
Ma'am, long-term, the baby may be suffering from the congenital conjunctive impairment हो सकता है, या फिर type 2 diabetes or metabolic syndrome.
The small babies can have the metabolic syndrome and neurodevelopmental issue throughout their life. They are compromised. How many minutes you have? Is there? We have 5 minutes. Is the audience wants to ask any question, or they're not allowed to ask? Organizers.
They can take questions. We just have 3 more minutes left.
तो chat box में दे दीजिए question. और Dr. Abha, you want to say something? Chat box से पहले.
नहीं, chat box हो जाना चाहिए पहले. अगर कुछ खास है तो.
देखिए chat box में क्या.
Ma'am, right now there are no questions.
कब तक आप देना चाहोगे जिस अच्छा डेक्सा देंगे या बीटामेथासोन देंगे? Which steroid?
Ma'am, Dexa.
Then up to how many weeks you like to give dexamethasone?
Ma'am, less than 34 weeks.
अब तो कुछ आ गया है ना, 39 weeks तक भी आप दे सकते हैं.
There are for and against data. The RCOG says for elective cesarean you give up before 39 weeks. There's a lot of data that DEXA causes neurodevelopmental issue, brain development, cognitive performance, school performance. So there are ifs and buts. For them, I think 34 weeks they should say like that.
34, okay. 34.
Yeah, for them they should say it's controversy mein na pade to acha. Yeah. What else? Anything else we missed out?
Now we have one question. Does chronic abruptio oligosequence cause early or late FGR?
Chronic abruptio, yes.
वो डिपेंड करता है कि कौन से ट्राइमेस्टर में हुआ. अगर फर्स्ट ट्राइमेस्टर में ही रेट्रोप्लासेंटल कलेक्शन ये सब स्टार्टिंग से दिखने लगे तो फिर वो अर्ली ऑनसेट में जाएगा. अगर थर्ड ट्राइमेस्टर में पेशेंट ब्लीडिंग के साथ आ रही है रेट्रोप्लासेंटल कलेक्शन then late on. Hoga.
Yeah, because if it starts early, then only the FGR needs time to develop. Doesn't matter that one episode of bleeding has developed. So chronic abruption early, less than 30, 32 weeks will cause. After 34 weeks, perhaps, babies already developed normally, may not even get FGR. What else?
Yeah, and amount of
Yes, amount
hemorrhage.
of bleeding. Amount of bleeding. What else? Any other question?
Any
No,
other
I
question in
think
the chat box?
no, ma'am, no questions. I think we'll wind up
So,
this session.
Yeah, I think
thank
so.
you. The postgraduates
Thank
have
you
done a
so
good
much,
job.
Dr. Abha and Dr. Gujral.
Thank you
And
so
thank
much.
you, Dr. Mala, Dr. Gujral, and Dr. Chandra for inviting me, and Dr. Kanwal Gujral for co-chairing the session, moderating the session with
It's
me.
always nice to have you because the basics they forget. I mean, in their exams, they may not even be asked the stages I've asked. I had to complete.
Oh,
But they may even get
first basics,
just at
first
nutrition.
basics.
Yeah, they were. Remember,
Few minutes.
when a case comes, you may just get stuck at nutrition. All this we had to ask because we wanted to complete the case. Examiner may not even go beyond nutrition, honestly.
Ma'am, if we have 1 minute, can we take one question?
One more question. What is that, quick?
If patient has apical and diastolic flow at 28 weeks, can we continue till 32 weeks?
Yes. Yes. Can I answer? Shall I answer this question?
Acha, you did
Absent
not tell
and
us any
diastolic, you can
medication.
continue till 34 weeks with a thrice weekly monitoring. And the last stage would be a ductus change. You can wait up till reversal of ductus. You should read those. कौन सा trial था? A truffle trial, you should read it up. Go home, read the truffle trial, read the grid trial. Time didn't tell us to teach you. Truffle trial, they continued at early ductus, late ductus with a safety net of CCTG in between. And their inference was that if you continue till late ductus and the gestation age is more, they have a better survival, neurological free survival than if you do an early intervention. Of course, with the late intervention, that going up till late ductus changes, you may have some stillbirths. That is it. That's what you must think, that stillbirth vis-a-vis long-term cervical. So you should have a safety net for looking at this baby with a CCTG. That was a truffle trial. You can wait till 34 weeks with your monitoring. Ductus is the last change you should wait. Is that clear?
Yeah, thank you so much, ma'am.
Thank you so much, everybody.
Okay, now we start with the second case, which is on UV prolapse. I would like to call upon my moderators, Dr. Geeta Mediratta, who is the chairperson in the Department of Obstetrics and Gynaecology, Sir Ganga Hospital. I think ma'am is busy in OT. She'll join shortly. Dr. Jayasree Sundar, who's director of Obstetrics and Gynaecology at Madhukar Rainbow Hospital, and Dr. Karishma Thariani, who's a young dynamic senior urogynecologist at Sitaram Bhartiya Hospital and Sama Hospital. Over to you, ma'am.
Hi.
Ma'am, should I introduce the speakers?
Yeah.
Ma'am, can you hear me?
Yes, I can.
Yeah. Yeah, ma'am.
Is
Case will be
Karishma
presented
here?
by Dr. Nikita and Dr. Nikhil. Dr. Karishma will be joining in few minutes. Ma'am, we'll start.
Yeah, please.
Yeah. So case will be presented by Dr. Nikita, who's a third year PG, and Dr. Nikhil. Please start with your presentation. Yeah, Nikhil and Nikita, please start with your case presentation.
Start. Good afternoon, ma'am. So, Mrs. X, 55 years old lady, wife of Mr. Y, resident of Delhi, belonging to lower socioeconomic status, farmer by occupation, para 5 L5, postmenopausal lady, came to the OPD with complaint of mass per vaginum since 1.5 years. She complained of mass per vaginum since 1.5 years, which was gradually progressive in size. Mass increased on cuffing, straining, and lifting heavy weight. The mass reduced spontaneously on lying down. It was associated with heaviness, dragging sensation, feeling of pressure, and difficulty in walking. Patient also gave a history of manual reposition of the mass while passing urine, along with a poor stream of micturition. There was no history of increased frequency, urgency, incomplete voiding of urine, burning, micturition, nocturia. There was no history of involuntary leakage of urine on cuffing, laughing, and straining. No history of chronic constipation, painful defecation, or manual repositioning of the mass while passing stool. No history of backache, no history of dyspareunia or postcoital bleeding or ulceration or discharge per vagina. She attained her menarche at the age of 13 years and menopause at the age of 50 years. Her previous cycles lasted for 3 to 4 days, came after an interval of 28 to 30 days, was regular, flow was normal, used 2 to 3 pads a day, and there was no history of any dysmenorrhea. She was married at the age of 19 years. It was a non-consanguineous marriage, and she had of her first childbirth at the age of 20 years. She is para 5 L5, always spontaneous conception and a full-term normal vaginal delivery. There was no antepartum, intrapartum, and postpartum complication reported in all 5 pregnancies. There was no history of any premature bearing down, prolonged labor, obstructed labor, instrumental delivery, or no history of big size baby. There was no history of any perineal tear. Patient resumed work approximately 20 days of each delivery. Patient is sexually active. Past history, there is no history of chronic cough, asthma, cold, chronic constipation, any previous pelvic surgery, neurological or connective tissue disorder, no history of chronic medical illness like diabetes, hypertension, tuberculosis. Family history, there's no history of prolapse or hernia in any family members or any connective tissue disorder or cancer in the family. She consumes mixed diet, appetite is normal, sleep-wake pattern was normal. There was no history of smoking or any other addiction. Bowel habits were normal.
On general physical examination, patient was conscious, alert, oriented to time, place, and person. She's averagely built and nourished with a height of 156 centimeter, weight 75 milligram, making her BMI 30.8 kg per meter square. There is no pallor, icterus, cyanosis, clumping, or lymphadenopathy. Oral hygiene was normal. Thyroid and bilateral breasts were normal. Gait and spine were normal as well. On vital examination, her pulse rate was 74 per minute, regular with good volume. BP was 114 by 80 mmHg in right hand in sitting position. Respiratory rate was 16 per minute. Temperature was 97.3 Fahrenheit. On systemic examination, cardiovascular system was normal with normal S1, S2 and no murmur. Respiratory system examination showed normal vesicular breath sounds. Bilateral air entry was equal, no added sounds heard. On CNS examination, no focal neurological deficit was seen. On per abdominal examination, on inspection, this patient is obese, umbilicus in midline, all quadrants move equally with respiration. There is no swelling, scars, sinuses, dilated veins, hernial orifices found intact. On palpation, no local rise of temperature. It is soft, no guarding tenderness, rigidity seen, no palpable mass or no organomegaly. On local examination, external urethral meatus appears normal with normal external genitalia appears atrophic with sparse pubic hair. There is a third degree uterovaginal descent seen with cervix as a leading point. Vagina is pale with low strigosities, no keratinization, no decubitus ulcer is seen. On pus speculum examination, pus speculation was done with patient in dorsal lithotomy position with full bladder. Anterior compartment was examined, and a bulge of anterior wall was noted with absent vaginal rugosities, and a central sulci was also noted. On a apical compartment examination, entire cervix was visualized outside the introitus, suggestive of apical compartment prolapse. No congestion, hypertrophy, or decubitus ulcer was noted. Similarly, on posterior compartment examination, a bulge was noted in upper part and lower part of posterior vaginal wall. On rectal and rectovaginal examination, rectocele was present. On pelvic floor muscle assessment, the strength of the muscle was 3/5 by modified Oxford score. On bimanual examination, uterus was retroverted, atrophic, bilateral phonesis was free and non-tender, and on bulbocavernous reflex was normally elicited, as well as anal wing reflex. So this is the POPQ classification based on the examination. AA point was lying at +3, BA was on +5, C was on +6, genital hiatus was 5, perineal body 2 centimeters, TBL was 8 centimeter. AP point was lying at +2, BP was at +2, and D was at -2. So the provisional diagnosis is a 55-year-old postmenopausal lady, para 5, live 5, with POPQ stage 3 with leading point cervix, without SUI, without decubitus ulcer, with modified Oxford scale of 3/5.
Ma'am, can you hear us?
Yeah. So, very well presented. Has Karishma has also joined or not?
Ma'am, I'm here.
Dr. Karishma has joined, ma'am.
I'm here, ma'am.
Yeah. Hi, Karishma. So, so what will be your line of management and what are the investigations will you offer?
Sorry, ma'am, please, can you repeat it?
What is your line of, what will be your plan of management for this lady?
Ma'am, she is a 55-year-old and she has completed her family. So we will give, and it is a stage 3 prolapse on POPQ. So we will offer surgical management with a vaginal hysterectomy with anterior and posterior repair.
Okay. So what will be your line of investigation for this girl?
We'll order routine investigations like CBC, urine RM, urine culture, thyroid profile, blood sugars, and uroflowmetry and an ultrasound pelvis.
Okay. Right. Why do you want a uroflowmetry?
Ma'am, she gives history of manual reposition while passing of urine and poor stream of micturition, ma'am. Poor stream while micturition. So we'll do a uroflowmetry.
Okay. So uroflow, will you not do her? So what are the complaints she has? She has hesitancy. She has a difficulty in voiding. She has to push it back. That is because of the
Prolapse.
position, right? So how
Yes,
will uroflowmetry help us? Will that be your first line of investigation for her? Are you going to change the
No,
management?
ma'am. First we'll order an ultrasound pelvis and ultrasound for post-vital residual urine, ma'am.
Okay. Okay. And will you not order a urine routine and culture?
Yes, ma'am.
Because
Yes, ma'am. We'll order urine RM and culture.
So first thing for a urinary symptom should be her urine routine and culture, and then ultrasound to check for the residual urine. Is she holding back any urine or not, right?
Yes, ma'am.
So uroflowmetry should not be your first line of answer for such a patient, because we are not going to do, though is very important, because many times we'll discuss that. I think Karishma, can you ask them anything when you are the person who has been doing this subject much better? So what would Karishma like?
I would like to go back to the, I want you to go back to the POPQ, please.
Yes, ma'am.
Yeah.
So her cervix was coming till +6 and D point was at -2.
Yes, ma'am.
Did she have cervical elongation?
Cervical. Yes, ma'am. She
Yes,
has
ma'am.
cervical elongation as well.
You're sure now? Because otherwise this POPQ cannot be correct.
Yes,
Yes,
ma'am.
ma'am,
She
she
had
has.
cervical elongation.
Okay, so she had cervical elongation.
Yes, ma'am.
And what was the total cervical length in that case? Did you take that?
No, I did not take this total cervical length.
You said you will be operating on her.
Yes, ma'am.
Okay. Okay, now another thing you said that your patient has come with 2-3 main complaints. Urinary complaints, she has prolapse and she
Yes,
has
ma'am.
stage 3 with elongation. She's a 55-year-old lady and
Yes,
she
ma'am.
has urinary complaints as well. So you said you're going to do a uroflowmetry. And Jayasree ma'am very rightly said it's not the first investigation. Even if you're planning to do a uroflowmetry, how will you do it? Will you do it with the prolapse deposited or with the prolapse out? What are you basically planning to see is what I'm trying to understand.
Ma'am, there's a reduced prolapse.
In reduced prolapse.
Ma'am, in
And
uroflowmetry,
how will you reduce the prolapse?
we'll see that whether she has to strain while passing the urine, ma'am. We'll see the straining, abdominal straining.
Uroflow, you'll see the pattern of the flow.
Yes, ma'am.
So in this case, the first, if we start from the beginning, she has stage 3 prolapse.
Yes, ma'am.
Have you got residual volume? And she has urinary complaints. So the first test would be residual volume assessment.
Yes, ma'am.
Because in a woman who has bladder coming to +5 centimeter outside the hymen, she is bound to have some flow issues and incomplete voiding. Now the dilemma point for us becomes that is the voiding issue because of prolapse or because of a bladder issue, inherent bladder issue? Because if I go ahead, do a surgery tomorrow and my patient is still incompletely voiding, then she is going to ask me कि you said कि ये तो prolapse की वजह से है.
Yes, ma'am.
Yes, ma'am.
So that kind of evaluation, if you need to do it, you first have to do residual volume.
Yes,
After in residual volume, second test is if you're doing a uroflowmetry, it should be done in both, with the prolapse out in a stage 3 prolapse and with the prolapse deposited inside.
Okay, ma'am.
Because you have to tell her what is going to happen after surgery.
Yes, ma'am.
So at your level, at PG level, it is best you don't talk about uroflowmetry as the first investigation. You talk about post-void residue and her other features, like if she's a high diabetic for long time, then in such case, if she's long-standing diabetes, then I'm thinking that a bladder issue can also be there. If she has features of urgency, leakage, and or other such things, then also I can think of an inherent bladder issue and then go about these further testing like uroflowmetry or urodynamics. What is your patient's post-void residue?
80 ml, ma'am. It was 80 ml.
Oh. Okay, and can you just go back to the complaint slide once again? Just a second, please.
Yes.
Main chief complaints where you had. Did you look for occult SUI in examination?
Yes, ma'am.
Was it there?
No, ma'am. There was no SUI.
So there is no other problem. There is no history of constipation, no defecation.
No, ma'am, no problem in defecation as well.
So have you made a list of investigations that you ordered for this patient?
Ma'am, we haven't put in the slide.
Okay. Then what are the investigations like Dr. Jayasree said? What all will you get done for her? Before you counsel her for
Ma'am, we'll order the routine profile like CBC, urine RM, urine culture, HbA1c, RBS, or fasting blood sugar, and an ultrasound pelvis, and an ultrasound for post-viral residual urine.
I would add an ultrasound KUB also out here, because whenever you're doing a surgery for such patient, she's 55, right? As Karishma said, you should look at her KUB also, right? The other thing that uroflowmetry you were talking about, Karishma very rightly said, if you're looking for stress incontinence, occult stress incontinence, and you should be aware that once you correct, because she doesn't have stress incontinence, once you correct the angulation, the angulation that is caused by the prolapse, she might develop a stress incontinence post-surgery, right? So if you are going to speak a word as uroflowmetry, you should have told her that then, as Karishma said, either you don't talk about it or you should do it with the prolapse and after repositing the prolapse. Isn't it, Karishma?
Yeah. Because if she is able to deposit the prolapse and passing urine well and is able to empty her bladder, then probably whatever irritative or obstructive voiding symptoms she is having are because of prolapse. But often women who suffer from prolapse are elderly women. They may also have inherent bladder issues, which are very important to rule out. Otherwise, post-surgery, you will have urinary retention and you'll be wondering what happened. So that is why this methodical examination is very important. Another thing, what all factors led you to decide that the patient requires only surgery? Did you counsel her? Did you speak to her?
Ma'am, we counseled her for the pessary, but she was keen for a surgery only, as she had had difficulty in her personal life, ma'am, and she had difficulty in walking. She was sexually active, so she had difficulty in coitus, ma'am. So she was keen for surgery only.
Okay. So what surgery did you do? What have you planned for her?
Ma'am, vaginal hysterectomy with anterior colporrhaphy and posterior vaginal wall repair, colpoperineorrhaphy, ma'am.
That's all. And she comes back to you in 3 months with wall prolapse then?
Suspension.
Ma'am, wall suspension.
Wall suspension.
With wall suspension.
What are the different types of wall suspension that you know of?
Ma'am, uterosacral suspension, ma'am, sacrospinous fixation, ma'am.
Okay, these are the two that you most commonly do at your institute?
Yes, ma'am.
No, first you have to talk about the preventive things, right? You will be offering her McCall's scaldoplasty first, right? That should be the first line of answer from you guys.
Yes. Have you heard of McCall's scaldoplasty?
Yes, ma'am.
Acha, what is McCall's scaldoplasty?
Ma'am, there's internal McCalls and external McCalls, ma'am. So we take the suture from the uterosacral ligament, then we take from peritoneum, and then the other side peritoneum and the uterosacral ligament, ma'am. And the external McCalls is from the vaginal wall, and then the peritoneum, and then the peritoneum, and then externally we take out from the vaginal wall, ma'am.
So you're not taking the vaginal wall. In the external McCalls, you're not taking uterosacral ligament. You're suspending the wall to the peritoneum.
Uterosacrals also.
Uterosacrals.
So McCall's scaldoplasty is the most basic walled suspension preventive procedure that you are supposed to do in all patients. And it's not excusable that you don't talk about it, or you don't know the steps. So in McCall's culturoplasty, we take the uterosacral Macken-Rod complex. We are not particularly taking the uterosacral ligament. And like you said, there are two. One is external, one is internal. Internal is usually taken if there is an enterocele.
Yes, ma'am.
If there is an enterocele and you're just looking at walled suspension, then the walled suspension is done using the external McCalls. Are there, how does one choose that I want to do only McCalls in this, or do a sacrospinous, or do a uterosacral ligament suspension? Okay, we'll park this question on the side. Okay, we'll just park it for now. You said you will do a vaginal hysterectomy for this patient with AP repair.
Yes, ma'am.
Now, taken up the patient for vaginal hysterectomy. What are the difficulties, Nikhil, right?
Yes, ma'am.
Yeah, Nikhil, what are the difficulties that you're anticipating in this patient? What is unusual in your patient? What was her, you said she has an elongated, she has a C point coming to +6.
Yes, ma'am.
She has an elongated cervix.
You said she has an elongated cervix. So what are the difficulties you're anticipating? Or no difficulties?
Yes.
No difficulties.
No, ma'am, we have to dissect. Rather dissect.
What do you do when you do a vaginal hysterectomy? What is the first step? You're which year PG student? Sorry.
Ma'am, second and third year PG.
Second and third years now. So what is the first step? You've given the incision, then what do you do?
Ma'am, we separate the
pubocervical fascia.
We dissect the vesicovaginal fascia first, separate it, and then push the bladder upwards.
So the bladder is coming down. You will be able to push it. Any difficulty in opening the pouch? POD? Sometimes in an elongated cervix, the pouch may be higher up.
Yes, ma'am.
So there may be difficulty in opening the pouch. That is what you have to be careful about. And especially if the bladder is coming so low down, then the incision where you're giving between the bladder and the cervix, you have to be very careful. Where do we normally give the incision?
Ma'am, 3 centimeter of the cervicovaginal junction.
So your cervix ka lip is at +6 and your bladder is coming till +5. Where will you go +3 centimeters?
Ma'am, we'll identify the bladder sulcus and then we'll give the incision.
Yes. Yes. You will look at where the givosities are ending and give the incision. So in such a case, the difficulties will be you may have difficulty in dissecting the bladder because there is very little distance between the bladder and the cervical lip. The cystocele is huge. Second difficulty can be in opening the pouch because the pouch is much higher up where you will be anticipating it to. So you know the other steps?
Yes, ma'am.
Jayasree ma'am.
So the next thing that you should be aware when you have an elongated cervix is in the first clamp, you might not reach up to the Macken-Rod's ligament, right? So you should be able to identify your Macken-Rod's ligament well, right? So many times I have seen when you have a very elongated cervix, the first clamp that you put might not be the Macken-Rod's ligament and you might be holding it as the Macken-Rod's ligament. So you should be able to identify, as she rightly said, you have to put in a metal catheter, push and see where your bladder is. You cannot have a number for identifying the cervicovagina where you're going to cut. You should be able to identify the plane, put in a metal catheter, see where it is extending, and then hold the bladder in your hand and put your first incision. And obviously, as you rightly said, you separate the bladder from the center, and there are two ways of doing it. Some people separate the complete bladder at one go, separate it totally. Some people just push it up and later do the dissection from the vaginal wall later. So it's a choice that people make between the two steps, right? Then you continue the incision backwards. And as she rightly pointed out, your pouch might be much deeper. You put in your finger and you might not be able to reach till the fundus because you have an elongated cervix, right? So you have to go step by step. The most important is the vagina has to be completely separated circumferentially, because if you don't do that, then when you're holding, it might be a tough thing, right? You might not be separating out the bladder well. So the circumferentially, the vagina has to be separated out well, right? So if your plane is correct, you don't bleed. If your plane is not correct, you will bleed a lot. And the most important is you should use moist gauze, and you should have a good team to work on it, right? And you have to be gentle with the tissues, because you said her sulci are absent. So she is very postmenopausal, right? So the tissues might not give away very easily. So you have to be very gentle with your tissues, right? So plane of dissection is the most important thing when you're doing a vaginal hysterectomy. So hysterectomy is not the main surgery, as Karishma rightly pointed out. Hysterectomy we are doing to facilitate our surgery because it's low down. She has completed the family. You don't need to retain the uterus and put it back in position, right? If it was somebody who was wanting babies, your approach to that patient would be different from what you are approaching now, right? So hysterectomy, many people say when you do the hysterectomy, you have completed that surgery, which is not true. So you should also identify your pedicles well. So the clamp I have already seen is, if you put McEnroe's, you put a curved clamp on your round ligaments or the pedicles on the top, you should put a straight clamp so that you know where to take your McCalls. So many times it is very confusing when you have multiple instruments lying there. So everybody should be aligned to that approach of work. Okay. Go on. Anything else that you guys would like to mention about this patient and post-op? Anything else, Karishma, you would like to say? And McCalls you take once you are about to do the peritoneum, right? So anything else, Karishma, you need to add?
Yes, ma'am. Now let us come to the vault suspension procedures. How will you decide whether your patient requires one? You've done a McCall. Now, how will we know is McCall sufficient for her or not? So in this case, you look at a patient profile. There are certain patients who may be at higher risk of having prolapse than others. What are those high risk factors?
Obesity, she's belonging to a lower socioeconomic status and is a farmer by occupation. So she will resume her work immediately. Then she's also belonging to a lower socioeconomic status. So her post-operative care would not be so good. Nutrition status would not be so good. So there is increased chances of vault prolapse.
Parity, age of menopause, the time of presentation of prolapse, on early onset prolapse. So if you feel your patient, we have a lot of risk predictors these days. If you look at, if you Google online predictors for recurrent prolapse, then there are different algorithms which come up. You can follow any one of the algorithms. There is one by ACOG, which I commonly follow in my practice. You can either look at the chances of recurrent prolapse in this patient, either then decide whether you want another suspension procedure or not. Or if you have removed the uterus and brought the vault down, if the vault is coming beyond +1, after removing the uterus, the vaginal vault is still coming, then it is good to do an additional suspensory procedure in the same sitting, so as to reduce the recurrence of prolapse. Because A, now women are more aware, B, women are living longer. So if she's only 55, she has another at least 35 years of her life to look ahead at. Secondly, did you assess her pelvic floor muscles in examination?
Yes, ma'am. Modified Oxford score was 3 by 5.
3 by 5, ma'am.
Her muscles are not bad. Another thing that you should do is that in the pre-op or in the post-op period, teach her how to do the exercises.
Yes.
All these things further help in reducing the chances of recurrent prolapse.
So I think, as Karishma said, the most important thing is, if you have done your apex and it is coming down up to the level of intravitus, then definitely a suspensory procedure should be done along with the repaired. So this should be an answer that you should have at your tips, as Karishma said.
So which of the two procedures have you seen? Uterosacral ligament suspension or sacrospinous suspension? Which of the two you see more commonly?
Uterosacral.
That's great. So can any one of you describe the procedure to me? At which level from the uterosacral ligament do your mentors take the bite, or you take the bite if you do it? Is there someone else also there? Okay, so do we use this? Do we use the uterosacral ligament below the ischial spine or above the ischial spine at the ischial spine?
Above ischial spine.
You've seen that?
They've seen, but don't.
Usually in high uterosacral ligament suspension, you may go up to the ischial spine or a little above, but in no other cases vaginally do we go above that level, because it is very difficult to locate the uterosacral ligaments till that extent, even till the ischial spine. What is the most common complication associated with this? What is lying next to the uterosacral ligament?
Ureter.
Ureter. What is the incidence of ureteric injury with a uterosacral ligament suspension procedure? It's as high as 11%. So that is why it is a procedure which has a slightly steeper learning curve if you're if you're a beginner. What are the advantages of a sacrospinous ligament fixation?
Ureteric injury chances would be less.
Yeah, good answer. So, what injury chances are higher?
Ma'am, pin structures would be damaged. Pudendal nerves and vessels, ma'am.
Yes. So where exactly do we take the bite on the sacrospinous ligament?
Coccygeus.
Ischial spine से कितना दूर लेते हैं bite?
2 fingers.
Because just below the ischial spine are your pudendal nerves and vessels. You keep a distance of 2 finger breadths or 1.5 to 2 centimeters from the ischial spine medially and then take the bite on the ligament. Sacrospinous ligament is basically a structure which is joined with the coccygeus muscle. So it is sacrospinous coccygeus ligament complex. You don't take a bite from the coccygeus muscle, you take a bite from the ligament complex. So for the beginners, it is a much simpler surgery to learn. And it has lesser complication rates as we've discussed. But obviously, approachability is an issue because reaching up till the ligament in that narrow space is something that you need to, which comes with practice. But out of the two, uterosacral and sacrospinous ligament suspension, efficacy wise, as the evidence shows, both have equal efficacy. But the learning curve is much simpler for sacrospinous ligament fixation. So at your stage, what you should know is the steps of vaginal hysterectomy. You should know all about vault suspension procedures, different types, and you have to know the advantages and disadvantages of each. What is the current status of vaginal mesh? She has such a huge cystocele. What is the recurrence rate of cystocele?
(15 to 20%, ma'am.
20 to 30% in most studies, even higher. So is there any role of vaginal mesh?
Ma'am, in MASH, risk of infection would be more.
Suppose, okay.
Dr. Karishma, can you hear us? Dr. Karishma? Dr. Jayasree?
Yeah, I'm here. So mesh surgery is not a very recommended surgery. Patient should be informed about the complications of mesh surgery, because it's a total mesh surgery and sometimes very messy. So that's not a recommendation, right? So I don't think that should be your first answer, and mesh surgery is not a recommendation at all. There is an incidence of cystocele, as you rightly pointed out. I didn't remember the exact number. You guys are giving exams. You should be remembering it better. So mesh surgery, you can mention to say that it is not a recommendation and not being used, because many of the meshes have been banned except for a very few, right? So mesh surgery to be mentioned, not to be used, right? So as she pointed out, the most important thing when you talk to this patient is about the risk of recurrence. So when you're consenting this patient, so consent is very important. I would like to talk about consent for this patient. So one is explaining the procedure. We have discussed the procedure. Number two is telling her the pros and cons of surgery and the recovery. Right? I always say when you consent a patient, first talk to her about the procedure, what to expect during the procedure, because many times they are caught clueless in the procedure. You just tell them you're doing the procedure. They don't sometimes even know that they may have stitches in their vagina. They think everything is going to be. So explaining the procedure in layman terms, documents. So I will talk about the medico-legal aspect of doing any surgery, right? So you will have to tell them about the stitches involved, how long you are going to keep the catheter in. That's also important. Some people prefer to keep it for 48 hours because you put a lot of sutures on the bladder fascia to push it up, because she has a very big cystocele. And then you have to talk to her about how IV antibiotics will be continued, how long she will be on her, she will be allowed to eat, whether you're going to do it under regional anesthesia or in a general anesthesia. And so it's very important to tell the duration of catheter in a routine case. And obviously, once you have told her these procedures, you should also tell her about the complications of the procedure. So one is telling her the routine complications. Number two is telling her about the expected rare complications. So always I say that if you're doing the surgeries regularly, you should be able to tell her about what is the incidence worldwide. And if you have done it for a while, you can tell her that as of now, we have not seen it in the past 2 years that we have been doing the surgery, right? So bladder injury should be mentioned to her, bladder repair. And then if that involves a bladder repair, how long the catheter can be kept in situ, what is the post-operative pain management that you're going to give her, and whether any bowel softness will be given to her post-surgery, and how long the IV antibiotic. So every procedure, and it should be documented in your consent. Consent should be ideally signed by the consultant in charge of the case, right? And there should be written in the notes that she has been told options. So the first thing you have to tell is you have told her about the options that are available other than the surgery that you're doing, and what are the risks and benefits, and what is the future follow-up, and what is the recurrence rate of the procedure, because wall prolapse is a known complication, right? So wall prolapse is something you should be talking about to the patient before you do any surgery. And as Dr. Karishma was saying, you should talk to her about the pelvic floor exercises, how it needs to be done, so that, and pelvic floor exercises done correctly in a cycle of 8, right? 8 times, 3 times a day, something of that sort. So all that should be mentioned to her very clearly, so that she knows what to expect post the surgery. I think you guys have told adequately about the suspension procedures. Then obviously the posterior wall repair is also very important. So if there's an enterocele, if you do a high McCall's, you usually correct an enterocele by doing a McCall's procedure. But separation of the bladder and completing the rectocele repair is very important. Surgically, when we are doing, the very important thing is to identify the levators when you are putting the stitches on the levator. So how do you identify the levators when you're taking the levator bites? Do you have a clue about that? So because the levators are a bit deep seated, so when you pull on the levators, you can see the
lifting of
so you should be able to identify your levators correctly because it's very deep seated, right? You cannot just take a superficial bite on the levator. You should repair the pararectal fascia also the way we repair. Many times the tissue is very fragile there, and by the time you come there, many people are bored to complete the posterior part of the repair, right? So that should also be correctly done, and levator stitches should be taken independently, at least 2 or 3 on the levator, and they should be tied together. I think that completes our procedure. Anything you guys would like? So this is about a 55-year-old, right? So if the same prolapse you see in a woman who wants further pregnancy, what will be your line of management for her?
We can offer, if she wants a surgical correction, we can offer her a Manchester repair or Fothergill's repair.
Surgical. So also you should, when you do a Fothergill repair, then having babies in the future might be a challenge. So you should be ideally offering her a hystropexy. The sling procedures are the hystropexy procedures, not a Fothergill's repair, right? If she's completed families, Fothergill's might be an option. Not completed family, we have better procedures. Procedures should be offered to her, right? I think we have summed it up well. Is there anybody else? Where is Karishma? I think Karishma back.
Dr. Karishma has left because I cannot see her on the screen. Any questions from the audience? You can please drop your questions in the chat box.
The two things, Beta, you presented your cases very well. My suggestion for you is when you're offering investigation to a patient or you are telling to the examiner, you should know why you are offering that investigation, right? You cannot just offer an investigation just because you have read the investigation, right? So the uroflowmetry should not be your first line. I mean, I would give a very negative marking for offering that. So whenever I say, what is your plan of management? Then you will say that I have explained the procedure to her. I will write down these investigations. I might want to do some specialized investigations if her bladder symptoms are worsening and I want to take a call before we do the surgery, in which I can include uroflowmetry. That should be the second line. I will also do an ultrasound KUB, and then the plan of management after discussing other options will be surgery for her. So the answer should come that way. Instead of directly you jumped, what will be your plan of management? You said what my vaginal hysterectomy with pelvic floor repair. I mean, that is the summation, right? So management means what you investigate, what you have offered her, and what you are going to do for her. This is how it should be. Any other questions?
No, ma'am, there are no questions. You want to ask any question, Nikhil and Nikita?
No.
I think you have understood your POPQ very well. So I think that's the tough one to understand. So this chart should always be in your mind and you should be able to draw it well, right? Because the classification has changed totally. Okay?
Yes, ma'am. Thank you, ma'am.
Thank you.
Okay, thank you so much, ma'am.
Thank you so much.
Thank you, Nikhil and Nikita. And thank you, Dr. Ma'am and Dr. Karishma, ma'am.
Oh, thanks.
Such a wonderful and interactive case
Thanks.
presentation.
Thank you.
Okay, we go to our next case presentation. It is on hypertensive disorders in pregnancy. I would like to call upon my moderators, Dr. A.T. Radhika. A very good afternoon to you, ma'am. She's a senior consultant in obstetrics and gynae at UCMS and GTB Hospital. Dr. Shashilata Kabra, who's a senior specialist in the Department of Obstetrics and Gynae at DDU Hospital. And Dr. Sunita Lamba, I think ma'am has still not joined. She's director and head in the Department of Obstetrics and Gynae at Mata Chanan Devi Hospital.
So thank you, Ila. Thank you for...
Over to you, ma'am. I'll just introduce the speakers, ma'am. Hypertensive disorders in pregnancy will be presented by Dr. Khadija and Dr. Arati. Start with your presentation.
Good afternoon, everyone.
Start हुआ? Yeah, please start.
Good afternoon, ma'am. I'm myself, Dr. Arati, third year DNB PG from Ganga.
And myself, ma'am, Dr. Khadija.
Ma'am, our case presentation is hypertension in pregnancy. So, ma'am, is our screen visible, ma'am?
Yes, yes, yes.
Ma'am, my patient is Mrs. X. She is 32-year-old female, a wife of Mr. Y, who's 35-year-old, resident of Mayur Vihar, New Delhi. She is homemaker by occupation, educated till class 12. Her husband is Mr. Y, who is 37-year-old, teacher by profession, belonging to upper middle socioeconomic class by modified Kupuswamy scale. She is a G2 A1. Her LMP is 2111. 2023. According to Nikhil's formula, her EDD, her POG is 32 weeks of gestation, and her expected date of delivery is 28/8/2024. So my patient's chief complaint is that she presented to my OPD with 8 months of amenorrhea for a routine ANC checkup, where on measuring her blood pressure, it reported to be a 150/94 mmHg. She came.
Arati, may I just interrupt?
Yes, ma'am.
Yeah, so can we just go back to the previous slide? The reason for interrupting in the middle of your presentation is because you, if you were to say my patient, my OPD, nothing belongs to you and me.
Yes, ma'am.
Isn't it?
Yes,
so
ma'am.
would you like to now say that again? Miss X presented with the chief complaints
of 8 months of amenorrhea, came to routine ANC visit where her blood pressure was high, 150/94 mmHg.
That's all. And is she booked? What she?
Ma'am, she is the booked case.
Can we go back to the previous slide again? So we can't see. We can't see her previous antenatal booking in your hospital or in any other hospital.
Ma'am, actually,
so at the time when you introduce the patient, it is important to say whether she was booked or not booked, or whether she was registered. I think connectivity is an issue here. Arati and
Okay, there's a slight problem with the connectivity. Just a second. Hello. Present karo.
Oh, वहाँ पे आ गए?
Hello.
Hello.
What were her earlier BP records? You have not mentioned in the slide.
Hello.
Yes, so I think it is important for you to introduce as booked, unbooked, or registered, number 1, and number 2, nothing belongs to us. हम तो बोलते जा रहे हैं.
Dr. Radhika is audible.
Hello.
Yes, now you are audible. Yes, carry on.
Ma'am, sorry, ma'am, there was some problem with the connectivity.
No problem.
Ma'am, can we, our system is starting, ma'am. Can we meanwhile present it verbally? Like.
No, but did you understand what I am trying to convey?
Yes, ma'am.
You can go on reading whatever you want, but the point is, here
Yes,
we are
ma'am.
together today to discuss
Yes,
out the various aspects of your presentation.
Yes, ma'am.
Yeah, so it is important for you to, at the time of introduction, introducing the patient, it's important for you to also tell us whether she is booked or registered, number 1. Number 2, we will desist from saying my patient, my OPD. Nothing is mine.
Yes, ma'am. Okay, ma'am. Ma'am, so we have to mention booked or unbooked in patient particular.
Your voice is not okay. Can't understand what you're saying.
Ma'am, we have to mention about patient booked or unbooked case in patient particular.
Yeah, whether she was booked in the antenatal.
In the beginning, in the introduction, you have to mention this.
Okay, ma'am. Hello?
Yes.
Yes, ma'am. Can we start? So, ma'am, she came to OPD for routine antenatal checkup, wherein her blood pressure was taken and it was reported to be 150/94 mmHg.
So that was at 32 weeks. What were her BP readings earlier?
Ma'am, throughout the pregnancy, whenever she came, when we measured her BP, it was always normal. Suddenly,
So
and
that is the reason why it is important for you at the time of introducing the patient.
Yes, ma'am.
To say that she was booked, because now you are aware that her earlier BP recordings were normal.
Yes, ma'am.
Isn't it?
Yes, ma'am.
Yeah. So then carry on with the presentation.
History of present pregnancy.
Are you not able to share the slides on screen?
Ma'am, 1 minute. नीचे slides नहीं दिख रही है.
You go to share option. It is a Zoom platform. That's very easy. You go to share option. And then click slideshow.
Ma'am, दिख रहा है अभी?
Yeah, it is visible now. Yeah.
Yes, ma'am.
You can make it slideshow. You can make it slideshow.
Ma'am, in the first trimester, it was a
perfect.
Spontaneous conception. UPT was done at home when patient had 15 days.
Arati.
Yes,
No,
ma'am.
Please go back to the previous slide. So the next one, this was the chief complaints. There is no chief complaint at all. The lady did not have any chief. See, you have titled the slide as chief complaints.
Yes, ma'am.
There were no chief complaints at all. It was an incidental finding at the time. But along with this, don't you want to highlight a few things more in your presentation? Negative or positive, whatever.
Ma'am, we have highlighted here.
Please understand your presentation is going to be marked. In the exam, this is just a rehearsal for you. So,
yes, ma'am.
If you're serious about this presentation, please do it properly. This is not okay. So, इसके साथ कुछ और बोलना चाह रहे हो, हाँ या ना?
मैम हाँ, बट हमने वो नेक्स्ट स्लाइड बढ़ा दी, चीफ कंप्लेंट में नहीं डाली.
आप कहीं पे भी डालो जो एक at the time of your presentation, what is right is what matters, isn't it? What is coherent or what is in continuation with what you're speaking. You put it in whichever that is, you decided to do that. But would you like to, with this slide here in place, would you like to now tell us, there are no chief complaints. This lady had no complaints at all.
No, ma'am.
She had come to the routine antenatal visit and was found to have high raised BP.
Yes, ma'am.
आगे बताओ इसके साथ क्या बताना चाह रहे हो?
Ma'am, on further questioning, there was no history of headache, blurring of vision, epigastric pain, bleeding per vaginum, leaking, pain in abdomen, or increased urinary frequency.
Why do you talk about increased urinary frequency?
Ma'am, we just ask all patients during
You can ask anything under the sun. Dr. Arati, I am asking you with this.
No, ma'am, it is not relevant to this case.
हम आपसे वही कह रहे हैं जो relevant है इस चीज के साथ आप इसीलिए please take your presentation seriously.
Yes,
है ना?
आप अपने केस से related important चीजें बताइए, positive and negative history.
Ma'am, there was no history of headache, blurring of vision, and no history of bleeding or leaking per vaginum. She was perceiving fetal movement adequately.
तो उसके साथ कुछ और, there are few more things which you have to speak. You know, history of chest pain is important, history of nausea important, history of vomiting important.
History of upper
that you have to also, you are discussing a case of gestational hypertension.
Yeah.
Yes. Yes.
And blurring of vision and headache are very important signs. They are the main harbinger of onset of eclampsia. So what is gestational hypertension?
Ma'am, gestational hypertension is when the systolic blood pressure is more or equal to 140 mmHg or diastolic BP is more or equal to 90 mmHg after 20 weeks of gestation without proteinuria.
Without proteinuria,
it has to be measured 4 hours apart. You have to check it double.
Two occasions,
that is very important.
And ma'am, BP resolved 12 week after
So this is
postpartum.
a case of gestational hypertension or chronic hypertension?
No, I think Shashi, let us first listen to the history, then we can go on to the discussion also. Okay? So Arati, आगे बताओ. Why did you skip that?
Ma'am, actually, I already told her. Ma'am, patient came to antenatal
Okay. Okay, next slide, please.
Spontaneous in her first trimester, the pregnancy was spontaneously conceived. UPT was done at home when patient had 15 days overdue, and her UPT was positive. She visited to SGRH at 2 months of amenorrhea, where her all the antenatal investigation was advised, which was normal as per patient. Her ultrasound for dating scan was done, which was normal. She had regular intake of tablets.
Normal? Ultrasound for dating scan was normal?
Ma'am, the cardiac activity reported normal as per patient.
She went for dating scan and the cardiac activity is normal. नहीं समझ आया.
Ma'am, नहीं, ma'am, she
Her
said
objective was to date the pregnancy.
Yes,
It was
ma'am.
not to confirm whether the baby is alive.
No, ma'am, she said दिल की धड़कन आई थी, इतना बताया था.
नहीं, but then you don't say dating scan, na? She went for
It is
an
just an
ultrasound.
obstetric scan.
Yeah, she just went for an ultrasound and she was told that the baby is alive. That's all.
Okay, ma'am.
Dating तो हुआ ही नहीं उसमें फिर.
Okay, ma'am. Then her NT-NB scan was done, which was normal as per patient. Dual marker was done, which was normal. There was no history of nausea, vomiting, fever
No,
with
how do
rash.
you know dual marker? Excuse me, Arati.
Yes, ma'am.
See, please don't go, like as if it's from the books.
Yes,
How did
ma'am.
you elicit the history of dual markers from this lady?
Ma'am, actually, when patient come to our OPD, we tell them this word verbally, कि NT-NB कराना है, dual marker कराना है. So they are quite aware of these words. So whenever we ask them, they reciprocate like, हाँ NT-NB किया है, dual marker किया है.
नहीं, but NT-NB अलग चीज हो गई, dual marker अलग चीज हो गया.
हाँ मैम.
हाँ, तो your patients know what is dual marker?
मैम नहीं,
NT-NB I can
usually
understand ultrasound.
नहीं मैम, मतलब यूजुअली हम पूछते हैं कि NT-NB के साथ एक ब्लड टेस्ट कराया था क्या, तो देन दे से हाँ मतलब
So
like
you
that.
are able to say that because this lady was booked in your institution.
Yes,
So
ma'am.
how would you have elicited this history if this lady was not booked in your institution?
मैम आई वुड हैव आस्क्ड कि प्रेगनेंसी के तीसरे महीने में कोई स्कैन हुआ था, उसके साथ इमीडिएटली बाद कोई ब्लड टेस्ट हुआ था क्या?
Okay. So which are the two tests with the dual markers?
Ma'am, we do nuchal translucency and
That is
Beta
not
HCG
part
and
of.
FAB-A, ma'am.
Huh?
Beta HCG and FAB-A.
Okay. Carry on with the history, please.
हो दिया history of radiation exposure. Okay. In second trimester, quickening was felt at 5 months of amenorrhea. She was booked in SGRH and immunized against tetanus. In second, her second ultrasound was done at 5th month, which the baby was grossly normal as per patient. There was history of intake of iron, folic acid, and calcium regularly. Throughout her second trimester, there was no history of rise in BP, epigastric pain, blurring of vision, headache, or decreased urine output. No history of excessive hunger, thirst, frequency of urination, recurrent UTI. Fatigue, easy fatigue, dyspnea on exertion, palpitation, chest pain, syncopal attack, and no history of fever, bleeding, or leaking per vagina.
Why syncopal attack, Arati? Why did you ask for syncopal attack?
Ma'am, sometime, मतलब second trimester में ma'am supine hypertension.
Really? You really think so? Or you just want to speak something?
No, ma'am. We just asked in like सारी history.
I don't think it's a routine for any of us to be asking for syncopal attack.
No, ma'am.
तो इधर ही पूछा है ना तुमने, यही हम जानना चाह रहे हैं. It's arousing my curiosity.
Which is significant usually in case of anemia only or cardiac disease.
Yeah, exactly. If you suspect a cardiac problem. But yeah, what is the next slide, please? Go back to the previous slide. Go back to the previous slide. So, as an obstetrician, these are the only things that you would have done if this lady had come to you. Any other history that you have missed?
Diabetic screening, ma'am.
Other than that, so one is very important that should have been done at the very first visit. Something else that's been missed here by way of history?
Fetal echo.
Fetal echo.
Don't do it.
Not
Again.
very important. Related
You
to
are in
this.
you are in India. What is the basic antenatal service which is to be given to all women? Basic. You might be sitting at a tertiary level, secondary, primary level.
Is there some prophylactic?
Anything which is needed twice.
Ma'am, TT, she was immunized against TT.
Nigda, very good. So today in the class, the basic things, we don't want to, you have to be first understanding the foundation before you go to the higher levels. So is it TT or what is it? What is given now by way of immunization?
Tdap, ma'am.
What is Tdap?
Tetanus, diphtheria, and acellular pertussis, ma'am.
Okay.
Is it given in second trimester?
No, ma'am. It's given in the beginning of third. Ma'am, around 36 weeks.
And TD? What about TD? If
Ma'am,
it was...
वो second trimester में देते हैं, capital T और...
So did she receive any of those? TT or TD?
Ma'am, she received TD.
No, but why is it not figuring in your history? Number 1 and number 2, screening
You
for
should
diabetes.
also mention history of calcium intake. Iron is given, but calcium intake is very important with respect to hypertensive disorder.
Calcium is written
He has
here.
written calcium once daily. It's written there, Shashi.
Chalo, aage badho.
In her third trimester, patient continued perceiving adequate fetal movements. History of regular intake of iron calcium was present. There was no history of leaking, bleeding per vaginum, excessive thirst, hunger, urination, no history of itching over palm and sole. Ultrasound done at 7 months for growth scan, which was normal as said by patient. In her second visit in third trimester at 8th month of amenorrhea, she came to ANC visit for routine antenatal checkup, where her blood pressure was taken and was told by her doctor that
ये तो तुमने already बोल दिया, Arati. Why are you again speaking out the entire thing? This is what she presented with.
Menstrual history, she attained menarche at 14 years of age. Her last menstrual cycle was 21 November 2023, according to which her EDD is 28/8/24. Her period of gestation is 32 weeks. And then her previous cycle were regular, occurring at 28 days of interval, which is lasting for 5 days. Average flow soaking 2 parts per day.
Did you at any point in the antenatal period tell us about her urinary complaints, if at all, if they were there?
Yes, ma'am.
Ma'am,
yes, ma'am. Yes, ma'am. First trimester में भी लिखा है, no, second trimester में भी लिखा है. नहीं, burning.
कहीं नहीं लिखा तुमने, मुझे तो नहीं लग रहा है कि तुमने कहीं लिखा है. Things which are relevant, important in your case, you are not highlighting those.
History of decreased urine output, ma'am.
No, but it could be simple urinary complaint. Why are you assuming just because today you've been asked to talk about hypertensive disorder in pregnancy, which could have a background of the renal problem as a root cause for her high BP?
Yeah.
You see, when a patient comes to you in the clinic or in your exam, they don't come with the diagnosis, na? You are supposed to make the diagnosis.
Yes,
so this history is a direction in establishing a diagnosis.
Yes, ma'am.
So it has to figure in your presentation. वो नहीं है इसमें, दिख रहा है ना? Urinary complaints तुमने लिखा नहीं है.
नहीं, second trimester, ma'am, no history of excessive thirst, hunger, frequency of urination or recurrent UTI.
So is that the way you speak in the history, recurrent UTI?
No, ma'am, we ask करके बार-बार
तो जब तुम्हें पता है वो चीज ऐसा नहीं है तो तुम ऐसे ही प्रेजेंट क्यों कर रही हो? फिर तुम सही चीज करती फिर. हमें रोकने की जरूरत ही नहीं है तुम्हें फिर. चलो आगे बताओ.
Obstetric history, she was married in year 2022. It was a non-consanguineous marriage. She is G2A1. Her one abortion was in year 2022. It was spontaneous. Missed abortion at 7 weeks. It was managed medically. Her present pregnancy is contraception she was using barrier method of contraception on and off. And then past history, ma'am, she's not a case of diabetes, hypertension, heart disease.
Excuse me. So where is the obstetric history? Is this all?
Missed abortion, whether fetal cardiac activity appeared, then disappeared, or there was any bleeding, any history of that? Suggestive of that.
First of all, how was the pregnancy confirmed? Whether at all she was pregnant?
UPT, ma'am, UPT was done.
At what period of gestation?
Ma'am, when she was 15 days overdue. Ma'am, we've
So why
mentioned.
don't you think it is important for you to highlight all that in the first? I am talking about the miscarriage. Please don't go back again and again. When you talk about in this lady who is having a problem, you are expected to describe each and every obstetric event that took place in her life. How was the pregnancy confirmed? Then what happened? Why did she have an ultrasound at 7 weeks? Did she start bleeding? Was she on any medication? What was the reason for this? What is an attributable reason for this miscarriage? If there is none, you have to highlight in your history that there is none. This is a bland statement. हमें तो कुछ इसमें पता ही नहीं चल रहा. ये तो मरीज ने बताया होगा. You as a doctor should have asked her more questions. And what happened in the post-abortal period? Did she use a contraceptive between the two pregnancies or the before the first pregnancy? Nothing. It's grossly inadequate, please. This is not the way obstetric history is to be presented.
Ma'am, we will be careful next time.
चलो आगे जाओ.
No history of diabetes, hypertension, heart disease, SLE, renal disorder, or asthma. No history of tuberculosis in the past. Personal history, she had regular sleep and wake pattern. She's a non-smoker, non-alcoholic. No history of illicit drug abuse. No bowel or bladder complaints. No known allergy. Not on any drug addiction. Family history.
Don't you want to tell us whether she is vegetarian, non-vegetarian, and if there are any? So you also told us about twinning in the family and all that. Family history, traditional obstetric history needs to have a few things spoken. I didn't see that.
In the next slide, I think family history she has written.
History of hypertension and diabetes in mother, controlled on oral medication. There was also history of hypertension in father, which was controlled on medication. There was no congenital anomalies in the family.
What about hypertension in any of her sisters, siblings? Did you ask? How many siblings does she have?
Ma'am, she had two sisters. There was no any history of hypertension in the sisters, so we have not mentioned.
Don't you think it was important for you to
You could have mentioned this, na? That she had these siblings and mother and not having hypertension.
That would have given you so many more marks. Other than the fact that
that is very important in a case of SDP.
Why it is important to have this history of hypertension in siblings and mother?
Yeah.
Because the
that increases the risk of having gestational hypertension and preeclampsia.
How much? By how much, Khadija? If the sister had hypertensive disorder, what is the implication?
Ma'am, she has increased risk of preeclampsia.
How much? Arati?
I'm not sure with the percentage.
You are expected to be sure of this. Hello, आगे जाओ.
She consumed mixed diet. Calorie intake was 2,600 kilocal per day, wherein the protein intake was 60 gram according to 24-hour recall method, which was adequate. Her general physical exam.
So tell me something, especially since now, are you aware that one of the macronutrients is known to be beneficial in preventing preeclampsia, hypertensive disorders in pregnancy?
Calcium.
Calcium.
So is her food, you told us about her dietary pattern. Does she consume milk, curd,
yes,
dairy products?
She was consuming milk twice a day, morning.
Other than the calcium tablets that she was on.
Yes,
how much is the dose as a prophylactic? So it is yet empirical, not proven.
1 to 1.5 gram calcium.
Is a routine requirement in pregnancy. What is it to prevent preeclampsia?
Ma'am, to prevent preeclampsia, it is 1 to 1.5 gram calcium.
Are you sure? Or is it 2 grams?
2 grams.
See, Preeti Handi also says 2 grams.
Yeah, it's 2 grams.
Yes, it is 2 grams.
आज तुम तैयार होके नहीं आए हो दोनों, है ना? Simple questions पूछ रहे हैं. These are very, very basic. This is being spoken since the past 20 years. चलो आगे बताओ. Examination.
Ma'am, on general physical examination, she was sitting comfortably, conscious, cooperative, well oriented to time, place, and person. Average built, she was average built, well nourished. General condition was fair. Height was 155 centimeter. Weight 60 kg. Her pre-pregnancy weight was 50 kg. Which, BMI was 20.8. On had
What is the significance of BMI?
And because obese patient are more risk to have a hypertension and preeclampsia in the pregnancy. Head to toe examination, general condition was fair. Hydration is adequate. Hair showing normal texture. No paler icterus, cyanosis or clubbing. No chlosis or glossitis. No facial puffiness was there. Oral dental hygiene was maintained. No any palpable lymphadenopathy or any thyroid enlargement was there. JVP was not raised, and the breast shows the normal changes of pregnancy and no inverted nipples. On examination, she had a grade 2 pedal edema. Which
so instead of saying no inverted nipples, you can say the nipples were everted.
Normal.
Yeah, normal. Normal changes of breast changes of pregnancy, the nipples are everted. Or
Why
normal.
is pedal edema in red?
Ma'am, that was
Why you have highlighted?
That was the positive finding, that why we just highlighted.
Positive in case of
No,
what?
but
It doesn't happen in normal pregnancies, edema.
What is the incidence of having pedal edema in normal pregnancy?
Sorry, ma'am?
In normal pregnancy, you get pedal edema.
Yes,
what
ma'am.
is the incidence?
Ma'am, 50%.
In 80% cases, you get pedal edema. So it is not a thing which is to be highlighted, not a very important sign of
no guidelines say that pedal edema has to be there in hypertensive disorder.
Yeah, exactly.
It
No,
should
but
not
there
be
is something. There is something more. It's not merely pedal edema. What is it that made you highlight this in red?
Grade 2 pedal edema.
So what is generally the physiological edema like?
Ma'am, physiological edema are generally grade 1 and they relieved after a 12-hour of rest.
Yeah, so here it is beyond that. So why do you call it grade 2? What was it that made you call it grade 2?
Ma'am, it was above the ankle. That why it was the grade 2 pedal edema.
So it was above the ankle and below the knee, was it?
Below the knee.
Okay. So that is why it makes you suspect that there is possibility of it being pathological. Please carry on. आगे बताओ.
Ma'am, vitals were temperature was 98.6, pulse rate 88, regular, good volume with no radial or radiofemoral delay. All the peripheral pulses were palpable. SpO2 was 98% and BP was 150 by 94 in the right arm and 152 by 92 in the left arm in a sitting position, and respiratory rate was 16 per minute, thoracoabdominal. On systemic examination, respiratory system was bilateral air entry present and equal. CVS apex beat in fourth intercostal space in the left anterior axillary line. S1, S2 normal, no murmur here. CNS, no sensory or any motor deficit, all the reflexes were normal. On abdominal examination, on inspection, abdomen is uniformly distended. There was no any abdominal wall edema. Uterine ovoid in longitudinal axis, umbilicus central and everted. Linea nigra and stria gravidarum were present. All quadrants moving equally with respiration. All hernia sites are free on cuffing, and there was no any dilated veins or skull mounts.
All quadrants were moving normally. Respiration, thoracoabdominal respiration. This is why I'm saying don't copy from the books, please. You should write what you see. ऐसा सब करोगे ना फिर ऐसा लगेगा, then people will ask you, have you ever seen the Viva goes in another direction.
On palpation, local temperature was not raised. There was no any organomegaly. Uterus corresponding to 32-week size, relaxed. SFH was 32 centimeter. Uterus was relaxed, non-tender. Fundal grip, soft, broad, irregular, non-palatable, podalic, and was suggestive of, was palpable at fundus, suggestive of buttocks. Left lateral grip, smooth, curved path, suggestive of back. Right lateral grip, soft, knobby path, suggestive of limbs. And first pelvic grip, smooth, hard, globular, palatable
The
path.
significance of SFH in this case?
Because, in this case, the preeclampsia or the hypertension leads to the FGR, fetal growth restriction. So sometimes we get a decreased fundal height.
Yeah, and it is a very good screening method for diagnosing.
First, pelvic grip, smooth, hard, globular, palatable part, suggestive of head. And second, pelvic grip, converging, suggestive of head that is not engaged. Liquor appears clinically adequate. An expected fetal width clinically was 1.8 to 2 kg. Local examination, no bleeding was present. PSP was not done. Our provisional diagnosis was a patient, Mrs. X, 32-year-old female, G2A1 at 32 weeks period of gestation, is a case of hypertensive disorder of pregnancy with a single live fetus in longitudinal lie, encephalic presentation, not in labor.
What are the differential diagnoses you have in mind?
Ma'am, it could be a gestational hypertension. It could be a.
So tell us points in favor and against. No, name. Tell us a differential diagnosis. Points in favor and against.
Ma'am, because it is diagnosed after 20 weeks and the reading was more than 140/90.
So Khadija, we would expect you to then tell us that way. So instead of saying hypertensive disorder of pregnancy, it could have been a gestational hypertension. And the reasons for saying so are these. However, I have the following differential diagnosis in mind. This is like, it's a heading of a chapter, hypertensive disorder of pregnancy. You know? So normally what used to be done a few years back was to test for urinary protein. And if it was there, then it was called as preeclampsia. Otherwise it was, but we don't do that any longer. So you can say gestational. And then I have the following differential diagnosis. You know? So you tell us the justification and the differentials that you have in mind.
But remember one thing, that on a single reading of 150/94, you cannot even call it. In the case of gestation hypertension, also you should have two readings. Right. So you will further wait for 4 hours and you will have another reading.
Ma'am, it was the reading were taken in some interval. It was not like only on one reading we did not admit the patient.
Nowhere in your history did you say that.
Ma'am, patient came in
Nowhere in the history did you say that, Arati?
Your history says only once you measured her BP.
So Khadija, tell us the differences.
What are the indications for admission of hypertension?
Ma'am, for the further evaluation of the that whether it is a gestational or it is a preeclampsia.
Is 150/94 an indication to admit? Or what does the guidelines say?
Ma'am, according to the guidelines, indication for admission is whenever the BP is 160/110. That time we admit, but we can admit if the BP is lower in case if patient is not following up regularly, and we need to work up patient to if she is a poor compliant, and we need to admit and monitor her, and she is not following up.
You mean only at 160/110 BP only you will admit the patient. If patient is having some other sign and symptom of preeclampsia, then you won't admit the patient.
Ma'am, we will admit
with BP by 150/94.
Lower BP plus any of the symptoms. You will admit, or 160/110. You will admit. These are the guidelines. But then, okay, go ahead. So you admitted for?
For ma'am, actually for monitoring her BP and to come up with the diagnosis, and also to do the fetal-maternal surveillance. And ma'am, we want to put her on
like antihypertensive.
So how will you rule out preeclampsia in this case? What are the signs and symptoms that are suggestive that this is a case of preeclampsia?
If she's having any headache or any blurring of vision, and we will send the investigations for the proteinuria. Sign of end organ damage.
Yeah, both sign and symptoms, right? And lab investigations also. Elaborate on all.
Ma'am, we will send CBC with the peripheral smear to look for the hemolysis and the also the platelet count. Then LFTs to look for the bilirubin level if it is more than 1.5. For the serum creatinine level more than 1.
I think it is AST and ALT which are more important than bilirubin.
Twice the normal limit.
Serum creatinine more than 1.1 से ज़्यादा.
No, but did you see Khadija and Arati? Is it bilirubin or is it
systematically?
Only AST, ALT.
अभी डॉक्टर शशि ने आपको एक चीज बताई, आप अपना बोलते जा रहे हो. Please register and say yes, madam, they noted it. Because what you are telling us is not okay.
Yes, ma'am.
है ना? हाँ. तो तुम bilirubin जो बता रहे हो, probably nobody will even talk about it.
Yes, yes.
We don't expect you to say bilirubin at all.
Yes, ma'am.
हाँ, but you are getting corrected, but you are carrying on with your this thing. ऐसे नहीं ना? So Dr. Shashi corrected you and you acknowledge that.
Yes, ma'am.
So when is bilirubin important in case of hypertension? Is it important at all?
No, ma'am. Whenever we suspect
help
in order to
hemolysis.
hemolysis.
What is the condition when hemolysis occurs? Which is the condition?
Ma'am, HELLP
What is it
syndrome.
known as?
HELLP syndrome.
Otherwise, ALT, ALT are important, but in
Yes.
hemolysis, unconjugated bilirubin may increase.
Yes, ma'am.
So systematically, if you want to say, you can say like this, that when our AST and ALT are double the normal, or creatinine 1.2 and above, or there is proteinuria 1+. We say that proteinuria is not important for making a diagnosis of preeclampsia. But if proteinuria 1+ is present, then again it is a case of preeclampsia. But if it is absent, then there are other signs and lab investigations which help you in making a diagnosis of preeclampsia. So this is how you have to say systematically, not haphazardly like this.
And how do you assess proteinuria in a patient?
Ma'am, we send the urine protein ratio, wherein if it is PC ratio, ma'am,
urine protein creatinine ratio, if it is more than 0.3,
you are doing that only.
24-hour protein is more than 300 milligrams.
Dipstick, ma'am, हम dipstick.
What you are doing, you are sending.
मैम एक्चुअली हमारे यहाँ लैब में पीसी रेशो 2 घंटे में आ जाता है, तो हम मोस्टली पीसी रेशो ही भेजते हैं, मतलब दैट कम्स फास्ट एंड.
आपने भी बताया 24 घंटे का यूरिन कलेक्ट करते हो, तो वो भेजते हो आप?
सॉरी मैम,
you just now told you 24 hours urine. Are you sending it?
No, ma'am.
24 hours. Why are you saying it?
We are sending.
You are sending 24 hours urine.
And PC ratio also we are sending.
Okay, if you
but
are
there is one another bedside simpler investigation.
That is a dipstick test we can do if it is more than 1+, then such as
1+ and persistent is the word. 1+ and persistent. It's written in Williams like this only.
So which sample of the urine you should avoid and why?
First morning sample. मैम वो पूरा मतलब उसमें false positive report है because it is collected from the जो ureter and it is not the freshly overnight collected होता है. It is not
So is it not better? In fact, proteinuria in preeclampsia is intermittent. It is not a continuous excreted proteins. So when you undertake a protein assessment of the urine with the overnight stored in the bladder, it is probably more reflective of the presence of protein or the absence of it. That is the whole pathology in this thing, and that is the rationale for taking 24-hour urine. We are not telling you that has been the tradition. Now things are changing slowly because other molecular parameters have come for diagnosis. And all said and done, so 24-hour urine is difficult to collect.
What is the cutoff for PCR, protein creatinine ratio?
More or equal to 0.3.
Okay. And albumin creatinine ratio?
It's 0.8. 8.
Spot urine is more feasible. That is why these days it is done. Otherwise, if 24 hours urinary protein you are doing, then it is very cumbersome and patient has to get admitted. More or less the same results.
But it is not doing the night sample is not a bad idea.
Yeah.
Okay, so it can be done.
Okay.
What other investigations you will order?
No, but other differentials, they have not completed the list.
Okay.
So your further management is going to depend on your differential diagnosis.
One is gestation. Her BP was 140/90, so her first is my gestational hypertension.
Okay.
Then
preeclampsia without severe features.
Non-severe preeclampsia is what you want to say.
Ma'am, the renal disorder, CKD, ma'am. Renal artery stenosis.
We don't understand abbreviations.
Ma'am,
And don't drop a word and expect us to know the entire.
Exactly.
You have to speak out the entire line.
Yes.
We don't understand. What do you mean CKD? What about
Ma'am,
CKD?
renal artery stenosis, ma'am.
Or specific renal artery stenosis. What makes you think that?
How many cases of renal artery stenosis you have seen in a case of SDP? No? Say
That
common
is number
things
one.
first.
That is number one. And that renal artery stenosis develops hypertension at third trimester, 32 weeks.
You know, in your
So
case
based on these
presentation,
differential diagnosis, you are going to investigate her. You think of renal artery, you are going to send her to a place who has no idea about undertaking ultrasound of renal artery in a pregnant lady who is 32 weeks. Talk of the commoner things first.
It could be a ma'am white coat hypertension.
ऐसा लगता है तुम्हें? 4 hours apart white coat ही चलता जा रहा है उसको.
always speak common things first.
We do agree with you regarding the renal cause as a reason for hypertension. But tell us what kind of renal disorder.
Ma'am, pheochromocytosis.
And then renal disorder are more common causes of chronic hypertension rather than gestational hypertension and preeclampsia. You presented this case as a case of gestational hypertension.
That would be your justification for saying why it is gestational hypertension and why you are having fourth differential diagnosis as renal and not the first. If she had been chronic hypertension with superimposed preeclampsia, your first would be renal.
Yes.
That is how you are expected to discuss out the case. I have the following provisional clinical diagnosis. However, I have the following differentials in mind. So this is the one, these are the facts supporting it, these are the points against it. ऐसे होता है ना? अब तो हो गए, हमने डिस्कस कर लिए, आगे बताओ. Investigations, Dr. Arati was answering.
Ma'am, we will do the protein creatinine ratio.
Then protein creatinine ratio.
CBC
How do you plan to investigate this lady?
Ma'am, we'll send a CBC with peripheral smear, then
justify each.
Okay. CBC and peripheral blood smear. What are the important things which are expecting in CBC and what in peripheral smear?
For the hemolysis and for the CBC to look for the platelet count. If it is less than 1 lakh, then it guides us towards the preeclampsia.
Peripheral blood smear में hemolysis में क्या देखोगे?
Ma'am, helmet cells, schistocytes, Burr cells to look for.
There is one biochemical parameter also.
Ma'am,
looking for the signs of hemolysis.
Low.
LDH, ma'am.
Serum LDH advise करोगे patient का, ठीक है? Carry on, next.
Ma'am, OTP, SGOT, SGPT, which is more than twice the upper limit of normal. And then, ma'am,
serum creatinine level.
More than 1.1 से ज़्यादा है या जो baseline है उसे double हो गया.
And urine PC ratio, if it is more than 0.3, then it also guides us towards the preeclampsia.
In case मैम अगर OTPT बहुत मतलब ज़्यादा होगा तो हम PT INR भी करेंगे.
Would you like to get PTNR done even otherwise?
Only in case wherein the OTP, SGOT or GPT is elevated.
Not otherwise.
Or if the platelet count are low, then also we go for the coagulation.
What is low? What is low?
Ma'am, if it is less than 1 lakh platelet counts, then we go for the coagulation profile. PTA.
If the platelets are less than 1 lakh.
1 lakh.
Okay. Any other investigation?
Serum uric acid, which is not done.
So you
now.
want to only look at the
Serum-
mother, you don't want to look at the baby at all.
No, ma'am.
Serum uric acid is not required for managing.
Ultrasound for the fetal growth and.
No, please answer Dr. Shashi's question. You said serum uric acid.
How does it
She
help in
raised the
managing?
query.
It is not helping in gestational hypertension, but in case the chronic hypertension is not diagnosed, then it helps us to differentiate gestational from chronic.
यूरिक एसिड ऐसा है?
ऐसा है?
मैम एरियाज में लिखा था that
chronic तो फिर नहीं, areas is not a standard textbook. First thing, you should read Williams and other national guidelines. And second thing, only by history, whether the hypertension has developed before 20 weeks of pregnancy or after 20 weeks of pregnancy, we can diagnose it as a chronic hypertension and gestational hypertension. Why do we diagnose it with the help of uric acid?
Ma'am, in case if the patient came to us after second trimester, then
would you like to get her fundus done if that was their degree of suspicion?
Ma'am,
list of investigation, fundus was never figured there.
Fundus examination is done in chronic hypertension.
In every
if you don't know
hypertension,
in this, yeah, exactly.
We do every.
Yeah. So instead of uric acid as the answer, it would have been so much better if I said I would like to get a fundoscopy done. So is that all? The list of investigations? अभी भी आप लोगों ने blood sugar की कोई जिक्र नहीं करी.
Ma'am, blood sugar.
Yes. In India, we don't think of blood sugar. We don't think, then who will think in the world? Nowhere in your antenatal presentation you talked about blood sugars. Now you are getting an opportunity to spook out the list of investigations. यहाँ पे भी screen नहीं करना चाह रहा. All this while she should have been at one point screened. That opportunity was missed.
Okay, then why is screening of sugar important in this very particular case?
Ma'am, because if she had chronic diabetes, then vasculopathy.
Chronic diabetes?
What? Chronic diabetes?
What is
Just
it?
simply say diabetes.
Ma'am, hypertension.
Because hypertension is, they're seeing that they are more at risk of developing a diabetes.
What percentage of women with preeclampsia can have diabetes?
20%. 20%.
Is that a guess or you know it?
No, ma'am.
It's much more. 20 to 30, 1/3 of these women could have diabetes.
So why does a woman have preeclampsia when she has diabetes? Why diabetes predisposes to preeclampsia or gestational hypertension?
Ma'am, obesity is the risk factor for both of them. If most of the.
That's one of the added factors. Why? How is diabetes responsible?
Placenta.
What happens?
Ma'am, placenta.
Bigger placenta. The disease of hypertensive disorder is in the placenta. Villi. And the size and number of villi. So they have bigger placenta. So bigger placenta leads to more of preeclampsia. That's why twin pregnancy have more preeclampsia. The volume of placenta is important.
And in the over diabetics, it could be also because of vasculopathy.
Vasculopathy, yes. Somebody wrote it in the chat box rightly.
So complete the list of investigations.
Ma'am, ultrasound for the fetal, we do an ultrasound for the fetal well-being and Doppler.
What is it? You want to call it as an obstetrician gynecologist? You want to say that you want to call that investigation ultrasound? If you are wanting to undertake an ultrasound to check for the fetal well-being.
Fetal growth and Doppler.
Doppler. If everything is fine, you still want to do a Doppler?
No, ma'am.
So Doppler का भी figure ही नहीं कर रहा. I am just asking you to complete the list of investigations. Next, opportunity number 2 to speak properly.
Ma'am, fetal growth assessment, AFI, AFI can be done, and the NST.
What is that test called on ultrasound to look for AFI?
Ultrasound BP.
हाँ, Khadija?
Biophysical score.
कह सकती हो ना तुम? Modified biophysical. Because you said 7 months he already has had an ultrasound. Everything was found to be normal. In your presentation, you said that. So, and clinically, the parameters, the uterine height and the amount of fluid, the volume of this thing, everything seems to be fine. AFI seems to be fine. Amniotic fluid.
Yes, ma'am.
So, you again want to undertake a growth, a biometry and the growth profile and all that?
No,
सब कुछ तो हो चुका है इसको.
हाँ.
So, modified biophysical score and what else? What are the components of biophysical score?
Ma'am, fetal tone, fetal breathing, fetal
Are
movement.
modified biophysical.
NST and AVI.
So don't you want to get her NST done?
Yes, ma'am.
Is it required really?
Ma'am, yes, ma'am.
Why?
Ma'am, for documentation purpose, like we can follow up patient accordingly.
She's a newly diagnosed hypertensive. You would like to be sure that the baby is fine. You don't know which direction she's going to take. She's been just diagnosed. So you're going to do a surveillance both for the mother and the baby to understand to what level the both are affected.
Yes, ma'am.
फिर आगे, what is your final plan? So once you have a plan in mind, then you will be able to tell us what you plan to do for the rest of the time.
Ma'am, we will start anti-hypertensive. We do a BP monitoring, and we will if our BP recordings are consistently more than, we'll start the anti-hypertensive.
More meaning how much?
Ma'am, it is more than 140 or 90 mmHg, then we'll start anti-hypertensive and we'll start with the
You
tablet.
agree with that, Arati?
150 or 90.
नहीं. खदीजा ने अभी ये कहा कि 140-90 से ज्यादा होगा तो हम एंटी हाइपरटेंसिव स्टार्ट करेंगे. And on the second breath, you said it's a non-severe preeclampsia. That was your second provisional diagnosis.
According to the guideline, non-severe preeclampsia.
Guideline की तो छोड़ो. I am asking you as a clinician, do you want to start her on antihypertensives? If yes, why? If no, why?
Ma'am, antihypertensive की जरूरत नहीं होगी if her BP is below 150-90 persistently.
No, if it is 150-90 persistently.
Yes, ma'am.
You want to start?
No, ma'am.
So at what cutoff would you want to start her on antihypertensive treatment?
150-90 के ऊपर.
What is the difference between non-severe preeclampsia and severe preeclampsia? Not in terms of hypertension, but in terms of treatment. In both, you will start medication.
No, ma'am. Preeclampsia without severe feature, we will not start antihypertensive.
This is without severe features only.
हाँ मैम, antihypertensive start करने की जरूरत.
You only said more than 150-90. You want to start her on antihypertensive. Both of you are saying.
No, ma'am, we will start on her on antihypertensive.
You're again coming back to square one. उसी पे तो discussion हो रहा है. Your friend says she doesn't want to start if there are no features of severe preeclampsia. If the severe features are not there. So in non-severe, you want to start her on antihypertensive treatment, Khadija?
Because we have to keep the BP, target BP is 135 to 85, we have to keep the target. So to bring the target, we have to start.
Who says?
Nice guidelines.
Who, see, for a person with gestational hypertension of less than 100 diastolic and less than 150 systolic, where is it written that you need to get the blood pressure down to 130/80?
Ma'am,
where is it proven? Where is the evidence?
So you have to be very clear about gestational hypertension, when to give treatment and when not to. 135/85 is only if you have started with the treatment, say she was 160, 110 and more, And now that target BP on the antihypertensive has to be that. For gestational hypertension, there are clear-cut guidelines.
But ma'am, for preeclampsia without severe features, we will start or we have to start?
Not at 150/90. No, but you were saying something about the NICE guidelines. If there is anything that is there in NICE guidelines, you can tell us.
Ma'am, NICE guideline has proposed to like keep the BP. They have proposed all this, but
Matlab, they says that to start the antihypertensive when the BP is more than 140/90.
Which guideline? Which year is this publication?
Ma'am, अभी एक publish नहीं हुआ, बस proposed.
Nah, the most recent is this year. It has come in March
2023.
You can refer to anything, na? This is the problem. You will give suddenly one reference. So don't, specifically for asking you this question was this only. So please remember, even the examiners and teachers would have come read and come.
Yes, ma'am.
ऐसे ही थोड़ी आके बैठ रहे हैं यहाँ पे. और बताओ, plan क्या है? My question was, what is your aim? What do you aim to do?
Ma'am, first is to establish the exact diagnosis after doing all the investigation, and then see consistently her BP. If her BP repeatedly is less than 150/100, then we can send her home with a follow-up without adding hypertensive. But if BP is more than 150/100, then we have to add hypertensive medication and then see how is her BP going, and then optimize the BP and then discharge.
Sending home is your aim, or managing
So,
the pregnancy?
optimization of blood pressure.
You want to deliver at 34 weeks, 38 weeks,
Ma'am,
39 weeks, 40
ma'am,
weeks,
she is
42 weeks. कुछ तो जवाब होगा तुम्हारा. As an obstetrician, मरीज भी पूछेगा कि डॉक्टर साहब आप क्या करने वाले हैं
We
हमारे
can put
साथ?
it the other way. If her BP is controlled and there is no further complications of preeclampsia, then when will you time the delivery of this patient? That you can.
So you have already admitted this patient. For how long you will keep her admitted? When you will send her home? With what advice? And for how many times in a week BP should be done? You have
How
to
often
create
her
a plan.
investigations will be
Dr.
done?
is asking you, what plan in your mind for this patient? She is admitted with you have done the investigation. Now what?
इतने सारे क्लूज मिल गए. पहले डॉक्टर शशि का जवाब, followed by डॉक्टर सुनीता का जवाब. अब
Ma'am, if
both of them have formulated the plan for you actually.
Ma'am, if it is less than 150/90 and it is and there are no any features of impacting eclampsia or no any lab abnormalities or parameters, then we will monitor the BP and discharge her, and we will look first. We will
With what
ensure.
advice?
First, we'll ensure that she is compliant to come and with the self-home BP monitoring, and she should come back with the BP records in a week.
So if everything remains well, when will you want to terminate the pregnancy?
Ma'am, if everything remains well, then after 37 weeks, we would like to terminate.
At 37 or beyond 37?
At 37.
Beyond 37.
Beyond 37. So beyond 38 also?
No, ma'am, between 37 to 38.
So only the mother you will monitor, nothing about the baby.
No, ma'am, we will ask for the
बार-बार baby को तो you are forgetting that there is a baby also.
Ma'am, for the ultrasound, modified
Ultrasound is the only way of monitoring the baby.
modified
home.
Will
एक
instruct the
तरफ से उसको
patient.
माँ को घर भेज रही हो आप.
Daily fetal movement count.
Daily fetal movement count, weekly NST. Ma'am, every 2 to 3.
Arati, please tell us what do you mean by saying daily fetal movement?
Ma'am, we will ask her to monitor her baby weight. Daily fetal movement count. She has to keep the track of 10 to 12, and whenever it is less, if she feels it less, she has to come and report to the hospital immediately.
फिर आगे anything else?
Ma'am, then weekly NST, ma'am, and then if the baby doesn't have any Doppler change, ma'am, if the baby's weight is within normal
Your
limit.
list is incomplete. Why are you? Don't
Lab
you want
investigations
to tell
is
the
also very
mother?
important.
There are any
Ma'am,
signs of
ma'am, her last lab
difficulty in
investigation will
vision,
be done.
gastric pain or vomiting, or
Blood
if your urinary
investigations.
output is less, or if there is a sudden weight gain, or if you have vomiting, or if there is a
or
reduced
sudden
fetal
respiratory
movement,
distress.
then you please come to the hospital first. Your discharge itself is not okay. I don't think I'll feel confident in asking you to discharge the patient. आप तो बता ही नहीं रहे मरीज को कुछ भी.
मैम once weekly उसका पूरा.
आपको बोल दिया हमने. We have told you the answer. So if her BP was on the higher side, when would you want to terminate the pregnancy?
34, ma'am. 30.
Or you will ask something else also. BP is high. Any other thing you like to ask when you may have to terminate it a little earlier. Or
You have to ask all those things which
for the severe features like headache,
severe preeclampsia you have to rule out.
severe right upper quadrant pain.
So again, you are forgetting the baby. If baby is in distress, you will have to deliver. So it's mother, maternal features, the fetus. So the objectives are control hypertension, do the management, when to deliver, and for the safety of the baby. These are the three things you need to know.
So Ila has posted a question. She would like to know the role of steroids. Nikhil, please mute yourself. Nikhil, mute करो अपने आप को.
Nikhil, please mute yourself. Nikhil, please ask him to mute. Yes, ma'am.
So Ila has a question. Is there a place for steroids?
Yes, ma'am. If the patient comes with a preeclampsia.
No, we are talking about this lady.
Yes, ma'am.
This lady is at 32 weeks and you find that her BP is 150/90. Is there a place for giving her steroids?
Ma'am, we can give her steroids.
You can do anything under the sun. बात उसका नहीं है. क्या चीज सही है ये पूछ रहे हैं. बाहर में कोई किसी को पूछ नहीं रहा है.
Ma'am, at present, if her BP is 150/90 with no sign of impending eclampsia, we will not give her steroid.
So after 3 days, she will have a high rise of BP and will develop sign of preeclampsia.
We should give her steroids.
No, you should give.
Because she can develop preeclampsia.
Because there is always a fear that she can worsen.
Or you can admit her, monitor her BP, see which direction and look for the parameters, biochemical parameters. Everything is in the direction of non-severe, and since she is admitted with you, you can take a little while, 2 or 3 days to understand what this entire thing is about. And then take a decision.
Dexamethasone will you give?
Sorry.
What will you like to give? Beclomethasone or dexamethasone?
Ma'am, we will give dexamethasone 6
Why
milligrams.
beclomethasone?
Ma'am, because in the India, the betamethasone which is available, it has only
isomer. That respective salt is not available in India. So Government of India guidelines says that you use dexamethasone, sodium sulfate.
What is the prescription for dexamethasone?
Ma'am, we give injection dexamethasone 6 milligram intramuscularly 12 hourly for the 4 doses.
So over 48 hours.
40,
so
48.
4 doses are over 48 hours.
So the dose is completed in 36 hours. Because 0 dose, then after 12 hours, after 12 hours, after 12 hours.
Okay, then your patient delivered normally. Now what? How will you follow up this patient? With 150/90, she delivered normally. How will you follow up this patient?
Ma'am, we will monitor her BP. If her BP remains less than 130/80, then we will not start on any antihypertensive.
How frequently the BP is monitored post-delivery in a case of gestational hypertension?
Ma'am, if she's admitted with us, then we can monitor.
She's admitted, she delivered with you.
So, ma'am, twice daily we can monitor her BP, and
then.
And if the BP remains less than 130/80, then we can discharge her, and we can ask her to. We will ask her to monitor the BP monitoring at the home, and whenever the BP readings are more than 140, more than 150/90, then she can. She should visit.
130/80. If she comes, if the BP is more than 130/80, will we start antihypertensive? So there is a cutoff, no, where you have to start antihypertensive in a case of gestational hypertension. I don't know from where you are getting 130, 80, 150, 90. These are your, I don't know from where you are getting these cutoffs. 130, 80 is normal. So what cutoff you will start antihypertensive in a case of gestational hypertension?
Ma'am, in case of gestational hypertension, if the
your patient,
suppose
hypertensive disease.
Suppose your patient's BP has become 160, 110.
Then we will.
How will you manage that hypertensive crisis?
Then ma'am, we will repeat the BP within 15 minutes, and if the BP is still more than 160, 110, then we will start. We will give the IV labetalol injection, 20 milligram over 20 milligram over 2 minutes, and then we will repeat.
What is the strength of a labetalol ampoule? How much volume and what is the?
Ma'am, the ampoule is of 4 ml, and the in 1 ml it is 20 mg.
Okay, then you give labetalol. Then what will you do?
Ma'am, we will after 10 minutes we will again repeat the BP. If the BP is still 160, 110, then we will increase the dose to 40 milligram over 2 minutes, and then we will repeat the BP again in the 10 minutes, and then we will still the BP is high, then we give the 80 milligram. So up to 300 milligram we can give IV. 220 milligram we can give.
220. NRHM guideline says 220, and after that, suppose BP is not controlled, then what will you do?
We can, if still the BP is not controlled, then we can give nifedipine immediate release tablet.
We give either nifedipine or hydralazine, anything is available. And nifedipine immediate release tablet is not available in India, so we give the normal nifedipine, which is intermediate release, which is available in India.
So her BP, review BP was 160, 110 or 160, 100. You have started antihypertensive. Which antihypertensives you will give in lactation?
We will start with the labetalol.
Okay. How much dose? When? Which are not to be given? Okay.
We generally avoid ACE inhibitors and ARBs, angiotensin receptor blockers, and angiotensin converting enzyme inhibitors. We do not give in the pregnancy.
Lactation.
If patient's pulse is 60, less than 60 or equal to 60, so would you like to continue labetalol?
No, ma'am. We will not continue labetalol.
Then what will be your drug of choice?
Then we'll switch off to the nifedipine we can give, ma'am.
Yeah.
I think we have crossed the time. We started early, so we have already completed.
So just one question last. When the patient
is asking one question. Yes, ma'am.
If the patient you have put on antihypertensive post-delivery, what advice you will give to the patient to look for some specific signs in the baby when she should report?
If the baby
in preterm deliveries, preterm babies.
Breathing, if the baby is lethargic,
yeah, cold clapping skin, refusal to feed, or lethargy. Though it's secreted very less in breast milk, but still in preterm babies specifically, all these things can happen. So everything you have to tell to the patient when to come, when to monitor, and how to take care of the baby. Don't forget about baby and mother. Both of them are important for us.
So drug of choice for postpartum hypertension?
Ma'am, it is enalapril. It is given.
Enalapril is ACE inhibitor.
Amlodipine is amlodipine. Then second choice is enalapril.
Why methyl dopa is not given during
because it's postpartum depression.
It is slow release, slow onset of action, postpartum depression.
And when it will settle down, the patient will ask, and when you will call it chronic hypertension if it persists. What is the cutoff?
If it is persisting beyond 12 weeks postpartum, then we will call it as a chronic hypertension. And if it is not persisting, then it is a gestational hypertension.
So long and short-term complications of hypertensive disorder of pregnancy in mother and baby both?
In mother, the patient can have a coronary artery disease, in future. Then metabolic syndrome she can have. She at the risk of the diabetes, at the risk of stroke,
diabetic nephropathy, diabetic neuropathy.
So what advice you will give to the patient to prevent all these things, future complications of
physical activity, diet, exercise,
and well-controlled blood pressure,
and to maintain the normal BMI, weight reduction.
Postpartum contraception, any advice?
Ma'am, we can in the hypertension, the intrauterine copper T, we can give. If there are no any severe features, then we can give
progesterone
only pills.
Progesterone pills.
Yes.
I think time is up, right? Na?
Yeah. Any questions from the audience?
I think
regarding this beclomethasone, we have already said, ma'am. There was one question, ma'am. This.
Yeah.
It's a question. Is beclomethasone available to be given or only dexamethasone is to be given?
Yeah, regarding this maximum dose, IV dose 300 milligram. The ACOG guideline says maximum dose is 300 milligram, but Government of India guideline says 220. So we'll stick to 220 only. And maximum oral dose of labetalol is 2400, which we can use.
Yeah, I think so. I think we can call it a day. Geeta, are you there?
Yeah.
Yeah. So I think today's discussion on hypertensive disorders finishes here.
Thank you, ma'am. It was a
Thank
very
you so much, ma'am.
Thank you.
It was a wonderful session, I think, and they need to work upon their histories, the basic thing.
Yeah. The very fact that they came on the screen and presented is itself a big achievement. It's not easy to face the audience.
Yeah.
So we appreciate
Thank you
that
so much, ma'am.
So many
all the best.
Asking question is not that easy.
Yeah.
If you are calm and keep answering according to what the guidelines are and what you do. Don't give your own cutoff 130, 80.
You read Williams. Williams very nice. There are two very good chapters in Williams.
So the rest of the my team joins me in thanking Mala, Srivastava and the entire team for having us here. So thank you very much.
Thank you so much, ma'am. Now we start with the fourth case presentation, which is on abnormal uterine bleeding by Dr. Preeti and Dr. Smriti. I would like to call my moderators for this case presentation. Dr. Sheila Mene, who is currently DNB faculty at KCG Hospital, Bangalore. A very good afternoon to you, ma'am. Dr.
Good afternoon.
Jain, who's a consultant gynecologist and director of Shubham Care Hospital, Jaipur. A very good afternoon to you, sir. And Dr. Sundar Deswar, who is consultant obstetrician gynecologist, SM Hospital, Patna. Over to you, ma'am and sir.
So can the students introduce themselves and start presenting? Preeti and Smriti, yeah?
Yes, sir.
Smriti Gupta.
Please start with the presentation. Slide show. Start.
Good evening, everyone. Myself, Dr. Preeti, and I have with me Dr. Smriti. We will be presenting a case on abnormal uterine bleeding.
Yes, Smriti can move this side a little bit. We can see only
44
one.
years, wife of
Excuse
Mr.
me,
Y,
can
46
Smriti-
years of age, resident of
Excuse me.
Karol Bagh, Delhi.
Excuse me, Smriti, she's telling madam.
Graduate and housewife, husband, graduate and shopkeeper by profession.
Hello, can you hear
Socioeconomic
us?
status,
Yes,
upper
yes.
middle class on
Can you
modified
hear
People's
us?
Swarmy scale.
Smriti,
They are not. Can you hear us? Can you hear us?
Yes, ma'am. Yes, ma'am. We can hear you.
But the other student is not visible, so I am just asking. sit in such a way that both of you are seen. Okay.
From that side.
And if there is any interruption from our side, if you find, then you have to wait there, pause. Okay. Fine. Okay.
Okay, ma'am.
Start. You can start presenting.
Chief complaints. Heavy patient
Can you
present.
go back? We'll start from the beginning. Excuse me. Go back. Start now.
Mrs. X, 44 years of age, wife of Mr. Y, 46 years of age, resident of Karol Bagh, New Delhi, graduate by education and housewife. Husband is a graduate and shopkeeper by occupation, and he belongs to upper middle class on modified Kupuswami scale. Patient presented with chief complaints of heavy bleeding per vaginum with passage of clots and pain during menses since last 3 years. She has history of heavy menstrual bleeding with passage of clots since last 3 years and was changing 5 to 6 pads per day, completely soaked on the first 3 to 4 days, followed by 2 to 3 pads per day. This affected her routine household work. She also gave a history of pain during menses, which was dull aching, non-radiating, localized to lower abdomen and lower back, and which was relieved on taking medication. Patient was asymptomatic till 2021. She had regular cycles when she started complaints of heavy menstrual bleeding with passage of clots and painful menses, for which she consulted a local gynecologist and was advised hormonal treatment for 3 months, but the symptoms persisted. Hence, she was advised hysteroscopy, DNC, and Mirena insertion, which she has undergone. She had irregular bleeding per vaginum even after Mirena insertion till 2023. Her symptoms were not relieved completely. She expelled Mirena spontaneously in December 2023, following which she again complained of heavy menstrual bleeding with clots and pain abdomen. On asking, she had a histopathology report of the previous procedure, which was suggestive of normal finding. There was a
Wait a minute. Just wait now. You said your patient had history of pain and passing clots, right?
Yes,
so, I mean, most probably now when you are taking a history, you said she had heavy menstrual bleeding. So from history, how do you judge that the patient has heavy menstrual bleeding?
Ma'am, we ask her the number of pads she soaked. If she is changing a pad in less than 4 hours, then we term it as heavy menstrual bleeding. If she is getting up at night and changing 2 to 3 pads, we term it as heavy menstrual bleeding. Or also we have a pictorial based assessment chart in which we give points.
Yes.
So in that we have 1 point for lightly stained pad, 5 points for moderately stained, and 20 points for heavily stained pads. So we add up all the pads, and if it's more than 100 for a cycle, then we term it as heavy menstrual bleeding.
Yeah. So average, at least when you say heavy menstrual bleeding, it has to be more than
200.
No. More than?
No.
Not so high. More than 80 ml.
80 ml.
Okay. Normal is between, normal flow is between
5 to 80 ml.
Yes, exactly. 5 to 80 ml. So if it is more than 80 ml, you will take it as okay. And patient is also giving history of passing clots. That itself suggests that the flow is heavy. Now, why you say that the history of passing clots, that means it's a heavy flow?
Ma'am, in the layman term, we ask the patient that the clot is 50 rupees, 50 paisa, and it is 1 paisa, 1 rupees coin. The clot
size. She is passing clots, right? So what does it suggest? It suggests heavy flow, but why there is a clot formation in heavy flow? Normal menstrual flow, there is no clot formation? No. Then, so what happens in normal cycle? There is a bleeding in normal cycle also?
Yes, ma'am.
Any change in the endometrium or something is released, enzymes which can cause, which will not allow the clot to form? So there is a fibrinolytic activity.
Yes, ma'am.
Yeah. So here the blood gets collected in vagina. So naturally there is excess blood gets collected in vagina and forms a clot, and that's how you think it is a heavy flow. Okay, go ahead. Another complaint, she said pain. Okay.
Yes,
so what
ma'am.
diagnosis come to your mind? She has this problem since 2021, right?
Yes, ma'am.
2021. Yeah. And pain and heavy flow. So you have some idea that patient must be having this problem. What is that comes to your mind, the first diagnosis?
Ma'am, the
It's a secondary amenorrhea and HMB.
Ma'am, the first diagnosis is adenomyosis.
Could be adenomyosis. Yeah. Okay, fine. So she has undergone DNC and she has taken treatment, and LNGIOS was also inserted, and it has been expelled also. Now you said that the HP report was normal. Normal means what? Have you seen the report, or it is patient version?
Ma'am, in the
patient's words
as
that
said
it,
by
it
the
was,
patient,
it
ma'am.
was normal.
Okay, fine. Proceed. Yeah, proceed.
So there was a history of NSAIDs intake for relief, history of hormonal treatment, as we described before, history of IUCD insertion 3 years back. She had no complaints.
Not IUCD. It is not IUCD.
It is IUD. Sorry.
IUD. Yeah.
No complaint of intermenstrual bleeding, postcoital bleeding or dyspareunia, no bowel or bladder complaints, no history of any trauma, no history of any easy bruisability, prolonged bleeding from wounds or bleeding from gums, no history of loss of appetite or weight loss, no history of heat or
By
cold.
asking this history, that no bleeding from gums and all that, she's 44 years old. What is that you are trying to rule out?
Ma'am, coagulopathies.
Okay, if you are suspecting a coagulopathy in a 44-year-old, what is that? What can cause these problems at 44 years? Otherwise, the coagulopathy is common in which age group?
Ma'am, in the younger age group.
Younger age group, no? And what are the most common?
Von Willebrand
factor.
And what else? What else? Is it only von Willebrand?
No, ma'am.
Then what else? You have invited this question. You understand?
Yes.
You invited this question. So tell me now, von Willebrand, you are right. What else? Anything else? It's not the only one, no?
Factor 8 deficiency.
Ma'am,
this is factor 8 deficiency. Okay.
Any
Then
coagulation factor deficiency.
Pardon?
Ma'am, coagulation factors deficiency.
Okay. Yeah. Factor 8 deficiency, von Willebrand. Fine. Then any other condition?
Ma'am, if in the platelets, ma'am, coagulation में problem है, platelets dysfunction, platelets के function में problem.
What is that? Yeah. What is that condition called as? Anything you know starting with G?
Gene.
Have you heard of Glanzmann thrombasthenia?
No.
Glanzmann thrombasthenia, where there is a decreased aggregation with collagen.
Between the
Yes.
2B3, it's a glycoprotein.
No, you are not clear, Preeti.
Hello, ma'am.
So there is a decreased aggregation with collagen, thrombin. Yeah. Okay, fine. So these are the conditions usually we find. Now at 44-year-old lady, what do you suspect?
Ma'am, there may be. मतलब इसका cause बताना है ना, तो कोई वो मैम there may be it is also for the कि वो कोई anticoagulant ना ले रही हो.
Yes.
That is one thing. Okay. Anything which can happen over a period of time. No, she can develop
thrombocytopenia or
yes. It could be ITP. Okay. Idiopathic thrombocytopenic purpura could be it is presented because she is on some drugs or something. So when you are presenting, you will have to, because you have already given the history. She has taken hormone, she has put a IUD. So this history, okay, is so much of negative history is not required. Proceed. In this case particularly.
Okay. A menstrual history. Menarche, she had attained her menarche at 13 years of age. Her LMP is 28 June 2024. The present menstrual cycles are lasting for 10 days every 28 days with regular but heavy flow with dysmenorrhea associated with clots. Patient changing 5 to 6 pads per day, completely soaked on first 3 to 4 days and 2 to 3 pads per day following that. She had undergone hysteroscopy DNC in 2021, but
and you have already told, yeah.
And Mirena was 2023. The past menstrual cycles before 3 years were pretty regular, 4 to 5 days, 28 days with average flow, and they were painless.
Okay, go ahead.
Obstetric history. Patient is married since 2022 and she is para 3, live 3 with all normal vaginal deliveries. Her last childbirth was 14 years ago and her eldest child is 19 years. No history of any postpartum hemorrhage or blood transfusion during her pregnancy. Her antepartum postpartum course was uneventful in every pregnancy. Regarding the contraceptive history, patient has a history of tubectomy in 2010. Past history, there's history of hysteroscopy DNC Mirena insertion in 2021. No history of any diabetes, hypertension, bleeding disorders, tuberculosis, malignancy or any other medical conditions. In family history, the mother has hypertension and has type 2 diabetes mellitus. No history of any malignancy in family.
Why do you think the history of diabetes and hypertension is important?
Ma'am, we have a condition called corpus cancer syndrome in which we have hypertension associated with obesity and endometrial cancer.
But suddenly, directly she is not going to develop, but I mean, she may be a candidate for that. That's why. Yeah, fine. Further, proceed.
Personal history, diet, she is vegetarian and with adequate calorie intake, sleep regular, appetite normal with no addictions, bowel and bladder habits are regular. Patient is on general examination.
On general examination, patient is conscious, cooperative, and well oriented to the time, place, and the person. She is average built and fair looking, and the gait is normal. Her height is 155 centimeter, weight is 65 kg, and the BMI is 27.1 kg per square meter. And she is afebrile. Pallor is present, but there is no cyanosis, clubbing, edema, icterus, and lymphadenopathy. Her pulse rate is 72 beats per minute, good volume, regularly regular. There is no radioradial and radiofemoral delay. Her blood pressure is 120 by 80 mm of Hg, taken in the sitting position in the left arm. Respiratory rate is 18 per minute. And the thyroid and the breast examination is normal. On cardiovascular examination, S1, S2 is heard and there is no murmur. On respiratory system examination, air entry equal on both sides and there is no adventitious sound heard. On per abdominal examination, on inspection, umbilicus is central and inverted contour of the upper abdomen.
Nothing, no positive finding. Okay, everything is okay on per abdomen, right? Yeah, go ahead, leave it, go ahead.
On local examination, external genitalia appear normal. On perispeculum, cervix and vagina looking healthy and there is no discharge and the bleeding per vaginum. And on per vaginal examination, cervix downward, backward, uterus is anteverted, enlarged up to the 8 to 10 week in size, globularly enlarged, firm and non-tender, and it is mobile and the both furnace is free.
Okay.
So by the history and the examination, my patient is 44-year-old female, para 3, live 3, presented with a heavy menstrual bleeding with passage of clot and dysmenorrhea since December 2023 after Mirena expulsion. On examination, she was average build per abdomen. On per abdominal examination, soft, no tenderness. On perispeculum examination, cervix and vagina was found to be healthy. On per vaginum examination, uterus was enlarged up to the 8 to 10 week in size, non-tender, firm, globular, mobile, and the bilateral furnace is free. This history probably suggests of abnormal uterine bleeding with adenomyosis. Provisional diagnosis, 44-year-old female, para 3, lab 3 with abnormal uterine bleeding with adenomyosis. And the differential diagnosis, it may be the leiomyoma and the endometrial hyperplasia.
Others can also. Why in the first place only you said that it is adenomyosis? You have given the differential diagnosis. Okay. She is a para 3 L3 with a bulky uterus.
Yes,
okay. So in your examination, what points you had to say that it is adenomyosis?
Ma'am, in examination, the uterus was, it was not irregularly enlarged, it was diffusely
globally enlarged, bulky,
bulky,
and
so that
and
deviated
mobile.
us from leiomyoma and endometrial hyperplasia.
But if it is a small leiomyoma, do you find much difference on examination between adenomyosis and you may not, right?
Yeah.
So differential diagnosis is better to give a differential diagnosis, right? Okay. Others can also ask the questions. Dr. Shailesh ji, Abhi puchiye. So how do you want to proceed with this case now? Yeah, aap puchiye.
Hey, ma'am, how would you like to proceed with these investigations and all?
So we will now we would like to get first of all a complete blood count because she had mild pallor on examination, and also along with that we'll get a thyroid profile done, and an basic the main modality will be an ultrasound to look for the uterus and the DEXA.
Ultrasound.
Ultrasound, you will ask
which
for any
ultrasound?
specific ultrasound or something?
Ma'am,
Yeah.
sir, transvaginal sonography.
Yes.
Okay, why this transvaginal?
Sir, sir, transvaginal sonography में sir, we assess the endometrial thickness and the जो structure है कि intramural या फिर endometrial cavities भी देख लेते हैं, plus adnexa भी easily visible होता है. In the transabdominal we only see the uterus is anteverted and the post and the retroverted और adnexa देख पाते हैं. लेकिन in the transvaginal we see the endometrial thickness and the endometrial cavity में कोई protrusion वगैरह तो नहीं है या फिर कोई mass present तो नहीं है.
And diagnosis of adenomyosis in ultrasound?
Sir, in for the diagnosis of the adenomyosis, there is a classification that is called Musa classification. It is the morphological ultrasound, morphological uterus so sonographic assessment of adenomyosis. It includes the uterus is globularly enlarged, asymmetrical thickening of the uterus. The most commonly the posterior part of the uterus is more thickened as compared to the anterior, and there is a myometrial cyst is present, and there is a hyperechoic island. There is the fan-shaped shadowing and interrupted junctional zone and the interrupted endomyometrial surface and the
myometrial cyst.
Yeah, okay, fine. And what finding you will get if it is a leiomyoma?
Ma'am, in the leiomyoma, it is well defined, and the wall appearance and it is hyperechoic, hypoechoic, and the isoechoic depending upon the degeneration. Mostly, it is hyperechoic.
Then you gave one more diagnosis as endometrial hyperplasia.
Yes, ma'am.
Endometrial hyperplasia, can you diagnose on ultrasound?
Yes, ma'am. Endometrial thickness देख के मैम हम पता कर सकते हैं endometrial hyperplasia.
How?
Ma'am, in the post-menopause, अगर endometrial thickness is more than...
your patient, 44-year-old.
Ma'am, अगर 44-year-old female है, अगर उसकी endometrial thickness is... मैम already वो मेरिना use कर रही थी, तो endometrial thin होनी चाहिए. लेकिन इसकी अगर endometrial thickness...
That is 3 months back. That it has been expelled now.
The effect has gone now.
अगर मैम in case endometrial thickness more than 12 mm आ जाएगा, तो फिर मैम it is the
anything else? Appearance of the endometrium on TVS.
Ma'am, trilaminar pattern
Any other pattern?
Will it be there or it won't be there?
Trilaminar will not be there. So what will be the other pattern?
मैम अगर ट्राइलेमिनार पैटर्न नहीं मिलेगा तो एंडोमेट्रियल थिकनेस मतलब उसका डिफरेंशिएशन नहीं हो पा रहा है तो मतलब एंडोमेट्रियम थिकन है मैम.
Yeah, but what else you can see? You can see small cystic spaces.
Yes.
Okay. Because it is so hypoplastic that you can find that on ultrasound. Okay. Fine now. Now, how do you want to proceed with this patient?
Ma'am, first of all,
we'll confirm our diagnosis on ultrasound. With
Yeah, it is
ultrasound.
adenomyosis. Fine, it is adenomyosis.
And then we would like.
Ma'am, then we ask the patient, we counsel the patient about the various treatment of the adenomyosis. कि अगर उसे मेडिकल मैनेजमेंट चाहिए, ऑलरेडी वो पहले रिसीव कर चुकी है, तो वो विलिंग नहीं है कि वो मेडिकल मैनेजमेंट दे. शी वांट्स कि और उसकी फैमिली कंप्लीट हो गई है, तो वो अपना परमानेंट क्योर चाहते हैं. तो वेरियस ट्रीटमेंट ऑफ एडेनोमाइसिस हम उसे बताएंगे, मेडिकल मैनेजमेंट एंड दी सर्जिकल मैनेजमेंट. इन दी मेडिकल मैनेजमेंट अगर उसे माइल्ड मतलब पेन है तो हम एंसेटोम मिफिनेमिक एसिड देंगे. उसके अलावा हम उसे प्रोजेस्टेरोन ओनली पिल्स भी दे सकते हैं, कंबाइंड ओरल.
Can you just speak in English? I would prefer Preeti, because if you get examiner from South India,
yes,
in your exam, you will not be able to understand. So you have to speak in English. Okay.
Yes.
What do you say, Dr. Shailesh? Because you don't know from
Yes,
where will you
madam.
get the examiner.
You
Okay, and
try
your
to use the medical
official
terms.
language is English. So you should try to say in English only.
Yes, madam. Yeah.
Ma'am, we will first counsel the patient regarding all the management options that are available, which would be first
No, we
line.
have discussed now. She has already received medical treatment.
And she
This
is
one
not
has
willing.
got expelled. Why do you think why the Marina was expelled?
Ma'am, it could be a faulty insertion of Marina.
No, she had it for a long time, right?
Yes, ma'am.
Yeah, she had it for a long time.
Ma'am,
what are the causes in which conditions it can get expelled?
Because her bleeding was very heavy, so and she has a paras os. So
Flooding, no? If there is a flooding, overbleeding, flooding, it can get. Anything else?
Ma'am, also
any other?
In rare cases, there are some. She has pain, so there are myometrial contractions which lead to expelling the device.
But that every patient. You said she didn't have pain after the LNG-IUS insertion. Your history says patient did not have pain.
So that
She
means it
your
was corrected.
diagnosis is adenomyosis.
Yes.
Can adenomyosis? It can happen. It can happen. Okay. Why? What happens to the cavity of the uterus?
Enlarged.
It is enlarged.
Enlarged. It is enlarged adenomyosis. So it can get expelled. Okay. So suppose the patient, you said medical line of management, and she is not willing for surgery. So you people are talking about medical. You tell me what medical management you want to offer her now.
Ma'am, we prescribe the progesterone only pills, Dynogest.
Okay.
And then combined or 2 milligram daily for 6 months. And then
First, kindly explain what is irregular ripening and what is irregular shedding. There are two things in abnormal uterine bleeding. One is irregular ripening and the other is irregular shedding. So, इसमें क्या difference है?
That is a ovulatory IUB.
Yeah.
These two come under ovulatory.
Yeah. So you said the periods were irregular. So what is irregular ripening and what is irregular shedding? Because the treatment is different for both, no? That is for ovulation, but the actually we placed LNG-IUS in this case. So irregular shedding is when you have the bleeding before periods. 22-23 ड्रॉ पे spotting शुरू होता है और फिर bleeding start हो जाता है. And irregular ripening is when you have periods spotting early phase and then heavy. So this is difference in AUB, irregular ripening and shedding. So you have to decide your medical management according to this, whether it's irregular ripening or shedding. So if you are giving progesterones, you said Dynogest directly. So why Dynogest directly? You can give simple other progesterones also, no?
Would you like to do a endometrial biopsy, people, before you start now? Because again, she has come back to you with heavy bleeding.
Yes, ma'am. We do
That is
the
the important investigation, one of the investigation to plan your medical management. What is that you want to give her, right? Yes?
Yes, ma'am.
Yeah, you would like, she could have endometrial hyperplasia, your differential diagnosis. In that case, you will have to go ahead with progesterone only. Then, would you like to offer her LNG IUS again?
Ma'am, we
offer her the we
if she is
offer her.
willing. If she is willing, she can.
Okay. Now there was a expulsion. She has adenomyosis. What do you think? What precaution, or you can do something to see that she does not expel it? You said the uterus is big, the cavity is big, so there are chances. Can you give her something, medical management? Which can help to reduce the bulkiness of the uterus.
Combined oral contraceptives.
That will not reduce?
Ma'am, GnRH analogs.
Yes, you can give her GnRH, right? You can give her GnRH, and then she will have amenorrhea. After that, you can insert the LNGIUS. Okay. If you want to go ahead with medical line of management, and now we have a progesterone only pill recently, no, which contains this. Is it the Dynogest for the progesterone only pill? You said Dynogest. Yeah. What are the other drugs for the medical management of adenomyosis?
Ma'am, medroxyprogesterone acetate.
Anyway, we don't use it now, no? We have Dynogest, which is wonderful. Any other? We talked about agonist. We talked about Dynogest.
Ma'am, selective progesterone receptor modulator.
What is that?
What is that? Is
it available in India, or it is yet to come to India?
It is not available in India.
Not available. Name? Have you heard of elagolix?
Yes, ma'am. Yes, ma'am.
Antagonist. No? It is antagonist. Yeah, that can be used, isn't it? Elagolix can be used. What are the other drugs?
Ma'am, we use the dopamine agonist.
Norethindrone can be used, ma'am.
Okay, but when you give this agonist, okay, if you are giving an agonist, what precaution you have to take?
Ma'am, we'll use estrogen add-back therapy along with, because she will have hot flashes and
add-back therapy. You may have to use add-back therapy. Yeah, okay, fine. Any other drug?
Is there any role of ulipristal?
Yes.
Is there any role of ulipristal or cabergoline?
This is adenomyosis. This is not leiomyoma. What do you? I think we will prefer ulipristal with leiomyoma, maybe, and all that. Yeah. Sir is asking about cabergoline.
Cabergoline, is there any role?
Yeah,
yes,
cabergoline can be used in adenomyosis. Any other drug? Aromatase inhibitors.
Yes.
Letrozole can be used.
Yes.
Even that can. So these are so many drugs for the medical management of this. I think chat box somebody is putting ulipristal and mifepristone delegates. That is for fibroid and not here, not for adenomyosis. We are discussing adenomyosis, LNGIUS. Okay. Okay, fine.
And
suppose this patient is
yes,
doctor. Yeah, Supriya, ask her.
Ulipristal in what dose you will prefer to give to this patient of yours?
Ma'am, in this patient adenomyosis, we don't give ulipristal. We give in fibroids.
Only fibroid.
Yeah,
No.
I just asked that.
No, supposing they are trying to give. So have you tried any time? Although it is not supposed to be given, that she said yes. That is why I asked.
No, what are the doses? Suppose if you want to give it for fibroid.
Yes, so okay, go carry on.
Ma'am, it is 60 milligram for the fibroid. Yeah.
on the
What
whole.
dosages it is available?
Ma'am, it is available in the 2 doses, 30 and the 60.
No,
Is
that
it right?
that is ormeloxifene.
Ormeloxifene,
Savista or
yeah.
Novex DS, that is ormeloxifene.
And why was why it has been not frequently used? Why?
Because of the
It was withdrawn from the market because what are the side effects?
liver disease, liver
So
toxicity.
suppose if you want to give it, okay, you will give it a minimal dosages, right? Okay. So now suppose if you want to start, so what investigations you would like to do before starting?
Baseline LFT.
LFT. How long you give? How long you give?
3 to 6
3
months.
months. You give it continuously for 3 months, 6 months?
No, ma'am.
No, ma'am.
3 months.
And then
Okay, what do you do after 3 months?
Ma'am, then we repeat the LFT after 3 months.
Yeah, okay. Okay, fine. When do you want to restart?
3 weeks. We
You have to give a 1 month gap. You repeat the LFT and then again you start. Okay. So there were cases where there was a liver dysfunction and patients had to undergo even liver transplants also. So that is why. Okay. And mifepristone also is for fibroid, but not for here again. Okay, now. So what do you want to do now for your patient? We have done the biopsy. It has come as proliferative phase.
So after counseling her regarding all the management, our patient was very keen on having a definitive management because she had two failed episodes of medical management with Dynogest and with Mirena. She was keen on surgical options. So as the family was complete, then we counseled her regarding hysterectomy, the pros and cons of having an hysterectomy, the routes,
various routes of hysterectomy.
So how do you counsel for the routes? How do you counsel her for the routes? She has 3 normal deliveries?
Yes,
ma'am.
Yes.
Then the various, when we counsel for the various routes of hysterectomy, that is vaginal hysterectomy, laparoscopic, and the abdominal hysterectomy. In the vaginal hysterectomy, we counsel the patient. There is a no scar mark in the vaginal hysterectomy, and the recovery time is less, and it is dependent upon the doctor expertise.
So what vaginal hysterectomy it is called as?
Non-descent vaginal.
Non-descent vaginal hysterectomy.
Non-descent NDVH, non-descent vaginal hysterectomy. Okay. How are you sure? Suppose if you are planning to do NDVH, what are the prerequisites before you plan to do NDVH? What will you do? What are the prerequisites? I mean, you should be successful in doing NDVH, you know?
Yes, ma'am. Ma'am,
so how will you know that you will be succeeded?
First of all, we will have a negative pap smear report. Negative pap smear report to rule out any of the cervical
pathogens. You will do as a routine. Okay. Okay, fine. Okay.
Then we will also ensure if in the ultrasound that she has no adnexal pathology associated.
Okay.
And
good.
Then
will you examine the patient thoroughly?
Yes, ma'am.
Of course, skilled surgeon. Of course, skilled surgeon.
Yes, skilled surgeon.
Examination. What will you look for in adhesion? Examination. You have to look for, when you examine the patient, what was your finding in this patient? Tell me, go back. What is your finding in this patient? The uterus is 10 weeks, anteverted according to you, and mobile and adnexa free, right? I remember.
Yes, ma'am.
Yeah. So suppose if the mobility was restricted, okay. If the uterus is fixed, you find, will you still proceed with NDVH?
No, ma'am.
That's what. So you have to rule out. I mean, you look for that mobility. You can also check for the descent of the cervix, isn't it? Okay. So you know that I mean, most of the Paris women will have first degree, but sometimes you can pull it up to 2 degrees, so you'll be happy. Okay. So these are the things I mean, you will have to check. Okay. Patient doesn't want vaginal, or there is no skilled surgeon. Then what do you decide?
Then we counsel the patient the other routes of surgery, that is laparoscopic and the abdominal hysterectomy. In the laparoscopic surgery, the scar mark is very minimal. Scar mark is minimal, and there is a recovery time is less, and it is also depend upon the skill of the surgeon.
Okay. Have you seen lab hysterectomy, TLH?
Yes, ma'am.
Yes. Okay. You want to do? What about the ovaries? What do you want to do? What procedure you will be planning for her?
Ma'am, we'll go for, since she's 44-year-old and her ultrasound doesn't have any ovarian pathology, we will counsel her regarding ovarian preservation. We'll explain her all the pros of ovarian preservation.
Pros and cons of ovarian preservation and the removal. And then we counsel the patient if the in the intra-op, if the ovary is normal, then we preserve the ovary. If it is looking abnormal and there is any mass, then we
Okay, if the ovaries are normal, okay, ovaries are normal. Do you think before you decide to keep or remove the ovaries, what history is very important?
Ma'am, we'll take history of any breast cancer or ovarian cancer in the family. Or
anything else? Anything else history? That means what? You're ruling out what?
HNPCC.
Yes.
Colon
cancer. HNPCC. We are ruling out HNPCC.
What is that?
Hereditary
non-polyposis.
Somebody is prompting you from behind. I don't want that. So there is a syndrome or a condition where these malignancies are seen. You said ovarian, breast, what else?
Colon cancer.
Colon cancer, then breast you said already, and ovarian and colon. Okay. It could be Lynch syndrome also?
Yes,
okay. Yeah, it could be BRCA.
Yes.
Yeah, BRCA1, more common with BRCA1. So you would like to have anything, history, any history of malignancies in the male members of the family?
No.
Is also important. Any other malignancies in the male members also you have to ask.
Prostate. Any history of prostate?
Yes, very good. Prostate and
breast cancer
in male.
Pancreas.
Okay,
even that you have to ask. So before you decide, you would like to take this history whether you preserve or not. Now, if the ovaries are normal, I think colon cancer was mentioned. Till what age you can preserve the ovaries?
Ma'am, till 50 years, the 50 years which we consider as average age for Indian women to have a menopause. So
what is the average age?
49 to 51 years.
No, you tell me the average age. You said average, so you'll have to give me the average.
47.
Yes, 46.7% is the average. Okay, the range is up to 52. Okay, fine. Then how long you will preserve? Till the age of 65. Okay. Even if we are doing, don't do that till the age of 65. Okay, sorry. You have to preserve the ovaries. Okay, now tell me the steps of TLH. Okay. Anything else you want to add? You're not removing the ovaries. What else? You're removing the uterus with the cervix. Anything else you want to remove?
Fallopian tube.
Why you want to remove the fallopian tube?
Because, ma'am, to decrease the risk, ma'am, because the fallopian tube is responsible for the epithelial cancer in the ovary. That's why we remove the fallopian tube.
So by reducing fallopian tubes, how much percentage this decreases of ovarian cancer, chances of ovarian cancer? By removing the fallopian tubes, there is 75% decrease in the chances of ovarian. So, and what will be the consent?
So which malignancy?
Yes.
Epithelial ovarian cancer.
Ovarian. So
So what will be the proper consent you will take before doing any type of hysterectomy? Means you are doing TLH. We will you will tell us steps of TLH, but before that, please tell what will be the consent. There are 5 or 6 consents nowadays. So consent paper में आप क्या क्या लिखते हैं?
So, in the consent paper, we written the first of all the diagnosis of the patient, and then the various route of treatments. We counsel her, and the patient.
The route she opted for, that is to be mentioned clearly.
And the procedure.
First, the procedure name in full.
And the procedure she opted for
laparoscopic hysterectomy with bilateral self-injectomy with oophorectomy if required.
If required.
Next, second cheese क्या बताएंगे?
The risk associated with the surgery, that is injury to the bowel, ureter, and the risk associated with the anesthesia, that is sepsis, and there is maybe the increase.
First is second is benefits of surgery. The third is risks of surgery. Risk of anesthesia is a separate consent sheet. Then fourth is what can happen if not done. Okay. And the alternative management of the surgery. These all are 6 points which should be included in every consent. Now tell us the TLH steps.
So to start with, we first put the patient in under general anesthesia. Then we in our institute we put the patient in dorsal lithotomy because we use vaginal manipulators also in total laparoscopic hysterectomy. Then we have a primary.
So first of all, patient put in the dorsal lithotomy position, and we empty the bladder, and then we do the perispeculum per vaginal examination, and after that we check. First of all, we check the painting draping done, and then after that we check the Very's needle. It is working, and then
first you will put manipulator now. Which manipulator you are using?
Sir,
so we are using Marva's manipulator. Hang ho gaya. Hang ho gaya.
Okay, so use the manipulator. Then what else? Next, proceed.
Then, ma'am, we'll first check our Very's needle. If it is patent or not, if the wall of the Very's needle is working, and if there are no any
there are patency. We check the patency of the Very's needle. After that,
okay, you have created the pneumo now. You have created the pneumo. Go ahead.
Then
we lift the abdomen, and then
we lift the abdomen and assess the where we put the scar mark. Actually, the in our patient the uterus
scar,
is incision. So, sorry, ma'am, incision. In our patient the uterus is 8 to 10 week in size. So we
opted for an infraumbilical port, primary port.
Primary port is infraumbilical, and after that we there is 4 is incision, 2 in the left side and the 1 is the right side. 2 in the left side. First is First, at the level of the first is at the 2 centimeter above, and the 2 centimeter above and the medial to the ASIS, and the second incision is the forefinger lateral to the primary incision.
In the
okay, fine.
In the mid.
Okay, now you have all the ports inside. Tell quickly, briefly. You just tell the steps, huh?
Then after that, we first of all we inspect the upper abdomen, and there is no there is any adhesions, and there is an EVO, and then we see the uterus and the fallopian tube and the bilateral ovaries. And after that, there is any collection and any abnormalities. And after that, we first
clamp, desiccate, and desiccate, cut the bilateral round ligament, and after that we desiccate and cut the bilateral tubo-ovarian ligament, because in this case we preserve the ovary, and then we separate the anterior and the posterior leaves of the broad ligament, and after that we
push the bladder down.
We push the bladder down, and then we ligate the uterine artery with the vicryl.
Are you ligating? Are you ligating in TLH?
Ma'am, one of our
Are you
surgeons,
ligating?
one of our surgeons is ligating, and one of them is using directly coagulating.
Yes, ma'am.
Yeah, fine.
Then
harmonic they use
yes.
harmonic also? Yeah.
Yes.
Okay, fine. Then okay. Uterines over, then next.
Uterosacral.
Then then we do the colpotomy.
Yes.
And then
yes.
And then we remove the uterus from the vaginal area, and then we do the vault repair with the vicryl number 10.
Okay, so vault is also closed. Okay. Yeah. So Dr. Shailesh, Supriya, anything questions you want to ask?
So somebody can
Complications,
explain
what
on that?
complication can happen intraoperatively?
Yes, during the operation.
First of
What
all,
are the
ma'am,
most points or the critical points you have to take care of during the operation?
first of all, we have to ensure that we are while testing with the varies, we are properly inside the abdomen before inflating the abdomen. Secondly, after we go inside, regarding the accessory port placement, we have to first look forward for any adhesions if we could see before putting the accessory ports. Then thirdly, we have to also be careful while if we had dealt with the IP ligament, we have to be careful of the ureter.
Yes.
Then while
Now,
coagulating
what will you use to open the vault? You said you will do colpotomy, right?
Yes, ma'am.
Yes. What is used to open the vault?
Monopolar could be cautery could be used.
Could be used. But if you use which is you will have more risk with monopolar or
Ma'am,
monopolar or
ma'am, depend
bipolar.
Ma'am, we use both depend upon the consultant. Some consultant use monopolar and some is used bipolar.
Okay, what problems you can face with what? If you have used monopolar, what is the risk?
Ma'am, in the monopolar cautery, the lateral dissipation is very high, and that's why the injuries to the bowel and the nearby structures is more as compared to the bipolar.
Also, there is a heat production also high. Smoke will obscure our view more in case of monopolar.
So what is the difference between cut and coagulate? Monopolar and bipolar, you have two modes now. One is cut and one is coagulate. So what you use?
So we use the coagulation, not cutting.
In coagulation mode, lateral thermal spread is very much. So when you are using at vault, you can use cut also. So if there is oozing or there are some bleeding points, then you can use
coagulation.
Yes. And what are the other?
Suppose if your patient has,
What are the other energy sources? You have monopolar and bipolar. Nowadays, many energy sources are available.
So yes, sir, harmonic.
Yes.
And
what are the advanced bipolars, vessel sealers? Harmonic is too expensive. It comes around 15-20 lakhs or maybe more than that. So nowadays we also have advanced bipolars that are called vessel sealers. Okay, so what is the advantage of these nowadays? कितना महंगा चीजें क्यों लेने का है? Simple monopolar bipolar से भी तो surgery हो सकती है. Then why these things are there?
So because these advanced bipolars have reduced lateral spread, so we have reduced complication rate. Also, these advanced bipolars have less heat, smoke and heat production. So the vision will not be obscured while handling these instruments.
I think good. Okay, fine. I think as a PG, they have seen. I think that's good thing. Now, suppose if the patient has come first time, she has come to you and she is bleeding profusely. You have done an ultrasound and you know that it is a thickened endometrium, right?
Yes.
Okay. So you would have done a people and sent it for. Now you want to arrest the bleeding, right? So what will you do till you wait? You have done the EB. What will you give her?
We will give her the IV estrogen and along with the
IV estrogen it's not available with us. IV estrogen.
And we will give the IV tranexamic acid.
Okay, IV oral. How much tranexamic acid you can give?
Ma'am, 1 gram in the 100 ml NS.
No, total dose, how much you can give oral? You don't have to give IV, you can give oral.
1.3 grams could be up to 1.3 grams we can give. Also,
Divided
we will start her for high dose combined OC pills, so that which leads on tapering doses of 7 days. So first 4 pills thrice daily, then.
But why do you know there is an endometrial hyperplasia? Your choice will be combined pill or your choice will be progestogen.
Progestogen.
Which progestogen?
Norethistron and the medroxyprogesterone acetate.
Which one? Norethistron. Patient is bleeding heavily. Which will you prefer? Norethistron or medroxy?
Ma'am, MPA, medroxyprogesterone acetate.
No, I say no. I will prefer norethistron. You tell me why.
Ma'am, because norethistron will help in acutely stopping the bleeding. So we give it in
That's
first
what, why?
Taper.
Yeah, you give the high dose and then you taper. So it has a septic activity. No, it vasoconstrictive activity, right? So it acts better. So when there is an active bleed, you prefer norethistron. Maintenance, you can use medroxyprogesterone, right? Fine. Now, suppose if you have done the endometrial biopsy or you have done the DNC and your report comes as complex hyperplasia with ATPia.
So,
what will you do? Complex hyperplasia. What do you mean by complex hyperplasia? Simple and complex. How do you differentiate between simple and complex? You know the classification of hyperplasia, right? What do you mean by simple? What do you mean by complex? Nobody is prompting?
Something related with glands.
High complex hyperplasia has high NC ratio and the endometrial gland to stromal ratio is increased.
What is more in complex? What is lost in complex? You comment about stromal, right?
Yes, ma'am.
The stroma is less, so the glands are compact, and there are projections like finger-like projections and they are compact. So that is complex. Okay. And now with ATPia. So what will you do now?
Ma'am, we will counsel the patient regarding the report, and since our patient was keen on definitive management, so
she has ATPR, will you give her a 44-year-old lady for para 3L3 a definitive treatment or not? Yes or no?
Yes, ma'am. Yes, ma'am.
Yes, no? Yeah,
Yes, ma'am.
because she is, okay, she's 30 years old, married for 1 year. Okay, so PCO, you have done this and you get the same report.
So there we will go for
Then what do you do?
high dose medroxyprogesterone acetate.
For ATPR, which progesterone you will give?
My guess. Medroxyprogesterone acetate.
She has to conceive, right? She is nulliparous. Yeah.
I guess megestrol acid.
Yes, yes, megestrol acetate, right? Megestrol acetate, how much? What is the dose?
40 mg twice daily.
Yeah, okay. Now you will call her for follow-up. What will you do? You can go up to higher dose also. The tablet is available as 40 mg. Okay.
Ma'am,
how will you follow her up?
We follow her up after 6 months and assess her symptoms and the endometrial.
6 months will be too long. Too long. Okay. What else you can use? Apart from megestrol acetate, what else you can use?
Is there any role of dydrogesterone?
Anything else?
High dose.
Can you use LNG IUS?
Ma'am, with
can you use LNG IUS?
In patients with ATPR, we don't.
Yeah. Yes, yes. Yes, you can. You can use LNG IUS. Okay. You can use LNG IUS also in them. Okay. Fine. So we can use LNG IUS here. We can use in elderly woman. Can you use the LNG IUS in a adolescent girl?
Yes, ma'am. The dose is less. There
With
is a
coagulation disorder.
no,
With
ma'am.
coagulation disorder.
No, ma'am.
You can use. It has even, you can use, okay? It has antifibrinolytic activity. You can use even in them also. Okay. Suppose if you have a young girl, okay, she has a coagulation disorder. So what will be the choice of treatment? LNG IUS will later. Can you give her? You want to give her hormonal or non-hormonal?
Ma'am, we give the hormonal low dose of progesterone.
You can give hormonal. Even if she is one will brand, you can give her hormonal. Okay. Can you give her tranexamic?
Yes, ma'am.
Coagulation disorder.
Theoretically, there are chances, but you can give. Okay. You can give even that also. Okay. LNG IUS is also been told. Non-hormonal? Tranexamic is non-hormonal. What else? Anything else?
Ethamsalate.
Yes.
And
Yeah, then
desmopressin.
how it is given? Yeah, desmopressin can be given. How it is given?
Nasal spray.
Nasal spray. Okay. Even that is how you manage them. Okay. So these are the conditions where you will have to be very careful. First of all, diagnosis is very important. Okay, Supriya, from your side, any questions to them?
Yes. So in this such cases are very often seen and is very in all age groups we see this. So there's no question actually now. Now just sum up. What will the take home message? What will you try to be careful in your practice? What in all the cases of AUB, what you need to be very, very specific about? So each one of you separately
Because
answer.
Supriya is here, I asked about adolescent problems.
Yes, actually,
Supriya.
Yes, adolescent AUB. You know, it's very, very common, and they get very panicky, even the parents and the patients. So what will you do if an adolescent come with you with this heavy menstrual bleeding? So what line of treatment you start with them? What do you do to them?
Ma'am, first of all, in adolescent AUB, we'll first try and find out the cause. We'll rule out the coagulation disorders. We will rule out any other pathology. And
is there any classification?
It is quite common. So reassurance is the first thing.
Yes.
Okay. Reassurance is the first thing to the daughter and to the mother. Correction of anemia, advice on nutrition. Okay. All these things you will have to tell them. Fine. Is there is a time or our time is up?
Our time is up, madam.
Organizers.
Organizers will tell us.
Yeah.
So one question,
Yes,
with your skill as you are a surgeon now, or after 1 year you will be performing hysterectomies. So what will you prefer, total laparoscopic hysterectomies or vaginal hysterectomy?
Just a gentle reminder, sir, we are just running out of time over here. If you
Yes.
wind up the
Last
discussion,
question.
Yes.
We would like
We are
to
ready.
be
We
trained in
said
laparoscopy and we would like to go for laparoscopic hysterectomy.
But
Just as a sort of, because we both are from endoscopy unit, so we have developed interest.
yeah, I was in the same unit, but over the years you will learn that vaginal hysterectomy is much more easier than the laparoscopic hysterectomy and much more comfortable for the patient. So it depends actually, but
less morbidity, less anesthesia complications, everything less. So, okay, thank you. Thank you all. Thank you,
Thank you,
Dr.
ma'am.
Shailesh,
Thank
Dr.
you, sir.
Supriya.
Thank you, madam.
Thank you, Gangaram team, for giving us this opportunity. Okay,
So
both
a
of you
very
did
thank
well,
you and very
but
good
I think
evening,
you
ma'am.
need to.
So a very wonderful discussion. I'm Dr. Huma. I'll be taking over the further sessions today. So a very thank you to all the chairperson and the presenters. A healthy discussion it was. Thank you, ma'am. Thank you, sir.
Thank you
very
ma'am.
much. Thank you, Dr.
So
Madam.
with this, we will move upon to the next session, that is on the case discussion on adnexal masses, presented by Dr. Rishabh, secondary DNB candidate, and Dr. Anusha, who's fellow in Gynae Onco in Sir Gangaram Hospital. And I would like to call upon the chairperson for the session, Dr. Rahul Modi. Dr. Rahul Modi is consultant, Obs and Gynae in Gynae Oncology Department in Sir Gangaram Hospital. Welcome, sir. And our next chairperson is Dr. Seema Singhal. Ma'am is MD Obs Gynae and Professor Obstetrics, an additional professor in AIMS, New Delhi. And the third speaker for the welcome, ma'am. The next speaker, the chairperson for the day is Dr. Helen Kamei. Ma'am is professor in JNIMS with special interest in Gynae Oncology. So welcome, ma'am. And she's in charge of Gynae Oncology Department in Manipur. And the next speaker for the day is Dr. Archana Mishra.
Good evening.
So good evening, ma'am. So I think we can go on with the case today.
Yeah.
Dr. Rishabh, Dr. Anusha.
Good afternoon, everyone.
Good afternoon.
Today my case is on the adnexal masses. So we have Mrs. X, 52 years old female, with the chief complaint of pain in the lower abdomen for last 5 to 6 months without associating with any anorexia or weight loss. Her history of present illness is she was apparently well 6 months back, then starting having non-radiating dull pain in the lower abdomen, which was not associated with her menstrual period, nor her bowel and bladder habits. Her menstrual history is she had menarche at 13 years old and had regular menstrual cycle of 3 to 4 days per 28 days. Her last menstrual period was on 14th July 2024. She doesn't have any history of dysmenorrhea. Her obstetric history is she has 2 live births, both LSCS. Her last childbirth is about 28 years ago. She has no history of tubal ligation, and she has history of using Mepred for 14 to 15 years till the age of 15. Our medical history gives she is a known case of hypothyroidism, for which she is taking Thariani 50 mcg OD daily without history of hypertension nor or abdominal surgeries. Our family, obtaining cancer was in the father without history of hypertension, diabetes, or hypothyroidism to any other members. Our personal history, she was well educated with normal bowel and bowel habits, non-vegetarian, and she has no history of any addictions or allergies. She visited to the local clinic. On examination, she was conscious, well-oriented, cooperative, with hydration, adequate hydration, of reply to touch, no pallor, icterus, sinuses, clubbing, or pedal-edema or lymphadenopathy. Our vitals at the time of admission in our hospital was blood pressure 130 by 80, heart rate 80 BPM, temperature was 37 degrees centigrade. Her weight is 94 kg and her height is 161 centimeter. On her systemic examination, respiratory is bilaterally equilateral, no added sound, cardiovascular, sound hearded, no added murmurs, CNS is no focal neurological deficit. Her per abdomen was soft, she was very obese, and about 20-week size mass was palpable. For a speculum examination, the cervix was very healthy, but it was a pinpoint cervix. On her per vaginal examination, uterus was anteparted, mobile, normal in size, left fornix is free, right form is non-mobile, smooth, about 20 into 15 centimeter mass palpable. Our per rectal examination, rectal mucosa was free, bilateral parameter was free, no nodularity in POD seen found. On her ultrasound, which is
ultrasound pelvis was done, which was suggestive of elongated mixed echoic 104 into 99 55 mm mass, predominantly cystic in nature, seen in pelvis, cephalad top of uterus and bladder extending up to intramural region with irregular margins, and internal echoes are seen.
Anusha and Rahul, may I interrupt?
Yes, ma'am.
Beta, we will go to the investigation. You have taken the history.
Yes, ma'am.
So, Anusha, this specific question is to you. Can you just summarize your case based upon history and examination?
Ma'am, the patient was admitted, came with a complaint of lower abdominal pain, and on her examination, we can palpate about 20-week size mass just below the umbilical region, non-mobile. And her per vaginal examination, we can palpate the same mass from the right POD, right fornix. And on her examination, first the ultrasound was done. In our ultrasound, we can see.
No, we are not going to ultrasound now.
Okay. On her investigation.
When you are summarizing your case, you did not even mention the patient's age. Do you think it is important?
Okay,
it is important to mention patient's
yes,
age. So be a little slow and be more, because when you are presenting the case, you are just come to your exam. I'm just coming to your examination findings. Just come back to your examination findings. Your general physical examination. Let's start with that. So you are writing conscious, well-oriented, hydration adequate, nothing. Then just come to the next. Right. So you're doing pulse, BP, temperature, weight, height, right? Just vitals. Don't you think BMI, taking out BMI is a part of general physical examination?
Yes, ma'am. Yes, ma'am.
What
Yes,
is-
ma'am. Yes,
So,
ma'am.
right? Did you mention about her pallor, icterus, pedal edema? Do you think it's important for her?
Yes, ma'am. We have.
Where have you mentioned that?
Yes,
No
ma'am.
pallor, icterus, cyanosis,
Query.
but okay. What about breast examination and thyroid examination?
Ma'am, thyroid examination was done. Breast examination was also done, which are all.
When we are presenting, nothing is assumed, beta. We just can't assume.
Sorry, ma'am.
Yes, nothing. No, it's fine. Just come to your examination finding. You have to mention clearly when you are examining a breast abdominal mass. The breast examination is very, very important. What's your patient's age?
53, ma'am.
So she's 53 years old, right? So you have to examine it while you're presenting your case, especially in adnexal mass, and you're writing the family has some history of cancer. So even then, it's a good idea to draw a pedigree chart and things like that, so that it becomes a little bit more organized and systematic, your case presentation.
Okay.
And you have to mention about her orodental hygiene. You have to mention about her hair. Then this thing, hair is very important, and these things are really very important. Pedal edema especially is very important in a case of adnexal mass. So these things. And then you are writing in your gynecological examination. Just come to your perabdominal and gynecological examination. Yes, first we are writing about the perabdominal examination. What do you all think that it is missing? What all is missing for when when there is a mass? Then you are not supposed to do a perabdominal examination just like that. It has to be systematic: inspection, palpation, percussion, and auscultation. So in those subheadings, you need to describe your abdominal examination findings, and that is why you are missing so many important things like
Scars. She is previous to LSCS. They have not mentioned scars.
So all these findings are so relevant. Even when you're presenting a short case, then also you have to be that systematic when you're presenting your case. So you cannot be just superficially saying this soft obesity present, 20-week size mass palpable. No, you not mentioned about it, like what was the consistency of the mass, what were the borders like, was it tender, was it non-tender, was the lower limit palpable of this mass. So these things are important. Then you have to mention about the fluid thrill. You have to mention about the percussion findings, whether the flanks were resonant or dull. Was there any shifting dullness? Was there any ascites? Right? So in all the quadrants of abdomen, the way we mentioned, all these things have to be drawn actually. You actually should draw this diagram in your examination findings, how the abdomen looked like, from where the mass was lying, from which extent to which extent, like what was the side to side and apparently this thing.
Mobility and everything they have not mentioned.
Mobility, yeah. So you have your book as Das is there, and you have those points under which you have to describe a mass, especially the perabdominal findings. So these things are missing here. Okay. Then in the per speculum exam, local examination of vulva is missing. We have to mention a 53 years old. Or is there any sign or anything on the vulva? Then pinpoint healthy cervix. No comment on vaginal
discharge.
appearance. Yeah, exactly. So that is missing. Then in the pervaginal examination, you are clearly writing that uterus is anteverted, mobile, normal in size. I have a doubt that when you are 20-week size mass and that is occupying the whole abdomen, then will you be able to really comment on this non-mobile mass, especially with a non-mobile mass? Will you be able to really differentiate between the uterus and the mass? Can you really make out the size of the uterus? So I'm doubtful about it. Secondary, then your rectal mucosa is free, but bilateral parametrum free. When you have fixed mass in the right side pay, then it may be difficult for you to exactly comment on the parametrum. So you may avoid that. So these will be my comments on your this thing. And then Dr. Archana was saying something about the summary. Yeah.
Yeah. You are just jumping on the investigation.
Yeah.
While you should be concentrating, you are a PG student. You have to give your exam. In exam, you will not be provided with the investigations. So you have to make a diagnosis based upon your history and examination only. It may or may not be the real diagnosis of the patient, whatever your patient is telling and whatever you are palpating in the patient and doing the examination. That is very important. There is a very important history that you have told. For 14 years, she is taking Maprate. Was there a reason for that? You have not mentioned it. Is she suffering from some disease? Why somebody will be taking Maprate for 15 years? She is 53-year-old. So I think in late 30s, she has started taking Maprate. how it was. It was cyclical. Was it continuous? It's not a simple thing.
Did she tell you about the name of the drug, or you as yourself assumed that it must have been Meprate? I mean, how did you learn that it was Meprate?
And she told it was it is Meprate, and she told me that she had been using it for 15 years, but she didn't tell the exact diagnosis why she is taking it. So
Did you
I
ask
asked
her
if it
when was it started? Yeah.
Yeah, I asked when it was started. She said after 2 to 3 years after her second baby, second CS, she started taking that medicine, but she didn't give the exact reason why she is taking it. And she has left almost 3 years ago. So she didn't say that I went to some hospital and some doctor prescribed me, or I had having some problems, so that's why I taken it. I had asked her repeatedly about that.
Anusha, it is hard to believe that somebody will take a Meprate so regularly that she
Really?
will
Yes,
have
ma'am.
breakthrough bleeding, irregular bleeding, and will continue to be, one daily without any breaks, without any. It is really hard to believe, actually. Maybe some miscommunication or something there.
Yes, ma'am. I had asked her, but she doesn't know why she is taking it for so many years. And after 50 years, somebody told her to stop it, so she stopped it. She just gave me that history.
So, do you think what can be the problems because of this such a prolonged progesterone intake? What is she at risk of, actually?
She might have abnormal uterine bleeding after 3 to 4 years of cesarean section.
Why should she have? No, I'm asking you, since your patient has taken Meprate for 15 years.
Yes,
So,
ma'am.
do you think she's at risk of certain complications, some problems because of this particular inadequate hormonal intake?
Yes, ma'am. She would have.
I think to break the thing, I think Anusha is our fellow in Gynaecology department, and Rishabh is a resident who comes from OBGY. So I think probably that's why the confusion with all these things. I think probably So yeah, and
Anusha should
I
definitely
think what
be able to tell us. Definitely should be able to tell us that the risk of such a prolonged progesterone intake, that to systemic administration.
That can lead to abnormal liver function, deranged liver function, and it can lead to
common complications kya hai of taking. What are the side effects of taking progesterone for a long time?
And it can lead to abnormal uterine bleeding, also breast engorgement and breast tenderness.
Why breast engorgement? Engorgement word नहीं use कर सकते हैं इसके लिए.
Breast lumps can be, it can cause
Anusha,
migraine, headache.
Migraine, headache, agreed. Weight gain, ये सब चीजें हो गया, metabolic चीजें हो गया. Anything is very, very important, Anusha. I'm giving you a hint also, yeah. Is there some cancer which she can be at increased risk of?
Endometrial.
Endometrial, why endometrial? What are the risk factors for endometrial cancer then?
Chronic anovulation is the
anovulation की होता है because estrogen unopposed होता है. अगर estrogen unopposed होगा, then they will be at increased risk. Progesterone will protect them.
Yes.
So which cancer they are at increased risk of? Breast cancer हो सकता है उनको ज़्यादा risk. Progesterone has been thromboembolism. Yes, somebody is writing in the thing, the chat box. Thromboembolism, VTE, definitely she'll be at increased risk. Okay, please go ahead. So you summarize your case. No, please don't go into that. We don't want to go for your slides and all. We want you to discuss this case. Management part.
When she is
Please tell us your differential diagnosis of a woman who is 50 years old, postmenopausal, and is presenting to you with pain abdomen and a 20-week size mass. Is that fine? Is that your case?
Yes, ma'am. Yes, ma'am.
So tell us the differential diagnosis now for your case.
Yes, ma'am. Ma'am, the differential diagnosis can be large ovarian cyst. It can be endometriomas or any dermoid cyst. It can be any tubo ovarian mass
or ovarian cancer, carcinoma of fallopian tube, or metastatic cancer.
So you're writing down as huge ovarian cyst. What do you mean by huge ovarian cyst?
Large ovarian cyst size more than 10 centimeter.
The patient is just 10 centimeters, right?
Yes, ma'am.
So
Yes, ma'am.
what is the need of writing huge ovarian cyst? You can write as benign ovarian neoplasm.
Yes, ma'am.
So when it is huge,
Yes.
is a word for finding, where you
Yes.
want to tell the size of the mass. That does not give you help you in differential diagnosis. Differential diagnosis is about the pathological condition your patient might be having. Is it not? So your differential diagnosis can be ovarian neoplasm, which could be benign, borderline, or malignant.
Yes,
Isn't
ma'am.
Yes, ma'am.
So this you can that way say, and then in the benigns you want to keep as serous adenoma, maybe epithelial serous epithelial benign tumors, or endometrioma, dermoid, or tubovarian mass. I agree with that. Then ovarian and fallopian tube carcinoma should be clubbed, no?
Yes, ma'am.
Together, you cannot keep them separately. It is very difficult to differentiate.
Yes, ma'am. It's very difficult to differentiate.
Why did you write metastatic tumor?
Because, ma'am, if the breast she is taking this Mepred so long, and if there is any, then breast can come to a secondary. So as a Krukenberg, so it can also be like metastatic, ma'am.
तो आपने breast का examination लिखा ही नहीं अपनी findings में इसलिए, है ना? You can't say that.
Exactly. And the differential diagnosis should be according to this patient, this 53-year-old, just menopausal lady. You should be writing according to this patient, because you're very much emphasizing on the things which are not that common and which are not.
Yeah, Dr. Archana ka shayad signals lost ho gaya hai. So that's what she's trying to tell you, that you have to be systematic a little bit. So one, you wrote correctly that epithelial ovarian neoplasms, benign, borderline, malignant, right? That you
Yes,
can write.
ma'am.
And then benign mein yours will be endometrioma, dermoid, teomas. I agree with that. Perfect. No? And then metastatic tumors you can write, but then you're forgetting, could she still be some uterine neoplasm, uterine mass?
Yes, ma'am.
Yes, ma'am.
Which uterine condition can be there?
Ma'am, non-malignant में fibroid हो सकता है, ma'am.
Which type of fibroid it can be?
Subserosal fibroid can lead to this kind of condition.
Very good. Subserosal fibroid या फिर broadly, because देखो आपका मास एक तरफ है, तुमने लिखा है fixed type का मास है, है ना? तो broad ligament fibroid में mobility भी नहीं आएगी और uterus के एक साइड पे ही होगा, है ना? Fixed type का होगा. डॉक्टर अर्चना, आपका सिग्नल वापस आ गया, आप कुछ कह रहे थे?
Yeah, I was just asking, okay, you have this examination and everything, and in a 53-year-old lady who is just menopausal, after 50, what are the chances that she can be a malignant case instead of benign? The likelihood of that? Because all your negative history and everything depends upon that. What is the age of the patient? What is the presentation like?
Ma'am, mean age at which the ovarian mass basically presents is like 63 years, 50 to 60 years of age.
What is the likelihood? How much percentage there is chance that it could be a malignant? A person who is taking Mepred for 13 to 14 years, I think she must be taking it only for the sake of the periods. I think it must be around 5 days a month sort of thing, because it's very unlikely that she's taking. So have you taken the history that she is suffering from some menstrual irregularity like PCOS or something?
Yes, ma'am. I have taken that history. Yeah, I have taken that history. But she denied she denied every negative, every diagnosis. I tell her that if she is having this and she is taking Mepred, she said no. If she is having any premenstrual bleeding or anything that's doctor prescribed her the Mepred, she said no. Everything that I said, she denied it, and she doesn't even remember why she is taking that.
It can happen, yeah, sometimes.
Maybe. She was taking daily. She was taking one dose daily.
Yeah.
Is it so?
She is taking one dose daily.
And she was having regular periods.
Yes, ma'am.
So how will you confirm your diagnosis now? Next steps for you. No, don't go into this. We don't want these slides.
Yeah. We have not asked for it.
Yeah,
You
it's
are
like
just
your exam,
going
paper.
ahead.
Slides से तो बोल ही दोगे ना? Slides नहीं बताना है. Slides are for your preparation. You should tell us the things. है ना?
Maybe we don't want to ask that. Maybe, isn't it?
No.
Tell us how will you evaluate her further and how would you reach to the diagnosis?
Ma'am,
And how do you plan?
Ma'am, her transvaginal ultrasound was done, followed by which was done.
First,
We are asking workup, beta.
You said transvaginal ultrasound. See, you did an ultrasound, a 20
Yes,
weeks mass. Why do you want to do an ultrasound? First, tell me what will you look into the ultrasound. Then we will decide whether you want to do a trans-abdominal or a transvaginal scan. Let's think like that. Okay? Tell me, what are you wanting to look into the ultrasound? Tell me.
Ma'am, basically, we wanted to see whether the what is the location of mass, where it is located, location we want to know, and if whether it is intra-uterine, extra-uterine, or arising from fallopian tube, we will confirm the location. Then we will see if it's originating from ovary, then whether it is had got unilocular, or it is cystic, or it got solid component, whether it has got unilocular or it's a multilocular cyst is there, or if there is any solid component is present or papillary projections are seen. So what is the size of cyst, or if does the mass is there, or we will see about the Doppler blood flow, how it is, if there is increased blood flow or not. So these are the things we are going to see in that ultrasound.
So very good, very well answered. आपका नाम है भूल गई, I'm sorry.
Rahul.
Rishabh. Rahul boss का नाम.
Yeah, okay.
Yeah. Rishabh, see, the thing is that you very nicely said that first ultrasound would tell you the site of origin, whether it is uterus or whether it is adnexa or whether it is a non-gynecological mass. Sometimes a large mesenteric cyst can also present, a large retroperitoneal
or inclusion cyst can also say.
Even peritoneal inclusion cyst. So all these you should be on your differential diagnosis. Even tuberculosis still you cannot rule out. And I forgot to ask you why your patient was having pain and what would you think about it, about this pain also. So when your patient is having pain, what do you think your patient could be having? Then we'll take it forward. Sorry, I forgot to ask that question.
Pardon, ma'am, can you again?
Why your patient had pain? You said your patient presented with pain abdomen. So why do you think she must have had pain?
Since the mass was on large size, it was pressing on the pelvic. It was giving pressure symptoms, or like it could. So that could be the reason she is having pain.
So stretching का pain हो सकता है, pressure हो सकता है, और क्या हो सकता है? और भी कोई reason हो सकता है?
What was the character of pain?
The mass? Anything can happen within the mass which can lead to this pain.
Stretching out the.
Which can lead to hemorrhage, yeah.
It can lead to torsion. If the mass get torsion, so that can lead to the pain, ma'am.
Torsion, intratumoral hemorrhage.
Yes, ma'am. But the kind of pain, it's like if it is acute, just like then it suggests of torsion, and if it's like dragging continuous pain and dull aching continuously increasing, then it can be of mass pressure.
Mass can also rupture at times, that loses capacity and the mass can rupture. That can also lead to acute pain. So all these things should come to your mind and you should look for them.
Yes,
so now coming back to the ultrasound, as you said, so he very nicely said that he will look for the site of origin of the mass and then also see what is the character of the mass, whether it is a benign or malignant. So ultrasound is one of the best triage modalities to tell you whether you're dealing with a benign mass or a malignant mass. So they have made a slide. You can project that slide as you have told very nicely. You can project that slide. You've made it. We could see this. So this one, yeah. So this is your aorta simple rules he's applying, and he's saying that if any of these features is present, he will assign his mass as benign or malignant. So anything else you will do? Suppose your mass is little bit solid area, some multicystic mass with some solid area seen in your mass.
Yes,
so what will you now next? What will you?
Ma'am,
ORAD's staging.
Ma'am, ORAD's staging can be done, ma'am, in this ultrasound.
Okay, see, now one thing I would like to clarify here. If your aorta simple rules are fine,
Yes,
so it's not necessary that you will also again apply ORADs also in this. So they are very different type of reporting systems to improve your sensitivity to look for a benign or a malignant mass, right? So there are different reporting systems, including aorta, adrenax, there are various models for objectively reporting the characters of the masses. So you can apply any of these with which you are comfortable with. Okay, so you applied aorta simple rule. So now next step is not the ORADs is not the next step. It is definitely just a reporting way of reporting how you are doing it. So you can use
Ma'am,
any of these.
we can send the tumor markers, ma'am.
Okay, which one?
Either of them. I would like to ask you, what was in your case? What was your case?
Sir,
We send the tumor markers, ma'am. And her
CA125 was 30.4 units per ml, or CA19.9 was 12.7 per ml. CA is 1.38 nanogram per ml. AFP is 3.06 nanogram per ml. HE4 is 51.8 pmol per liter.
Why did you go for HE4?
Ma'am, it's
ma'am, since the mass was serous, ma'am, so it can be the serous, it is expressed in serous and endometrioid type of ovarian cancers. So it is more specific. That's why we tried to.
In all the cases, do you do HE4?
No, ma'am. No. It's like it's.
What are the indication? What is the benefits of it or indications? She's a postmenopausal lady, no?
Yes, ma'am.
No, ma'am. She is having regular menstruation till now.
Okay.
So she's taking peptide, na? Continuously.
Oh, yeah, of course.
Taking some drugs, na? I don't know. We don't know what drug is she on. God knows. That also we do not know. Yeah.
Okay. I was not interested in your tumor markers. I was interested that you have applied M rule and B rule. You know theoretically this. So I just wanted what was in your case. Was it towards M or was it towards B? Because your management will depend upon this.
So, ma'am, in our case,
you have read your ultrasound, no?
Yes, ma'am. So, in our case, there is a irregular mass. In ultrasound, it says the irregular mass, but there is no presence of ascites, and it is multiloculated. Means not multiloculated, but it's at the cystic area with the solid area, and solid area is not mentioned in that ultrasound. Since that ultrasound is done outside of our hospital, and it is not mentioned with the no blood loss or in color Doppler, no blood flow in a color Doppler. So it is, I can say it is classified as inconclusive.
Yeah,
No.
it is
How
inconclusive.
do you
Now,
in Anusha, and how do you in iota in M and B rules, how do you term it as B and how do you term it as M, and when do you term it as inconclusive? कितने factors positive होने चाहिए इन 5 में से, and then you say कि हाँ करके.
Sir, should be one or more than one in the M rule without the presence of B rule.
So why did you say inconclusive? Now you told that it has an irregular solid
Yes, sir.
appearance. Then why not M? And why inconclusive?
But sir, it doesn't have blood flow in the color Doppler, and it's
that is not a criteria, no? So see, so whenever you apply iota ka M rules and B rules, even any one factor out of it comes positive, you term it as that. You know, it is not कि आपको दो color Doppler भी चाहिए and this भी चाहिए वो भी चाहिए. You know, so it is either one of anything. If nothing is fitting anywhere, then it is inconclusive. You know.
Okay, sir.
Okay. And like you were saying about ORADs, ORADs does not come from the same system.
Yes,
yeah, and ORADs does not come from the same system. It doesn't come from IOTA. You know, IOTA is a different organization which deals with everything. What are the other models of IOTA? other than the simple, the B and the M ones?
There are 3 systems from IOTA.
Yeah, there are 4 systems from IOTA, but how many, full form of IOTA? Chalo, we'll, I think, leave it with that.
But then one thing,
I
Dr.
think-
Modi, one thing, there's no blood loss.
Yeah.
Inconclusive, there's one more thing to inconclusive. If none of them is applying,
Yeah.
then also both are applying.
Yeah.
Even
Both are applying.
inconclusive.
Both are applying, then
Yeah.
also it is
And then
unconclusive.
also it is
So I
inconclusive.
think,
That she said
yeah.
the B5 is applying. So that is why she's saying that it is inconclusive, I think.
Even I'm agreeing with that. It may be inconclusive. We have to go further to make a diagnosis because there is no
Yeah.
blood flow
Because,
and rest of the things are coming in malignant.
Yeah, but the original, whenever the IOTA simple rules came in, it was very clear on that. These are all the modifications which came after LR1 and LR2 models that, when it came, so that's why the system went off of B and M because of all these, contrasting things with it. Yeah, I think we can.
What we like, another thing is in the tumor markers, Anusha. See, doing CA125 in a 50 years old female, I have a doubt in this. Why did you get for AFP? I'm sorry, AFP I meant, not CA125. AFP, why did you advise for AFP for this patient? That is one question.
Ma'am, alpha-fetoprotein also gives you the carcinoma of
But this age group.
Yeah, just remember one thing. If a young patient is coming less than 40 years old, then you suspect that they could be having a germ cell tumor. So you advise, as a rule, that you advise them the markers of alpha-fetoprotein, beta-SAG, or even LDH also, as a principle. But beyond that, if you're suspecting a patient to be ovarian neoplasm, then it is not mandatory unless until you are suspecting something. So it is not mandatory. Going in isolated AFP, I don't think we recommend that. If it is, I don't think any of the guidelines also recommend this to do an AFP at this stage. So AFP and HE4 is not usually done for this kind of a picture as your patient is. Dr. Archana and Dr. Modi, if you agree with that, so that we can convey this message to all of them.
Yeah, of course, we
Yeah,
cannot
ma'am.
do
Yeah,
plain
we
cell.
agree. Yeah.
Of course, a rare possibility when you have liver lesions or something as a thing, then we sometimes do AFP just to rule out HCC and all those criterias. But at this age group with only ovarian mass, I don't think so. Probably because we get all these patients with all the investigations done from outside when they come, so they have jotted down everything here.
Then
So
you
I
cannot
think,
note down everything. You have to first
yeah.
filter your case.
That of course, that's
Even in
the
your exams also, when you are presenting your case, patients might tell you thousands of things which they consider as relevant, but you need to filter when you build up your case and present in your exam. That would be helpful. Otherwise, you will unnecessarily run around here and there, and actual discussion will be missed in your exam. So be a little bit more selective and discreet when you are presenting your case in your exam also. So that's a good opportunity for us to convey you this message. So next, please. What all other investigations will you do? So in your patient, tumor markers were literally non-inconclusive kinds. So you did not get any information based on tumor markers. So what will you do next? So what do you think she's having, and how will you proceed further?
So next, ma'am, we have she has done MRI pelvis.
Why MRI? Is there some particular indications where MRI is more helpful? You have told that you have felt the uterus and uterus is of normal size. You have already told this. So we do consider that it is an extra uterine mass, and most probably in adnexa. We are taking it till now as a genital tumor sort of thing. Okay. So you have specifically went to MRI. So you must be knowing why you have ordered MRI instead of any other imaging modality.
Ma'am, she had already, before coming to us, she already had that MRI pelvis done. And
that is not the answer.
No, ma'am.
Even if she has done, you should be, as a student, you should be knowing.
Ma'am, it can help as a complementary tool in case of this if the indeterminate ultrasound, if it was inconclusive, so it will be beneficial. That can be the reason for doing the MRI, as well as it helps in it helps in knowing it.
What is the sensitivity and specificity of MRI, and why MRI in this particular case is useful? I'm very well agreeing with you that you went for MRI instead of any other modality like CT scan or PET CT. In this case, this is particularly useful. Whenever there is a doubt of benign or malignant, you should go for MRI instead of CT. And what is the sensitivity and specificity of MRI in differentiating a benign from malignant mass?
So fine. In regarding the imaging, 2-3 things. Let us summarize that part by they are ultrasound, there's MRI, there's CT, there's PET CT. As Dr. Archana has very clearly, and it's very important for you to explain this to your examiner, that why advanced imaging actually. That becomes very important. So the specificity of ultrasound is very good in discrimination of benign and malignant ethnic cell masses. So इसमें the systems, the ORAD, the IOTA rules, and also the subjective interpretation of an experienced radiologist. So these things work well, and it has been found when the studies were done that subjective interpretation by an experienced radiologist who had the best specificity actually. Experienced clinician, they look into this completely. So that's what led to actually a next model where they have included all these factors too, a little bit. So these things. And MRI is done for those masses where ultrasound is inconclusive to assess the characters. Right?
Yes, ma'am.
So you can say that as ma'am is asking you.
So her MRI pelvis showed ill-marginated lobulated solid cystic mass less than about 10.1 into 6.7 into 5 centimeter, seen in epicenter in the midline lower abdominal wall, involving both rectus abdominal muscles, cranially extending up to the level of umbilicus. Our uterus relatively bulky. Innometer measures up to 5.5 mm in thickness and appears normal. Diffuse asymmetric thickening of junctional zone seen with multiple subendometrial cystic foci suggestive of adenomyosis. Or bilateral adnexa, including the fallopian tube and ovaries, are normal.
Fine. So it's a solid cystic adnexal mass, right?
Yes,
and anything else you would like to do in imaging now with the solid cystic mass? Your tumor markers are inconclusive. So what do you think, why, what it could be, and what all will you do further?
Ma'am, since we can see this uterus separately and the mass separately, we can think of this is not about the uterine or gynecological masses, but extra. So,
but how
I think there is an important finding that it is invading the rectus abdominal muscle also. Yeah, looking at this, I think everybody's asking you what would be the next investigation of choice.
So next investigation we did as a PET scan.
First of all, no, listen. You are advising them a battery of imaging one. That's what Dr. Archana was also wanting to tell you, that no, please, ऐसे नहीं जा सकते one after the other. Ultrasound, MRI, PET CT. पहले आपने MRI देखा. What is your interpretation with this MRI? What do you think clinically? What your patient? You said your ovaries. I can't see anywhere that ovaries are not seen.
Yeah, exactly. Ovaries are not seen is not written here.
Ovaries तो कहीं पता नहीं
This report seems to be inadequate.
Yeah, exactly. Exactly. So we don't know. अभी भी इसमें ये तो ovarian mass is still not ruled out with this. An ovarian mass can also be infiltrating into the rectus sheath. Why can't?
Better you should have shown the film.
है ना? So that's one thing. Remember that. So number one, you should have a comment on ovaries if they were appropriately seen. So that is first thing that you should comment. Secondarily, you want to say the epicenter of the mass is in the lower abdominal wall. So which differential comes to your mind? What she could be? Tell us that. Clinical diagnosis क्या बनेगा? See, ऐसे तो imaging हम करते रहेंगे, है ना? We are clinicians, so we have to have a clinical diagnosis with each imaging or with each complaint or with each report. Then only we can correlate. Then we can help our patients, right?
Yes,
so think about it. Just think which problem can be like that, where there's an abdominal wall tumor localized, maybe infiltrating into the rectus abdominal muscle. What comes to your mind? बोलो, गलत भी होगा चलेगा, कोई फर्क नहीं पड़ता है. यहाँ पे सारे सीनियर्स माय टीचर्स ही हैं, तो कोई फर्क नहीं पड़ता.
Sarcomas,
just a differential diagnosis.
Okay, they can be uterine sarcoma or
solid cystic mass.
Okay, some sarcomatous mass is infiltrating. Okay, chalo, theek hai. Anything else? Rectus sheath का कोई ट्यूमर होता है जो कि प्रेजेंट कर सकते हैं. तुमने कहा ना बड़ा लोकलाइज है abdominal wall में घुसा, abdominal wall sarcoma. I will take it. It's fine. Desmoid tumor या कुछ ऐसा कोई ट्यूमर हो सकता है क्या? Localized बता रही हो?
Yes,
in
ma'am.
that condition, your examination findings should have been the lower limit of the mass could have been reachable. It should have been a diffuse mass, which you could not palpate clinically so clearly. In your findings, you were so clear about this mass, isn't it? You were seeing it in the pelvis.
They have done a PV and PR examination.
Unlikely,
yeah, they have done a PV and PR examination.
Abdominal wall tumor will not be seen through, will not be able to feel through pelvis itna zyada clearly. So some discrepancy in your findings here. You get my point?
Yes,
Are you understanding? Are you understanding where we can improve our things further? Huh?
Yes.
I would like to go for a radio review in this case.
Yes. Nice.
Radiological review could have been a helpful thing, no? Isn't it?
Yes, ma'am.
Because this report is not seemingly adequate to me. A lot of things are missing here.
Yeah. Samajh aa raha hai, Anusha and Rishabh?
Yes, ma'am.
Yes, ma'am.
And how do we build the case? How do we go ahead with each and everything?
Yes.
Right? So
Yes, ma'am.
now the question is, why do you want to do PET CT? First, you have to justify. See, PET CT has two things. One, it is very expensive. Number two, it is giving your patient 25 grays radiation exposure, which is 4 to 5 times higher than a normal CT also. So just imagine, है ना? So हम ज़्यादा उसको क्यों रिस्क पर डालेंगे, है ना? Cost भी हमें समझना है. So before we have a proper indication in our mind, okay, with this imaging, I'm going to have this additional information, this additional benefit to my patient. Then only I should order that test. You understand that?
Yes, ma'am.
Now you tell me what additional information do you want from PET CT? Okay? Batao.
Ma'am, since the MRI said it's a cystic mass, solid cystic mass, but hasn't said the what type of solid types means this
with FDG.
With FDG a bit.
So why should you want that if it is FDG a bit or not?
Whether these are
metastatic
at all. There's a mass. Solid cystic.
Whether it is metastatic mass or originate from the lower abdominal wall only, or it is given metastatic by the other tumors that are missed.
So why not CCT? See, PET CT has its own specific indications, especially when you are advising it in the setting for an adnexal mass or a isolated mass where you're not sure about the site of origin. I agree, you can do it. I'm not denying on this. But first you try and understand. You have a mass where why it cannot be a pedunculated myoma or something, which is kind of infiltrating over there. Myoma, maybe sarcomatous, as you said correctly.
Yes, ma'am.
Can be which you are missing the connection with the uterus or something you are missing that way with your findings only. I'm telling you this. Okay. So be that which you are not able to make out. So do you think a biopsy and assessing what is site of origin will be more useful, or a PET CT will be more useful at this time?
FNAC should be done, ma'am, to take out the biopsy from
Why
that.
not biopsy? FNAC तो वैसे इतना time waste करा देगी.
मैम
बायोप्सी में आपको IHC करने का भी बेनिफिट मिलेगा ना, तभी तो appropriate डायग्नोसिस से पहुंच पाओगे अगर इतना dubious सा mass
Is the
है.
sensitivity of FNAC is very high?
Yeah.
In ovarian masses, what is the sensitivity of FNAC? Just 70%.
Yes, ma'am.
FNAC से तो बहुत कम इन्फॉर्मेशन मिलेगी ना और कम भी हो जाएगी और
Yes, ma'am.
IHC भी नहीं कर पाओगे उसमें प्रॉपर्ली. इसमें तो तुमको चाहिए ना IHC.
Yes,
Then
ma'am.
only be able to reach the diagnosis, especially when it looks like little bit an uncommon condition.
Yes,
ma'am.
So biopsy, and then you can take up the call for another thing. Now, basically, next imaging you want, because you have till now only imaged the mass.
Yes,
The
ma'am.
best- You have not imaged upper abdomen. You've not done anything to rule out distant metastasis for this mass. So your first aim now is to know which mass am I dealing with, what kind of tumor, which is a site of origin for my mass, right? And then I have to see what is the distant metastasis. Then only I will be able to plan what should be my appropriate therapy for this patient, surgery, chemo, radiation, what, right?
Yes,
You
ma'am.
understand?
Yes,
Based on that understanding in your mind, now please proceed further. So what will be your battery of investigations now for her?
Now I have done the PET scan, FNHC from the abdominal wall mass, which suggests of malignant epithelial neoplasm, likely suspicious of clear cell adenocarcinoma of Mullerian type.
All right. So one more यहीं पर एक क्वेश्चन है. So अगर हमने इसका IHC करेंगे तो क्या चीज है जो कंफर्म करेगी कि ये क्लिनिक ऐसे सस्पिशियस लिखा है ना, क्योंकि उन्हें क्लियर सेल दिख गया होगा उसके अंदर.
Yes, ma'am.
So अगर सपोज ये FNAC ना होता या बायोप्सी होता, so which IHC markers are likely to be positive in cases of clear cell carcinomas?
Ma'am, PAC-SET will be positive in case of as well as ma'am, NAPSA will be positive, ma'am.
Absin A, right? So PAC-SET will be positive in all Mullerian markers. So it is Mullerian type, so PAC-SET positive. And
As
clear
well as
cell Absin A, agreed.
P53 can be sometimes positive in this, plus minus.
आगे HNF1 बीटा भी होता है, वो भी हो सकता है पॉजिटिव इसके अंदर. चलो नेक्स्ट करें, आगे बताओ आगे क्या करेंगे. नेक्स्ट प्लीज.
Then PET was done, which suggested large lobulated heterogeneously enhancing solid cystic mass lesion with FDG with SUV was max 10.1 with solid component measuring approximately 8.5 into 10.1 into 5.6 centimeter in size, more toward the right paramedian region, infiltrating anterior abdominal wall muscle. Uterus demonstrated heterogeneous attenuation with hypodensity noted within.
मैम
अभी भी तुमने अपनी पेट सिटी की रिपोर्ट फिर से तुम बस अपना नैरो विजन में लिखे हो. You have not mentioned why you did the PET CT. You did not do PET CT to know this. See, you were aware it is solid cystic mass infiltrating into the abdominal wall, so you knew it is a malignant mass, right? Your FNAC also told you it is a malignant mass. So now your PET CT is not done for this. Your PET CT is done for something else. Tell me, what are those findings?
We need to see whether the nodal involvement is there or not,
metastatic
or metastasis is there, whether they distant nodes are involved or they are more FDG evidence is seen or not. For that reason also, ma'am, it is done, ma'am. We need to see overall if it is metastasis, then which all regions are involved. For that reason, PET CT is done. Basically, PET CT is not indicated, but for our reason, this was the same. It is not indicated, only done for the indeterminate. If there is inconclusive or indeterminate type of ovarian carcinoma for that or recurrent, then for that evaluation we only do.
Recurrent, yes, you are very correct. And
Very
also,
nice, very nice. At least you understood this thing. So why simple CT scan could have better?
Yes,
हाँ
ma'am.
यार, लेकिन बटन डिस्टेंट मेटास्टेसिस के लिए क्या है तो बेटा बाकी ऑर्गन्स पे, लिवर में, स्प्लीन
Yes,
में
ma'am.
कोई डिपॉजिट नहीं है, ये सब तो बताना है ना.
Yes,
चेस्ट में
ma'am.
क्या फाइंडिंग्स हैं ये बताना है ना.
Yes, ma'am. So
The case is very good actually. It is giving us a clear message. It's one thing to understand how type 1 tumors would present. Type 1 tumors may present with locally infiltrating lesions. They may infiltrate the abdominal wall without ascites. Patients will not be very symptomatic, and probably your patient is having pain entirely
Yes.
because the mass is infiltrating into the anti-abdominal wall.
Yes.
Right? So these things
Yes.
you have to remember. Right? It's a good case. And how will you proceed further?
So, ma'am, further, we did a diagnostic laparoscopy.
And the removal of mass from the abdominal wall along with Richter's sheath muscle was done, followed by total abdominal hysterectomy with bilateral self-injectomy and then staging laparotomy was done, ma'am.
What's the finding of diagnostic laparoscopy?
Yeah.
Yeah. Intraoperatively, it's about 11 into 10 centimeters solid cystic mass arising from the rectus muscle, extending up to the umbilicus and the pelvic area downwards. Uterus was normal with the bulky right ovary, and the pelvic nipples are normal with with the normal omental.
So basically, the mass was isolated. It was not arising from ovary or uterus or anything.
No, ma'am. It's isolated in the abdominal wall that is extended up to the umbilical area and down towards the pelvic area towards the pelvic area.
So you removed the bulky nodes, or you did not do periodic lymphadenectomy. I mean, your FNAC was suggestive of panmullerian. I mean, that's what is the difference. Had you done IHC, you'd have been more sure about this.
Yes, ma'am.
So you think it is a stage 4B disease, ovarian 4B disease, or what? What do you think at this time? Did you send the mass for a frozen section?
Mass, yes, ma'am. Frozen section was sent. It is, but for the margins, ma'am, because our FNAC already told it's the adenocarcinoma. So for the margins, we have sent the frozen section to see the margin is free of tumor or not. So after frozen section, we have dissected almost 1 or 2 centimeters from the anterior wall of the mass and from posterior and from the lateral wall of the mass surrounding the mass.
The entire mass was sent with margins for frozen section, and it turned out to be clear cell carcinoma, but we also had to look for the margins of the resection because we had to do a complete right wall resection for that thing. And Anusha and Rishabh, like before you directly came for the treatment and everything, but how do you proceed के हमें इसमें directly surgery करना है या हम directly surgery नहीं करेंगे इस case में, so what are the different things which guide you that, and what are the two approaches अगर ऐसा कुछ होता है, because the initial suspicion of whatever the patient got the reports from outside, even the FNAC done outside, was that it is something arising from the pelvis infiltrating into the rectus sheath. So how do you, supposedly it's a advanced CA ovary, like, Dr. Seema was also telling, whether it's stage 4 and everything. How do you determine that you have to operate up front or you have to give anything else?
Sir, we have got an opportunity for doing laparoscopy.
But what is
here.
the goal? Yeah,
Sir,
that is okay. वो तो लिखा हुआ है इसमें. But what is the goal of your
to know whether it is
whenever
operable? We actually wanted to know whether it is operable or not. For that, Fagotti score is there, so it can guide us to know whether there is metastasis or not. We can count the score and whether we can go whether for either chemotherapy is required or directly surgery can be done.
So it is not, I think, operable or not. It is that you can achieve a complete gross resection or not is what the goal is whenever you are doing. So it is not about operability, yes or not. Operate, so you can do even with R2 resection. But the goal is that whether you can give a complete gross resection or a R0 resection or a CC0, whatever terminology you use. So that is the goal.
And since this mass is already infiltrating into the abdominal wall, so there was no other solution for you except to remove it actually.
Yes.
Otherwise, the patient would be in real pain. And as such, the preoperative imaging also did not show any signs of unresectability. It was probably nowhere else except
No, yes, ma'am.
right. So multiple peritoneal biopsies and everything was done appropriately, right? And why you did not remove the para-aortic lymph nodes? Okay, this you need to answer. You remove pelvic lymph nodes, you did not remove para-aortic lymph nodes. Did you open the space?
No, ma'am.
So remember, if it is an adnexal mass, this is a very dubious kind of a mass. We do not know the site of origin from where was it arising, unless until the IHC and everything has come out, because ovaries are saying lying separately, they were not arising from ovary. So very different. Let us see the histopathology final, but otherwise para-aortic spaces should be, probably it was not done because it was already stage 4B. Disease, and that is why probably it was not done. So you have to know that. But then you have to open the space because it is a clear cell carcinoma. So clear cell carcinoma has an increased predilection towards nodal spread, and they do not respond well to chemotherapy. So it's very important to remove the bulky lymph nodes, which you otherwise don't find. So to open the space and look for the nodes, and if they're enlarged or bulky, you have to remove them, especially in the clear cell variant. They usually relapse in nodes. Okay?
Yes,
so,
okay.
Fine. What is our final histopathology? Really interesting to know.
Our abdominal mass, in the final pathology report, our abdominal mass was clear cell carcinoma of Mullerian origin, possibly arising in the background of endometriosis. The IHC was done with the tumor cell positive for PAX8 and Napsin A. ANCR is very focally positive, ER is patchy positive, and PR is negative. WTI is now negative. WT1 is negative. 553 type wild type expression pattern.
So as you were saying at that time, P53 could be positive. P53 is usually positive in serous ones, high grade serous actually indicates that. So ये जो type 1 cancers होते हैं, they're not high grade serous types. Although the behavior is poor, clear cells, the behavior is very aggressive, but they are still considered as a type 1 and their mutations are very different. They're not P53 mutant. There are different kind of mutations for type 1 tumors. So that's what this report is telling you to reinforce that when you were telling us this. Okay. Okay. So, but the bilateral ovaries did not show any tumor, Dr. Rahul. Very strange and very interesting to know.
It did not. And yeah, I think probably these guys never realized we had actually dissected the entire retroperitoneum and everything, but we couldn't find.
That's what I'm saying. Very interesting. कहाँ से आया abdominal wall में clear cell tumor ऐसे? वो uterus भी बिल्कुल normal था, उस पे भी कुछ नहीं था. Interesting. Anything, Dr.
It's very unlikely that endometriosis will go into anterior abdominal wall. And
Is
there
my
will
voice
not
audible?
be any...
Yeah.
So that pathology showed na, that maybe in the background it has developed.
It's totally going into the anterior abdominal wall instead of this thing. POP is only having foci of endometriosis. Really very, maybe scar endometriosis it may be.
ना बड़ा. And she was on progesterone इतने सालों तक, वो suppress ही नहीं हुआ क्या endometriosis?
That's really amazing.
Very interesting.
Well, this case is being presented as a case of adnexal mass because
but for you,
topic was
for both of you, the examination findings were not appropriate. Your examination findings when you presented this case, they were not appropriate. The findings were probably missed. So you have to be more thorough when you're examining your patients. You did not mention your findings correctly. The case was very interesting, challenging. I take that way. It is very interesting to learn so many things. The type 1 tumors, how do they present, how erratic they could be. So that's fine. But when you examine the patient, your findings were not matching actually. So that you have to be more, read from your book and you have to write in a different manner. Okay. Remember that was very useful. Very good message actually. Dr. Rahul,
what are the chances of development of malignancy in a case of endometriosis and which malignancies do develop?
Clear cell endometriosis.
And the second one?
Endometrioid type of.
Yeah.
What are the chances?
Endometrioid.
Endometrioid cancer. Chances nahi.
Less than 2% chances that endometriosis will have. It should be taken in consent that if you are, of course, you were not knowing about the endometriosis in this case.
What are the
If you
various
are operating a
malignancies?
long-standing operative.
What are the various malignancies known to arise in the background of endometriosis? 1, 2, 3. One, you already had one, Bolo.
Yes, endometrioid carcinoma, ma'am.
Second.
Clear cell, this one.
Very good. Third. Seromucinous also. They're also known to arise in the background of endometriosis. Yes, so that is also.
Actually, so these, I think, a new group of endometriosis associated cancers which are growing without the primary being really detected. And probably this is the third in our thing which has come. We also did one episiotomy having a clear cell carcinoma with a ischiorectal fossa mass, and that came out to be positive with laparoscopy, ovary and uterus being perfectly normal. And so that is also one where the patient is receiving radiation now. So we had to excise the entire ischiorectal fossa over, and it was just 2 years after her delivery, which she presented with a huge mass.
Interesting, right. So what is the outcome prognosis of your patient? What will you do now post-operatively, and what is the prognosis? How will you explain this to patient? How would you prognosticate her? Last question from my side.
Go for chemo. Go for chemo.
So what will you do now? Chemo.
Yes, ma'am.
Paclitaxel carbo.
The rate of chemo responsiveness of this tumor. What chemo will you give? Tell us that.
Paclitaxel carboplatin, ma'am.
For 6 cycle in a 3 weeks interval, ma'am, we are going to give. And dose is
It's okay. You need not. I mean, if you don't remember, it's fine to tell the dose. 175 milligram per meter square paclitaxel, and UC 5 to 6 carboplatin. Up to 3 weeks you gave. That's right. That's okay. And how do you prognosticate this patient?
Prognosis factor of clear cell carcinoma, it's not good, ma'am. We can counsel, assure them.
These are highly aggressive. These tumors are aggressive tumors.
Highly aggressive.
5-year survival. 4B हो गया ना ये stage तो.
Yes, ma'am.
I don't know whether actually, yeah. So I think really not sure that whether we can apply the ovarian cancer staging to these masses, whenever, because now a certain new group of endometriosis associated cancers is a new group which is being told, and, where the ovaries are actually normal. But can we apply the same staging system as we do for the ovary? I think it's a bit controversial. So that's why.
This patient is controversial, but otherwise for clear cell carcinoma or endometrioid carcinoma or seromucinous, we use the same classification, same staging system.
Yeah, but in case the ovary is involved, in that case, if the ovary is involved,
very erratic, very different case.
Yeah, because these ovaries were grossly normal.
Very grossly, microscopically also, I think your ovaries are normal.
Yeah. So
very
that's why.
Case for that matter. Yeah. So from Dr. Archana, from my side, it's like no more questions asked.
Yeah, I think the time is up. It's really a very challenging case. Of course, for PG class, I think it is little bit complicated. But my only message to the PG students is that please be more clinical, because in exam you will not be provided with the investigation. Don't jump to the investigation. Kindly try to make a differential diagnosis and diagnosis of the patient first, and properly summarize the case. That is much more important than going to the landing up to the correct diagnosis, because these are very different things. You have to appear in exam, and you have to, ma'am has already, Dr. Sima has said that you have limited time. So in limited time, you have to do the discussion also, summarize the case. Kindly do not digress from your initial discussion.
So very well said, ma'am. Thank you all the experts of gynae oncology,
Thank you,
Dr.
ma'am.
Rahul sir, Dr. Seema ma'am, and Dr.
Thank you,
Archana
sir.
ma'am. It was a very enlightening session and a very interesting case by Dr. Rishabh and Dr. Now we would like to move upon the next session. That is a case on pregnancy with previous LSCs. So for that, I would like to call upon the moderators for the session. Dr. Bharti Rajshekharan ma'am. Ma'am is President, Karnataka State Obstetrics and Gynaecology Society, and she works in Sadri Multi-Specialty Hospital. So welcome, ma'am.
Thank you.
The next expert we have is Dr. Nalini Arora. Ma'am is Director and Head and Professor of ESIC Medical College in Kolkata. Welcome, ma'am. And now we have the third moderator over here, Dr. Deepthi Goswami, ma'am. Ma'am is the Director, Professor and Unit Head in charge of the Gynae Endocrinology Clinic, and she's a faculty in Reproductive Medicine and IVF specialty in Maulana Azad Medical College. So very welcome to all the moderators. And for the case presentation, we have Dr. Sriva Balakrishnan. She is postgraduate resident in ABVIMS and Dr. RML Hospital. And the second presenter is Dr. Pragya Pandey. So now you can go ahead with the case. So do we have Dr. Sriva and Dr. Pragya over here?
Yes. Yes, ma'am. Ma'am, are we audible?
Yeah, you're audible. You can go ahead with the presentation.
Okay. A very good evening, respected faculty members.
Good evening.
My patient is Mrs. Ma'am, are we audible?
Please go ahead, Dr. Pragya.
Yes, okay. So my case is Mrs. X, 30 years old female. She's Gravida 3, Para 1, Live 1, Aborta 1. She's married for 10 years. She's graduate by education. She's a housemaker by occupation. She's a resident of Paharganj, which is 3 kilometers from our hospital. And she belongs to upper middle class socioeconomic status by modified Kuppuswamy scale. Her last menstrual period was 17th October 2023, which makes her EDD of 23rd July 2024. And she was 36 weeks, 3 days POG as on 28 June 2024. She presented to our casualty with chief complaints of pain in the abdomen for 2 days and white discharge per vaginum for 1 day. She's a book case at our hospital. It's a spontaneous conception, and she came to our casualty with pain in lower abdomen. The pain was insidious in onset, intermittent cramping in nature with increasing intensity, initially lasting for 20 seconds to now for 40 seconds, which was radiating to back and thigh, and it was not relieved by resting, and there was no aggravating factors. Patient also complained of thin white discharge, which she has noticed only for 1 day as her underpants were stained. It was non-foul smelling and was not associated with itching. There was no history of fever, no history of burning micturition, increased frequency, painful micturition, or fever with chills and rigor. There was no history of leaking per vaginum or bleeding per vaginum. There was no history of diarrhea, nausea, or vomiting. Trimester-wise history, she did her UPT at home after 1 week of overdue, and which came out to be positive. There was history of nausea without vomiting in morning, breast tenderness, excessive sleepiness. Her first ANC visit at our hospital was at 2 months of amenorrhea. There was no history of preconceptional folic acid intake. She received folic acid supplements, and routine ANC investigations were done, which were told to be normal. OGTT with 75 gram glucose was done at first visit and was found to be normal, as said by the patient. First trimester screening ultrasound was done at 3 months amenorrhea, and it was normal. Dual marker was done and was found to be normal. There was no history of excessive nausea, vomiting, no history of fever with or without rash, spotting, or bleeding PV. There was no history of any other drug intake or radiation exposure, no history of burning micturition, pain abdomen, no history of discharge per vaginum, no history of excessive bleeding per vaginum. Second trimester history, she had quickening at 5 months of amenorrhea. There was history of regular intake of iron and calcium. Level 2 ultrasound was done at 5th month to rule out anomalies and was found to be normal. She received 2 doses of TD injection at 20 and 24 weeks period of gestation. OGTT was done at 28 weeks and was found to be normal. There was no history of polydipsia, polyuria, polyphagia, no history of headache, epigastric pain, blurring of vision, decreased urine output, shortness of breath, or raised BP records at antenatal visits. There was no history of discharge PV, spotting PV, bleeding PV, pain abdomen, or burning micturition. Third trimester history, fetal movements were perceived well and were adequate. She continued to take iron and calcium. There was no history of bleeding PV, spotting PV, or leaking. No history of burning or painful micturition or any other signs of UTI. There was no complaint of itching over palm, sole, and abdomen. Now her obstetric history, she is Gravida 3, Para 1 with 1 living issue and 1 abortion, and she is married for 6 years. Her first pregnancy was a booked case at Lady Hardinge Medical College. Her antenatal period was uneventful. She was induced at 41 weeks period of gestation for postdatism, and she had full-term LACS 4 years ago in view of MSL with fetal distress. Baby was a male baby of 2.8 kg baby weight. Postpartum period was uneventful. There was no history of any blood transfusion, ICU admission. Foley's was out at post-op day 2. There was no history of any foul-smelling discharge or lotia with fever. No history of any surgical site infection. Patient discharged on post-op day 4 and stitch was removed on post-op day 10. She did exclusive breastfeeding for 6 months and there was no history of any NICU admission. Developmental milestones were normal till date and baby is immunized till date. She had 1 spontaneous abortion in 2019 at 1.5 months period of gestation, and it was followed by dilatation and curettage. And this is the present pregnancy. Her menstrual history, she achieved her menarche at 13 years of age. Her previous cycles are regular with no history of dysmenorrhea and passage of clots. There is no history of any contraception. Past history is not significant. There is no history of any chronic illness or surgical illness. There is no any chronic illness in the family. She is vegetarian by diet. Her total calorie intake is 1900 kilocalorie by 24-hour recall method, and total calorie requirement is 2100 kilocalorie. She is deficient by 9% in calorie intake, and protein intake is 123 gram, and required protein is 127 gram, which is adequate for the patient. Pre-pregnancy weight of the patient was 65 kg, and gestational weight gain of 10 kg has been done during this pregnancy.
On examination, the patient is conscious, cooperative, and well-oriented. The general condition is fair and hydration seems adequate, and patient is of regular build and afebrile on touch. On examinations, her pulse rate was 86 beats per minute. BP was 112 by 76 mm of Hg. Respiratory rate was 18 breaths per minute, and SpO2 was 99% on room air. Her pre-pregnancy body weight was 65 kgs and her height is 152.5 centimeters, which makes her BMI of 28.2 kg per meter square. There was no pallor, icterus cyanosis, clubbing, pedal edema, or lymphadenopathy. Systemic examination was normal. On abdominal examination, on inspection, the shape of the abdomen is oval. Umbilicus is centrally placed and everted. All quadrants were moving symmetrically with respiration. A previous fenestrial scar was seen, which was 8 cm below the umbilicus. It was a healed scar of about 15 centimeters. The stria gravidarum was present on the lower half of the abdomen bilaterally, and there was no venous engorgement, pigmentation, or any visible lump. All hernial sites were free. On palpation, the uterus was sperm size. There were 2 contractions, each lasting for 45 seconds in 10 minutes. Her symphysofungal height was 36 centimeters and abdominal girth was 42 inches. There was no evidence of any scar tenderness on relaxation. The estimated fetal weight was 2.6 kgs and the lichens seemed adequate. On the grips, the first grip, a broad and firm part was felt, which was suggestive of breech. On the second grip, a smooth curved part was felt on the maternal left, which was suggestive of back, and multiple knobby structures on the maternal right, which was suggestive of lymph. A hard globular veloutable structure was felt, which was suggestive of head. And on the fourth grip, the fetal head was not engaged and was above the pelvic rim. On auscultation, fetal heart rate was felt, which was 140 beats per minute in 4 centimeter lateral and 5 centimeter inferior to the umbilicus. On a local examination, the genitalia was normal. There was no evidence of any bleeding, leaking, or any foul-smelling discharge. On per speculum examination, the os was open, but there was no evidence of any leaking or discharge or erosion, and both cervix and vagina looked healthy. On per vaginal examination, the os was soft, central. It was 3 centimeters dilated. Cervical length was 2 centimeters. Vertex was -3. Membranes were present, and pelvis seemed adequate for the baby. Ma'am, the summary of our case is Mrs. X, 30-year-old, gravida 3, para 1, live on the bottle 1, at 36 weeks, 3 days period of gestation, belonging to upper middle socioeconomic status, with complaint of pain in the lower abdomen since 2 days. Insidious is onset, intermittent, with increasing intensity radiating to back and thigh, not relieved by resting, with no aggravating factor. On examination, the uterus was corresponding to 36 weeks. There were 2 contractions which were lasting for 45 seconds over the past 10 minutes, with cephalic presentation with an FHR of 144 beats per minute. On per vaginal examination, the os was 3 centimeters dilated, central, cervical length of 2 centimeters. Membrane was present and station was -3. So our diagnosis is Mrs. X, 30-year-old, gravida 3, para 1, live 1, abortus 1 at 36 weeks, 3 days period of gestation, with previous full-term lower segment cesarean section with a singleton live pregnancy in longitudinal lie, cephalic presentation in labor.
Okay, Dr. Pragya,
Yes,
now
ma'am.
you have made a diagnosis of 36 weeks in early labor. So how do
Yes,
you
ma'am.
plan to manage this patient? What would be the mechanism?
Ma'am, okay. Ma'am, since this patient is already one previous lower segment cesarean section, we have admitted the patient in our labor room, and we have taken out the FLAM score for this patient, which came out to be 4, and which gives us a score or percentage of successful VBAC of 89%. So we have planned the patient for TOLAC after explaining the patient about the risks and benefits of TOLAC over ERCS, and we have taken up the patient for TOLAC.
So what are the risk factors you have explained to the patient? And in what
Ma'am,
way
we have
have you...
Yes, ma'am.
Yeah, and I mean, how have you explained, and what was the consent taken like? What have you explained to her in the consent?
Ma'am, first we have explained her what are the pro factors which contribute to a successful VBAC for this patient, as her age, which is less than 40 years. She is in spontaneous labor. She has 1 full-term lower segment cesarean section for a non-recurrent cause. And currently her bishop is good. So she has a very high success rate for TOLAC. And we have also explained that she is in a tertiary care center where 24-hour operation OT facilities, blood bank facilities, senior obstetrician and anesthesiologist is present. Also, CTG monitoring is present, so we can give her a trial of TOLAC. We have also explained that there are certain risks associated with TOLAC for the patient, which includes scar rupture, which is 1 in 200 or 0.5%. There is also risk of bleeding, risk of multiple blood transfusion, and there is a high risk of emergency cesarean section.
And so have you taken the consent with the family in confidence, or it's just
Yes, ma'am. Yes, ma'am. We have explained it to the patient as well as to the family, and on combined consensus, we have taken the patient for TOLAC.
Also, ma'am, on admission, we had assessed the patient, and we had ruled out any signs or symptoms of any scar rupture. Because if there is scar rupture, we cannot take up the patient for TOLAC.